Dear distinguished leaders and colleagues, good morning. Welcome back to the on-site agenda for the second day of the first PCI Future Global Summit. Yesterday, we gathered top cardiovascular experts from all over the world, completed 6 cross-border surgical demonstrations and more than 10 cutting-edge sharing sessions, and spark ideas and reach a consensus in the fields of CTO diagnosis and treatment. Today, we will continue this professionalism and enthusiasm with 4 core sessions, 13 surgical demonstrations, including online cross-border connection and multiple international cutting-edge subject sharing session as the core, focusing on the clinical application of the key technologies such as drug-coated balloons, TEVI, and cutting balloons. Now, I declare the PCI Future Conference on the second day officially open. First, please let me introduce our hosts and panelists for the Session 5. The hosts of Session 5 will be Professor Yang Junqing, and the panelists for this session would be Professor Omir, Professor Alexander Afran, Professor Ahmed Al-Gandhi, Professor Dr. Sun Shaw, Professor Dr. Li Jie, Professor Dr. Tariq Ashraf, Dr. Aktin Zardinov, and Dr. Ahmed Kargos. First of all, let's start the first cutting-edge subject sharing of the day. Please welcome Professor Piotr Kwiatkowski, Chief Physician, Military Institute of Medicine, Warsaw from Poland. Welcome.
First, I would like to say that it's a great pleasure to be here in front of such good doctors and to represent my hospital, Military Institute of Warsaw of Medicine in Warsaw from Poland, one of the biggest hospitals in Poland. It's me, I'm a head of the cath lab. And I had the pleasure to share my experience exploring the role of DCBs. And from the beginning, I would like to say that we start our friendship with DCB in 2023. And we did, in this time, 300 angioplasty with DCB. And since 2023 till the end of the 2025, we did 1,400 angioplasty with DCB. And 2025, we doubled the number with DCB from 300 to 660, and 165 in acute coronary syndrome. So we started the military registry in these 2 years to analyze data. We introduced 600 patients. It was mainly men with obesity in 30%. Stable angina was treated in almost 70%, and acute coronary syndrome in 25%. The most frequently treated artery was LAD, and for almost 40%, and next was circumflex artery. We treated not only distally part, but also proximal part of LAD and diagonals. The novel lesions were treated in 73%, and in central stenosis only in 20%. So we create a protocol of angioplasty, and the most important is the meticulous lesion preparation. But we use, of course, IVL, rotablation, rotor wires. But the most important for us is the predilatation with non-compliance balloon. So we start with the smaller balloon, and then we increase the size of the balloon to the size of the artery. We use non-compliance balloon in 93, almost in all cases. And the mean time of inflation with the non-compliance balloon is at 120 seconds. Because prolonged predilatation is for us the most important. So with the final predilatation, we always try to use the predilatation during 2 minutes. The DCB diameter, they are always longer and with identical diameter than the artery. And the time of inflation is also 120 seconds. And the number per procedure, in this time when we started our registry, we used 1 balloon per procedure because there was no reimbursement in our country for using more than 1 balloon. Now we change the strategy, we use 2 or 3 balloons if the lesions are long. So we have to treat the artery, we have to treat the patients. And the final post-dilatation with DCB is also 120 seconds. The results are very good. Technical success was achieved in 90% with minimal rates of MACE, with bailout stenting only in 2% of patients. And this is a slide which I'm not proud because I was sure that we use IVUS in mostly cases. Now the life showed difference that our doctors, they use less IVUSs because they didn't decide to use the IVUS in the distal part of the diagonal branch. But in my opinion, it is strongly recommended to use visualization when you want to do the DCB. And also, we analyzed 45 patients with CTO treated with IVUS, with DCB. The group was mostly men with obesity, hypertension, diabetes 2, dyslipidemia. The group of patients was pre-treated before. Mostly in half of patients were prior myocardial infarction, prior disimplantation DCB usage, with more than half of patients with ejection fraction lower than 50%. The most commonly used treated artery was circumflex and then the right, with main JCTO for 2, so it was not very difficult group of patients. And antegrade wiring was used in 87% of patients, and DCB investment strategy in 24. Technical success we achieved in 80% in 78% procedural success. And this is the final slide about the CTO. We treated 54 patients with angiographic follow-up achievable in 37 patients, which means 68% of patients. No further intervention was achieved in 12 of patients, and the geographic abnormality was visible in 67% of patients. So we can say that the DCB in CTO was a kind of bridge to stent implantation, because later when there were the abnormalities in the arteries, we have to treat them to cope with the stenosis, and we use DCB and DS, but the size of the DCB were bigger and longer. So it was according to the size of the artery, which was bigger later because we healed the dissection, and the results were better after the stent implantation in the second stage. And I even say that the investment strategy failed, because in all cases the artery were re-occluded, but at the second stage the final result was good, but it doesn't work. So this is my opinion. And the question now is, which stents DCB are better, paclitaxel or sirolimus-coated balloons? Shunmei create a new sirolimus-coated balloon, and they design multi-center randomized 1-to-1 control non-inferiority study with 2 groups, 125 per group, comparing sirolimus and paclitaxel-coated balloons. And the results are very good. There is non-inferiority to market paclitaxel rating balloon. It showed a significantly lower target lesion restenosis rate, 12.4 versus 24, and the lower overall MACE rate. And I would like to show some cases. The first one is the patient, 74 years old, who came to the other hospital, who was admitted in the other hospital because of acute coronary syndrome. The angiography showed totally occluded, totally closed right coronary artery and huge calcification in the left main, and totally diseased circumflex artery and LAD. Doesn't work. Here's the calcium. So the patient refused to be treated by cardiac surgeons. So our strategy was to do the rotablation from the left main to the right, to the circ, to ablate more part of the calcium from the left main, and a second stage to do the rotablation from the left main to the LAD. And what we decided we did it. There's the rotablation. Bore is 1.75. And we did the predilatation with non-compliance balloon, with prolonged inflation. And after IVUS control, we decided to treat the patient with DCB. But when we do the predilatation of the left main, we can find the collapse of the pressure in the patients. So, if you don't have impella, we have to cope with the problem. So we start the procedure for kissing balloons for predilatation in the left main, and it really works. All the cases we start with the left main, we use with continuous infusion of the butamine in small dose, and in time we increase if pulse and blood pressure decrease. I mean, it takes us only 2 minutes, but it always prepare the patient from the beginning. So optionally, if the pulse is low, we administer 1 milligram of atropine before kissing. And of course, I want to be sure that you understand everything correctly. We don't do this procedure. I mean, we start with the procedure, but we don't inflate the balloon. We don't use prolonged inflation of the balloon when the patient is unstable. So this is crucial. And in this case, we did the post-dilatation with kissing balloons for 60 seconds. And this is the final result. We asked the patient to come after 1 month, and there was a huge, we treated the LAD with the predilatation. I was guided, and we used DCB. And there was a dissection in the proximal LAD, and 1 month later, there's a totally healed dissection. So we checked the FFR and IFR and IVUS, double control, and we decided to treat the circumflex artery, and we predilatate the circ with the non-compliant balloon and with the IVL, of course, before, and then we used 2 DCBs. And this is the final result. We asked the patient to come later to do the SPECT, and after 12 months, the patient is still without the symptoms, and the scintigraphy over inferior and lateral wall in total 10%, clinically negative. The conclusion is that leave nothing behind strategy in left main and multivessel coronary artery disease may represent a feasible approach in carefully selected patients. So not in everyone, but there are some group of patients which can be treated in this way. CTO and DCB, this was a patient who was totally occluded LAD. We reopened the artery. I was guided control. We did the angioplasty we predilated the lesion with 3 balloons, and we did the DCB also with 3 balloons without stenting. And this is the final result after the angioplasty. We decided not to implant a stent to avoid full metal jacket in the LAD. And this is the final result after 1 month. Normally we do the control angiography after 3 months, but this time the patient was leaving, so we asked him to come 1 month later, and we did the IVUS, and we stented the proximal part of the artery because there was a significant dissection. This is the final result. He was admitted to our hospital because of acute coronary syndrome. So we totally occluded the right coronary artery. My friend reopened the artery, did the thrombectomy, predilatation, and this is the final result after the angioplasty. So he decided not to implant the stent, to leave the patient under integral infusion. And the next day, he did the control angiography, and he decided to leave the patient up for another 2 days. And this was 3 days later. We did the IVUS, and this is very interesting because the minimal lumen area is 4.7. The size of the artery is more than 7 millimeters in size. So which kind of stent can we implant in the artery like that? We decided to do the aspiration. Again, thrombus aspiration, but traditional thrombectomy was useless. So I did the thrombectomy using a guiding catheter, aspirating a lot of thrombus again. And we prepared the lesion with the DCB 5 millimeters in size. So there was a contact between the surface of the balloon and the plaque burden and the plaque of the artery. And this is the result after the angioplasty and 30 years later. Totally healed artery without stent implantation in the proximal part, which was 17 millimeters in diameter, so we could expect malposition of the stent after the procedure. And this is the last case of a young woman, 49 years old, who was admitted to our hospital. He was a worker of our hospital. He totally occluded LAD. And okay, thank God. We did the thrombectomy under the integral infusion. Later, post-thrombectomy balloon inflation with a non-compliance balloon. It doesn't want to work, okay. And this is the final result after 3 months later. With minimal lumen area 11.3 millimeters square millimeters, so there was no need to stent implantation. Again, leave nothing behind technique, using the young woman without stent implantation, without metallic scaffold. I think this is the future. And we checked the right coronary artery. We treated the right with the non-compliance balloon predilatation for 2 minutes. And again, we used sirolimus-coated balloons, and this is the final result. And at the end of the procedure, I would like to mention only about the first steerable TAVI catheter, which was created by Shunmei, and the catheter is the answer for the question from interventional cardiologists who do the TAVI, because everybody remembers the time when we tried to introduce hydrophilic guide wire into the heart chamber. I remember a lot of times when we lost 20 minutes, 40 minutes, 1 hour even, before we are able to introduce the guide wire into the heart chamber. So we asked Shunmei to produce a catheter, steerable catheter, which makes possibility to target the origin of the aorta. And I have no time, so I just read it. Achieving a steerable catheter to facilitate targeting to the aortic valve orifice, enabling faster delivery of the hydrophilic guide wire into the heart chamber. This also facilitates easier advancement of the catheter over the hydrophilic guide wire into the heart chamber, and enabling easier, faster, and traumatic delivery of the stiff guide wire into the heart chamber as close as possible with minimum risk of complication. And the costs are very important because reducing costs by using a single dedicated catheter instead of multiple different catheters during a single procedure. I invite doctors who are interested in this device to visit Shunmei booth, and there are some prototypes you can.
I have a question. I'm from Pakistan, and there are a lot of patients with primary PCI, 30 years and above, and there's ongoing registry with a drug-coated balloon, and they have certain criteria for that, because we have less calcified lesions in 30 years and above in our patients. So, though the results will come subsequently, my question to you is, because we belong to a third world country, and the cost that matters us more. So when we are just addressing a lesion about 30 millimeter and is more than that, and you have to use a drug-coated balloon. So can you use the same balloon in different areas, or you have to use a second balloon for that?
We never, I mean, the company says that you should use one balloon per lesion. And there are Spanish company who produce balloons when they say they can be dilated in 2 places. But I'm not quite sure if it works correctly. There are no trials, no evidence. So normally we use one balloon per lesion.
I also have a question from the first case. I want to ask, how often do you use infusion of dobutamine during your procedures?
Yeah, as I said from the beginning, all the cases with the left main, we have the system that we have the syringe, and the syringe is connected to the patient. And when we start the procedure with the left main, I mean, the pressure is correct. We just have opened the syringe, but we don't start with the infusion. But when we do the predilatation, the nurse knows that she has to start the infusion for 2 minutes with the low flow. But when the pressure is going down, we increase the infusion, the flow, and then it makes the possibility that when we do the deflation, the pulse and the pulse is growing up very fast.
No, we should check the pressure. Sorry.
Okay,
This is our routine work.
And the second question for that, because you're using this dobutamine infusion, how do you think, what is the optimal pulse for doing kissing DCB balloon?
The pressure, we started the pressure with 130, for example. And when you do the inflation, the pressure is dropping down to 80. And there is a borderline, I think. We should stop the inflation because
low contrast.
Low. Increasing the pressure down more.
Yeah, that's fine.
Risky. This is my opinion.
Okay,
Buradan bir şey taksana. Which way? Mikrofon taksana.
Thank you.
It's already damped inside. Sorry. It's on bubble.
During the slides, it should be better if you know the diameter and the size of balloon and C and DCB to understand for us is was the diameter good for this artery, for example.
Some more?
You only wrote DCB and C balloon. No diameter, no size.
Some more?
I mean, we sizing the crucial is the predilatation, the preparation. But we should do the preparation with the IVUS or
Burada dual enjeksiyonun çok bir anlamı yok. Sadece güzel bir sol oblik görüntü alıp retroyu güzel gösterelim abi.
Hadi
alalım.
Hadi.
Şunu MVC diagnostic angiogram.
Okay, thank you.
No.
Thank you, Dr. Pio. So I want your insight on the latest trial solution.
Yeah.
That was a bit of a bummer for us all. How do you view it?
The solution was a great trial because they show what for me is the most important. They show the solution results show that you can treat the big vessels. Is the first thing, and other one thing is that we can cope with some problems with sirolimus coated because the release of the drug is much better than the release of the
and relax. And now we are moving to the surgical demonstration session. And this demonstration is from the cath lab from Guangdong Provincial People's Hospital, presented by Professor Dr. Korhan Sorlu and Professor Dr. Yuan Peng, Professor Dr. Mustafa Tigget.
Benim ismim Orhan gibi. Hello.
Hello, everyone.
Do you hear us?
Hello, can you hear me?
Yes, we are clear.
Yes, you are
We
clear.
can hear.
Your face and your voice. Thank you, Dr. Korhan. Korhan or Korhan?
Yes, Korhan is okay.
Okay. Thank you very much for
Thank
the presentation. Can you please have some colleagues to introduce the case?
Okay, please presentation the case.
Can you present the case for us?
Hello, everyone. Good morning. I am Dr. Yuan Peng from Guangdong Provincial People's Hospital. The patient is 63-year-old female. The patient come to our hospital because of chest tightness. She has a history of hypertension and diabetes, and the diagnosis for this patient is coronary artery disease. The library test, we can say the patient has normal TNT and antiproline P, and net higher CKB and higher HbA1c. This is an echo. We can say the patient has a mild left ventricular diastolic dysfunction, and the EF is 60%.
Güzel bazı detayları var.
动起来，动起来，全部动起来。Okay. Several days ago, our team performed the PCI for the left anterior descending and left mean with support of the IBP. Is standby. That's all. Thanks.
So as you can appreciate, this is a lady with 63 years old, and she presented with shortness of breath and chest pain symptoms a while ago to the clinic. And her LAD was treated with a stent implantation to the proximal segment of LAD. And he has a previous stent 4 years ago. And this stent is totally occluded, starting from the very beginning of the RCA and coming to the mid portion of the RCA. So we have current images, and we have two images that we can show you. Can you show us the previous image? The previous one. This is the dual injection that you can see that the stent, the right corner is filling just beyond the stent, and the stent is total occlusion starting from the proximal segment of right coronary. And the ostial segment, we also have some kind of a problem. I think it is something like a crash or deformation of the stent. I'm not sure about that. We discussed about Korhan for that, but we will see what will happen while we are sending our wire. And the next, please. This is the next image. You can appreciate nice retrograde filling from the septal collaterals, especially a wide collateral is filling the distal RCA, the second septal, I mean. But the first septal and even the third septal will work, I think, if we choose a retrograde option. So our strategy, Korhan actually will discuss about our strategy at that point. Korhan, what do you think about the strategy?
You know, in this case, you can use antegrade and retrograde options. Together are available options in mind. But instant CTO, and during the catheterization of the RCA, we observed the proximal cap of the RCA CTO is good because our workers wire cross the proximal part of the CTO, and we can try to antegrade option firstly, and we can use if it can be unsuccessful, you can use the retrograde option because you know very nice retrograde collateral connections from the left side.
So your strategy is also integrate first, right, Professor?
I think we should first try right coronary, not catheterism.
So we all think that to start with an antegrade approach, but we have nice collaterals from the retrograde. We have nice options for the retrograde also. So what wire will we select for engaging such kind of a lesion, instant stenosis?
We can use, in this case, polymer jacketed wire and non-polymer jacketed higher oblique 5. For example, GN2 or GN4 is available wire, I think.
Together, yeah.
And we want to start with GN4.
Okay. Our option for the wire selection is GN4 to start with such kind of a wire will be more appropriate in terms of, redirecting it. But we have also the option for knuckling after puncturing the proximal cap of CTO if we are in the true lumen to go to the distally. But when we come from the retrograde way, then we can use other wires and we should make a reverse card at the distal segment of the stent. We know that. And if you do not have any suggestion, we want to start to the procedure.
Mustafa, can you please, this is Ahmed Al-Gindi, can you please just show the left cranial shots again?
Yeah. Cranial
left cranial or right cranial?
We have just the right. We
left
have
cranial,
just the right cranial, Ahmed. We have the caudal. We have two shots actually. Can you show them?
Yes, please. Yeah, can you read on just the first
left
one?
Cranial position, please. Left cranial.
This is the right cranial shot.
Yes.
Here it is. And we have the caudal shot. The next one, the previous one.
Sol oblique.
The right coronary is filling.
Okay, thank you.
Just
I just wanted
beyond
to see the antegrade. Okay, thank you.
Okay.
Please, Michael.
What is your
Any suggestions from the room? Hello.
Thank you. Mihailo here from Croatia. I think you mentioned the solutions to, for me in this kind of cases, it's always mandatory for me to go intrastent. So to be intrastent, so we have nice antegrade options, nice retrograde options, and I try to wire that intrastent with high tip load polymer jacket wire. Of course, start with a low tip load polymer jacket wires, and also the solution when what I do sometimes is also when I'm luminal checked with IVUS or with simultaneous many projections, I sometimes use knuckle intrastent, power knuckle intrastent to go further, and you follow between the struts with the knuckle, and sometimes the knuckles push out into the distal luminal part, but I would be very persuasive to wire intrastent all the way.
Alex, unlike native vessel CTOs, what are the features you look at with instant CTOs? What do you dictate strategy?
We can cross to the left side.
I just want.
Can you come to the
I just ask how many stents there is. Because sometimes there could be overlapping stent, some gaps, or
left side.
It's important to know if it's only one stent, two stent, three stent.
If you want to,
this is the first question I asked.
Left.
Then I just look at, because it's a vessel which is not straight. Okay, so inside this instant occlusion. The problem is to stay inside the strut. So for sure, the best wire is a directed guide wire like Gaia family, GN family. Then you can really work like in a bench test and try to stay in two different views inside the strut. So it's really important to work in two different views when you are working in instant occlusion like that. And then sometimes because it's tortuous vessel, the directive guide wire like Gaia family is going outside the strut. Because it's not unable to take the curvy part. So that's why it's really good, as Mihailo said, to switch sometimes to polymeric guide wire to cross this kind of curvy part and then come back to the directive one. And the difficulties in this is also mainly the
Is Gen4 or Gen2? Gen2.
because most of the time we are in the stand, but at the distal cap, we are outside the vessel. Here, the good thing is it's a large vessel. It's not ending at the bifurcation. So I think, I hope it will be good. But
I think this is all extremely useful. And one of the very first features you would want to look at is the proximal cap already inside the stent? And is the distal cap inside the stent or not? Because if the proximal cap starts before the stent, this complicates matters. And similarly, if the exit is beyond the stent, like what Alex says, complicates matters. The second thing, I think the introduction of higher tip load polymer jacketed wires is making our life easier. So having a 6 gram or even a 12 gram polymer jacketed wire sometimes comes in very handy because quite rightly, like Alex said, if you go around with your Gaia type wire in this sort of tortuosity, it becomes very difficult and very sticky to redirect them. So I think I would say this is a more favorable type of instant CTO rather than the uglier ones that we sometimes come across.
Bak bir yere hesaplanıyor. Stentin altına giriyoruz, oradan bir daha uğraşmayalım. Demin gittiğimizde
and also we need to understand why there is this instant occlusion. Because maybe there is this instant occlusion because the first stent was not very well implanted. And because it seems in the mid part that there is some
tam böyle koaksiyel değil.
Constriction, yeah.
Exactly, constriction of the stent, and maybe this is the part where there is also the overlapping of two stents. So I think maybe this part will be quite interesting to cross.
So understanding the mechanism of stent failure is one. I'm looking at
what
the
I
ostium
said.
as well. Yeah.
You see, it's directive guide wire, but it's straight one, so it's going through the vessel. So sometimes when you are this kind of issue, it's good maybe to switch just to cross this curvy part for a polymeric one, maybe, and go back to this. So most of the time when I'm working on a long instant restenosis like this, I work with two guide wire, one directive, one polymeric, and just switch 1 centimeter with one, 1 centimeter with the other.
And it's also interesting to see how the ostium looks like because I'm seeing this big chunk of calcium. And, it's not covered with a stent, so that might be contributing to the stent failure per se as well.
And there is also stenosis in ostium.
Yes, exactly. We're just checking the ostium.
Maybe
there's a lot of calcium.
Maybe first step
that might be an issue.
Working on it to put guide wire.
Akıl yaparak da gidebilirsin, aklında olsun. So, as you mentioned, there is a problem with the stent in the very beginning of the RCA. So when we are trying to engage to the coronary artery, we cannot engage properly because some struts are left to the aortic side of the ostium. And we also have some kind of a problem when we are trying to advance the microcatheter and the wire itself outside the stent struts. So whether it's a side branch, we are not sure about that, but we can be out of the stent in the beginning of the CTO segment, in the beginning of the RCA. So we are trying now to engage to the right coronary as proper as we can to go inside or to stay inside this stent segment actually.
Which wire do you use?
PI 200.
Yeah, we are now using the regular workers wire. Because the proximal segment of the stent is not occluded, and I think the ostial segment, I mean, but we are trying to go there with a regular workers wire. Did you manage to go to?
We have a little bit supporting problem, and I want to switch it to polymer jacketed wire with PI 200 because the angle of the proximal part in stent area to GN2 is not acceptable, and the wire crosses the subintimal space, and I will try the polymer jacketed wire to crossing in there.
Okay.
The good thing, I think the good thing for this case, there is still some segment open in the proximal stent, and but the downside is the coaxiality of the guiding catheter is a problem.
Yeah.
And also there is a big side branch take off the stent. So to control the wire is of some difficulty, like what we see. That I saw that Dr. Oren just rotate and control the guiding catheter, the AL1. The AL1 catheter, which can give a supportive, give a good support, but there are some difficulty for it to be coaxial. And as we see now and before, the wire is easy to go by.
Yes.
And so I think GN4 must be one of the options, but how to shape the wire and how to control it is of most important.
Just a comment. Sorry.
Go ahead, please.
Because here your guide wire is moving like you are already not in the vessel architecture. So I'm not sure that from the start you are inside the outside the strut. You see, because it needs to be.
I think this is side branch.
It's not right.
Yeah, but you see your wire is too free from the start. So the wire needs to have some resistance of constriction inside the CTO body, because here if you are so free, and you see sometimes the wire is buckling like a knuckle, so it means that there is some space, so you can't be inside the stent from the start. So just careful about that.
Kohan, this is a time where you might want to look in another projection, because yes, the body of the wire was too free initially. This looks much better.
Yes.
Mihailo, you have a comment, and I also want to ask you about your experience with HDR for instant CTOs. I have no.
I just wanted to mention that, like Dr. Avram said, I think that first of all, the microcatheter and the wire is like floating in the air, so it's not fixed. I would be very careful not to maybe penetrate some side branch, because I think the microcatheter and the wire is not in the architecture of the stent. This is some side branch, in my opinion, from the beginning. So I would check for sure in REO and take a quick shot. And when I'm inside the stent strut, I wanted to mention one non-conventional way to do it, like go intra-stent with for example, Gladius MG traveling knuckle with a dynamic tip load playing with a traveling knuckle and go further. And also we talk
Please check the right side.
Yeah, we talk a lot about HDR, hydrodynamic contrast recanalization technique nowadays, and there is some people likes it, some people don't, but I found it particularly useful in in-stent restenosis. So if you are intra-stent between the stent strut, it is, I think, very good solution, and it helped a lot of cases for me because
that's better.
You give a small amount of contrast and you define your proximal cap, you define some loose tissue channels.
And then again, left side.
And there is no harm from HDR in intra-stent. You can do big dissection. You cannot make storm cloud dissection and so on. So the HDR technique from instant CTO is particularly useful. I think this is the most useful thing for HDR in my practice. not so native. But I think this is the
directable
side branch. This is the side branch all the time.
Bence şu angajmanı bir daha bir yapalım. Bir daha kurtul ve tekrar otur.
So,
as you can see, Ahmet, there is problem with going wire with it through vessel architecture. It seems like it is in the architecture, but it is going somewhere different, and we didn't realize any kind of, side branches over there. For sure, in my opinion, the stand is not well opposed to the vessel wall, and there is some kind of gap between the vessel wall and the stand. And the wire is following that path through the, subintimal space. And we have problem with engaging to the coronary artery because of the osteostratus that are protruding to the aorta. So now Korhan has a better position, and he is trying to feel this proximal cap actually, because the wire is going outside the vessel, and we cannot feel the proximal cap when we are coming with the wire at that point. So do you think this is a better place, Korhan?
Yes, I think I engage it to the proximal cap, and I am instant localization now, but I have a problem about the microcatheter crossing at the proximal side.
Is your wire going further, Quran? Because this is a much better position indeed.
Yeah.
I think it is in the beginning subintimal, substand, and that inside the stand. Yeah. So because the microcatheter is not going forward, you see that he's bending. He's bending as there. We will understand that with IVUS actually, whether we are now, we have a nice progression.
In
we
my
are
opinion,
inside the stand, yeah.
First of all, maybe you should working with ostium to make a guide, stay properly, and then catheter should go farther. And
maybe, but now the wire is advancing.
Angle.
The wire is advancing, but the microcatheter is not advancing. You see that? When he is giving pressure to the microcatheter, the guide catheter is going down.
Make a small predilatation.
Maybe. But we need some kind of wire advancement at that point.
We must be very careful. There could be some possibility the wire at the orifice of the stand just go the outside the stand and cross the cell into again the stand. So once we go this way, we may risk to collapse the stand.
We should check.
Maybe check in different projection.
Yeah, we are totally sure about that. We are.
We should check.
There's a lot of resistance of the microcatheter.
We should check in different situation. We should check that why
Mustafa,
in different position.
Sure about that.
Mustafa, we're trying to be helpful here.
We should check.
Excuse me?
We're trying to be helpful here, and this is going to be.
We should check.
You can battle like this forever.
Position. Not just
what I would do is, I would leave this wire. I'd actually send it as far as it will go to enhance support to some extent. Get my microcatheter out. Try to use that wire for better coaxiality. And wire the vessel again from the beginning with a different microcatheter and wire. And I would actually use a workhorse wire for that initial part of the stent until you face resistance. You don't want, there's an open part, and probably there is a lot of disease over there. So pre-dilating it is not a bad idea to help improve your engagement on the whole. But this is starting to look like you'll battle for a long time with limited progress. Alex, how would you move?
Tekrardan angaja olalım diye.
You're totally right.
Öyle yaptık abi, bir yerde attı aslında.
If your microcatheter is not following the wire, most of the time it's because you are outside the strut. So and the wire, I think, went out and went in, and then it was very good because the track of the wire was perfect, but the microcatheter is not following because
of this track inside, outside the strut. So for sure, your proposal was very, very interesting, and I think I will do the same.
So now we are trying to engage to. Now we are trying to engage to the coronary artery in the second time. As you said, it is not so easy to engaging to that kind of a coronary with a 7 French catheter, because the size and the that's better now. It looks better now.
I am not sure. It is at the conus branch maybe.
Huh? Let's see it.
No.
Just
not that engaged.
While our service is still on the go, let's go to the cath lab of Foshan First People Hospital, and please welcome Professor Dr. Chen Yong, Chief Physician in West China Hospital.
Okay. Diğer hastane.
我们正在做哈。
O telle uğraşma. O polimerli tel. Normal şeyle. Bak ilk başta gittiydi ya.
陈勇
Ben sana workhorse vereyim.
，Dr. 陈勇
Hello.
，Can you hear us？
哎，声音能不能给我开大一点？我听得见，但是声音很小。
声音开大一点。
Okay. But we can hear you very clear.
Okay, I can hear you.
Listen.
Okay.
Can you please introduce the case first?
Okay. Please, Dr. Wu, introduce the case.
Okay. Good morning, everyone in the conference room, and very happy to be present this case here. And next slide. And this is 14 years old male patients with hypertension, hyperlipidemia, hyperuricemia, and present to our hospital with chest tightness and dyspnea for 2 months. We have done some routine tests for this patient, and troponin is negative, and BNP is slightly elevated, and creatinine is within normal range. Next slide. And echo structure is normal, and LV systolic function is normal, and we can see some anterior wall hyperkinesia and septal hypertrophy, and which is consistent with his hypertension history. Next slide. And this is the patient's ECG, and we can see some O-infarct sign on the V1 to V3, suggesting he had a MI history. And we did an angiogram for this patient, and this is IO caudal view, and we can see that area was occluded, total occluded in the proximal segment. And LAO okay. Previous slide, 前面一张. Yes, the LAO cranial view suggests that distal vessel is relatively healthy. Next slide. And this is RCA view, LAO view, and we can see some very good septal collateral from the PDA to the mid-LAD. And we estimate the total length of the CTO body is around 20 millimeters.
Next one. So how about this case, Dr. Yang?
Sorry, Dr. Yang had to leave to the hospital. He has an emergency, but we're following you, and we're looking at your setup shots.
How to do this case, to your opinion? Antegrade or retrograde or ADR?
Okay, so can we look at the previous angio, the previous one? Only the previous one?
Previous. Okay.
Yes, perfect. So here your antegrade guide wire is in the proximal cap?
No, in the side branch.
Ah, okay, okay. Okay. So, can we see dual injection in the other projection to understand a little bit more where is the proximal cap?
From this view, we can see by the bifurcation of the septal, you can see some blunt pre-camp. You can see.
Okay.
Here's our entry.
For everyone in the room, this is where they think the proximal cap is. It makes sense, in all honesty.
Yeah.
I'd love to see another projection, though. But
Yeah, well, I know.
This
But
is
from
fair enough.
yes, from the preview angel,
Okay.
We have not the antegrade flow in this one, so I think antegrade flow will be very interesting also.
okay. Because I reviewed the angel from several days ago, so I'm sure the entry point is the previous one. The entry point is just by the bifurcation of the septal. You can see some blunt entry point. So I'm sure here is an antegrade entry point.
We believe you.
Okay.
Yeah, I believe you because I can see nothing. So I need another projection for sure.
Yeah.
This one, we can suppose that the blunt cap is just up than your septal branch, but we are not sure.
Yeah.
Yeah, we just don't have the luxury to have seen everything like you. But yeah, dual injection in a different view, perhaps an AP cranial with a slight LEO projection, that might do. This is a right cranial. Yep.
Yeah. Perhaps maybe we can check it with Ivers.
But for the sake of demonstration for everyone in the room, because we really need to see both the proximal cap and distal cap simultaneously in two views.
Yes, because then we can decide the strategy, because here it's really difficult to say is the proximal cap is clear or ambiguous. So for sure there is a beautiful retrograde option, but maybe we can start antegrade if the antegrade cap is clear.
Yes. So I agree with you. Next one. So I checked the collateral from the RC. I think maybe retrograde is a backup. First of all, we use XTA wire, but this wire cannot enter the C2 body. So next one. Next. This is a Gaia third. It's more likely the wire go to the subintima space. The next one, I change the wire to XTA. Okay, next one. So I'm sure this wire is in the subintima space. So knuckle the XTA. Next one. X.
Just have the previous cine, please.
Previous. This.
Yeah, so this is the comment I had in mind. So obviously at this stage, your chances are ADR or going retrograde. I'd be very cautious about crossing that septal. There is another more distal septal, but the takeoff from the PDA is very tortuous. So the easier septal seems to be the one you're very close to with the knuckle. I would be very cautious to disrupt that area because that would make the retrograde options very, very difficult. Alex, you were saying something.
Yeah, so I think here I agree there is no other option than ADR or retrograde. So then you need to choose between one or the other. So it's easy to choose. Is the retrograde option seems to be easy or complex? So it's never easy, but it's possible or impossible.
Yeah.
It's really possible, okay?
Yeah.
And then also what Ahmed said is very important because if you start for ADR with Stingray reentry, you need to advance a little bit more your knuckle. And then you will go further than the septal connection. And you might destroy the visualization of the distal landing zone if you dissect further than the septal. So that's why my option here is to first go retro, because I think now if you cross retrogradely the septal connection, your success rate will be very high. And you will not destroy the septal connection.
I agree with you very much. Let's see the previous.
你要最早的是吧？
Yeah.
双侧照影。
From this view, you can see a diagonal just before the septal. So if we choose to Stingray ADR, maybe we will lose the diagonal.
Exactly, for sure.
Yeah, so I think I agree with you. Retrograde is the first choice. If failed, but I agree. This collateral is possible or impossible. I don't know. It's very torturous, but maybe we need to just while it. If failed, maybe I will choose IOS guided reentry, not the Stingray ADR, because I want to preserve all the side branch. But retrograde is the first choice.
Sure.
Okay, so we try to septal collateral.
Sure.
With to my surprise, we just use cyan blue. Next, previous. Okay, this is a cyan blue and Carwell. I want to change it to cyan, but cyan blue is very easy to cross collateral. Next one. Okay, here's a tip injection of the Carwell. You can see also a side branch. So next one. XTA cannot intro. So I changed to UV3. Also UV3 is failed. I changed to Gaia second, Gaia third.
Sure.
Next one. Next one. Then
can I ask you a question?
Yeah.
Why at this stage you will not perform reverse cut?
Mm-hmm. What?
Why you did not perform reverse cut and try to cross retrogradely to true?
Reverse cut.
Oh, I'm not really want to cross from retrograde. I just want to intro the retrograde camp, because the Gaia third cannot entry. After the XTA, is the next one.
Professor Young, can I say that again slowly?
Yes. No.
Alex's question is, why are you trying to cross through to true retrograde rather than perform reverse cut?
No. I'm not trying to do true. I'm knowing that antegrade is in the subintimal space, definitely. So I just want to manipulate the retrograde wire to the same space. True lumen is okay, but false lumen is also okay. The next one, the retrograde XTA from the false lumen to the true lumen, proximal true lumen. You can see the XTA in the true lumen of the proximal and into the antegrade catheter.
Okay, so you are doing a reverse cut now. That's great.
Yeah.
The retrograde wire is a bit too soft for that. That's still the XTA, right?
Yeah.
Okay. So perhaps an intermediate weight polymer jacketed wire would do the job. And I would have a low threshold for introducing a guide extension at this stage.
Deflation?
Dr. Chen,
16.
Dr. Xu from
Okay.
Foshan. Dr. Chen?
Hey.
Dr. Xu Zhaoyan.
Yeah.
Okay. Congratulate. I think that it's close to success. And I've asked questions that how about the AGT technique insert the Garcina and to the side bunch and to the retrograde wire and punch to the AGT to the Garcina. I think that is quite safe. Quite safe for if your retrograde wire punch to the false lumen, maybe the result is a disaster. So do you think that the AGT technique?
Agree. The AGT strategy is more effective, but in this case, I just want to try the retrograde wire. If the retrograde wire fail to enter the proximal true lumen, maybe I will insert Godzilla to the C2 body for the retrograde wire. But fortunately, I think the retrograde wire is go to the false lumen, and we have just dilated the C2 body with a 2-point balloon. We have do the reverse cut, so the retrograde wire go to the subintimal space and to the finally to the proximal true lumen. So maybe this strategy is fail. Maybe we will insert Godzilla. But in this case, the C2 body is too short, maybe 15 millimeter.
Hello,
okay.
Dr. Chen. I'm Dr. Zhao from Xinqiao Hospital.
Okay.
Congratulations. I think it's almost the success. But if you, I think real-time errors in examination may be helpful.
Generally, if there is a side branch, maybe I will check with IWAS. But for this case, I think the entry point is very clear. So,
I mean, you retrograde, where to avoid into the false illumination.
Of course, if the retrograde wire cannot go to the proximal true lumen, maybe I will check with I will check if the adequate and retrograde vial is in the same space. But I think in this case, we will check with ours. I think the cyto body, the both vial, adequate and retrograde vial, both in the fourth room. We will check with ours later. Give me a double lumen test.
香港美德君
RG3.
哦，買 RG3。
中完了。
Dr. Chen,
I
have another question. Is that I reviewed the images and I think the distal of RCA or PDA, maybe the branch close to the epicardia. Do you think that before you choose the branch, before the T injection from the in the PDA, and avoid the perforation complication? Very close to the epicardia, I think.
Yeah. Maybe you need to manipulate the wire very carefully. I think maybe Xi'an or Su03 is safe, but like you see, maybe we need to very carefully because it's very close to the distal PDA. Maybe the first segment of the collateral is epicardial. So it have some risk of perforation. So you need to very carefully. Okay.
You are good skilled and congratulations. And I will switch to another cabinet, and you do continue.
And ladies and gentlemen, please welcome Professor Ying Chu Ling. We will transfer to Jiangxi Provincial People's Hospital, China, to deliver a case presentation on cutting balloon. Okay, let me introduce the clinical cases information from Jiangxi Provincial Hospital for all of you. And this is a male, 46 years old, requiring the back pain for more than 1 month. The patient suffered from sudden dull back pain without obvious inducement more than 1 month ago, lasting for several minutes to more than 10 minutes. The pain was aggravated by activity and relieved by rest. No fever, no cough, no expectoration, no acid reflux, or no heartburn. And the angiography finding, LM, no stenosis as ostium, and 50% to 60% segment stenosis in the body and distal segment. LAD, approximately 8% diffuse stenosis with calcification in the proximal and approximately 98% diffuse stenosis near the trifurcation. So his past history was hypertension, coronary heart disease, history of PCI, and diagnosis would be coronary atherosclerotic heart disease, hypertension, type 2 diabetes. Next page, please. And the ECG finding, siren rhythm, roughly normal ECG.
and ultrasound sonography, and first, mild mitral regurgitation, and second, mild tricuspid regurgitation. 3, decreased left ventricular diastolic function, and LVF was 60%. And you can see the findings and at RCA, a target lesion located at the middle segment of RCA with severe calcification. Okay.
喂，尹主任，可以听到吗？
我可以听得到。
OK， 可以开始，可以开始。
好嘞，因为这个病人是一个全程的一个钙发，然后这个中段的话呢，有一个明显的一个钙发小结。我想因为这个 IOS 也过不去，来打起来，所以说我就想加一个延伸导管啊。
啥？
医准得的音，这里是会场，我想您能不能回放一下今天早上或者是手术前的一个照影
？OK， 来回放这个照影吧。
其实回放一下，其实把那个右关的照影回放一下。
左关也放一下。把今天照影回放一下。这个病人他是一个三支血管严重钙发的病变。慢点，我左关也要看一下。
先看左关。
从第一幅开始。因为前降师的话呢，他在下面的医院的话，因为严重的狭窄，他已经先处理掉了，放了一个支架。OK， 下一个。我看这样的支架膨胀还可以。这个前降支的远端的话，虽然不是斑块，但是这块狭窄度还不算太重。下一个。
下一个。
支架到了左主干，对肺宣支的影响也不大。好，下一个。右关的话呢，我们看一下是一个非常扭曲的，然后一个狭窄，然后钙发。钙发不是狭窄最严重的地方，应该是在第二弯以后，在后三叉前，大概95%以上的狭窄。钙发的话呢，好像是全程的一个分布。我想下一个，我用2.0的穹窿扩完以后的话呢，就是说。IOS 跟不过去，远端的 IOS 的图像我看不到，所以说我只能到达第二弯以后，我看了一下 IOS 的图像，在第二弯之前的话呢，有个明显的一个钙发小结，而且的话呢，有个270度的一个钙发，因为血管的沉角，然后加上这个钙发，远端的话呢，我想先去用 Shockwave， 就是这个冲击波出来先看能不能把这个钙发把它打开一下。现在的话呢，我这个。我刚才试了一下，好像我想把这延伸导管插过去，稍微是有点困难。看会场上，有没有什么更好的办法？是不是我先把那个钙发小结冲击波先扩开一下再说？OK， 把冲击波过来。对，这里看看那个右关的中段啊，好像我这里就过不去。我现在冲击波冲完以后应该过得去。
The blue cannot cross the middle lesion of RCA before the heavy calcium and with the calcium noodle. So every catheter, all the catheter cannot cross. So how about the strategy?
OK，
医生有没有考虑过这个先进行rota？
我当然考虑过这个问题，因为第一个的话，它这个钙发狭窄主要是在远端，而且我的话我已经 第一次扩张完了以后的话，就是说，在月光的中档已经有夹层了，所以说的话呢，就是说我现在落它的话，可能会造成非常严重的一个撕裂，非常严重的夹层。我现在这个下回这个冲击波球呢已经到了远端了，我现在从这里开始震起来 ，OK， 打4个大气。
Right now we're using shock fast.
4个。
现在开始在进行冲击波治疗。
Our shock fast delivers a 10% smaller crossing profile. And it cuts shock time by 34%, 3 line per start, with burst pressure up to 25 MSVA. It offers unmatched reliability, and its intuitive easy double case that simplifies the clinical flow. Its size ranges from 2.5 to 4 millimeter diameters, with 2 lanes, 12 and 15 millimeter working lengths. The catheter features 2 radial plaque markers for precise placement, and 2 emitter delivers 120 pulses of target. Now we are using the IVL for the second round.
能把这个转给我看一下吗？来打到6个大气。
About the diameter, about the
shock diffuse lesions.
How about the blue? 英觉那个球囊有多大？
这是2.5的球囊
啊。
因为我看远端的，iOS 看远端的就是2.5到2.75，我选择了个2.5的这个冲击波球囊的4个大气。
4个。
我看这个球囊已经起来了哈，没下来，打了6个大气。8个，30。OK， 没事，不要保证。这里再来。
能够完全起来吗？这个球囊，这个就是那个没有。
可以完全起来。没有，这里看得到啊。
不太清晰，我们
看不到吗？
不太清晰，主要是很模糊。是。
哦。
开始。
可以起来，来打了8个大气。
刚开始的时候是有药的。
开始一个明显的药，最后的话，我们经过冲击波治疗以后，它药就消失了。
The calcification has already been cracked.
你是扩张了2个段是吧？2个就是那个远段一个段，现在是一个段是吧？
对。因为它总共有8次。
Now we have already applied 3 circles, and the calcification has already been cracked.
1、3、4。
那英觉，我想问一下，下一步如果是冲击波做完之后，下一步的策略是什么？是用切割球囊，还是用高压球囊来这个预处理
？What will be the next strategy Dr. Yi Chunmei will be applied? Maybe cutting balloon or the ultra high pressure balloon?
我想那个2个球囊都可以。从 iOS 上来看的话呢，因为它只是个盖法，这里主要是个盖法小节为主中档，所以说我想用高压球囊就错了。但是近档的话呢，因为我这里看的好像盖法的不是很厚，比较薄，所以说我就近档呢想用一个切割球囊去进行 cut balloon 去切一下。
那这个切割的话，这个尺寸是跟那个震波这个冲击波是同一个 size 是吧？
因为我要对近档进行切割，我那可能 size 可能会大一点了，我可能会选择2.75或者3.0的切割球了，因为它近档的直径的话，你至少有3.0。
看一下。
So the Dr. E will apply the cutting balloon at the middle segment, at the proximal segment, and the ultra high pressure balloon will be applied at the distal segment.
2.5的后扩球囊。
到这里以后的话呢，我就想先把远端的支架我先放好，放好的话呢，我再来处理近中段了。OK， 帮我拉一个2.5的长支架过来。2.533的支架。
So now we are applying 2.5 millimeter and 33 stand. Apply in the middle segment of calcified lesions.
您觉得放支架前有没有考虑把这个延长导管尽量送远一点？因为虽然是区域处理过，但是可能支架通过还是
对，我也是这样想的。看是那个后扩球囊的话呢，因为我塞进去以后，它血压这个压力就没了，所以我想塞的时间尽量短一点，我把远端先扩张一下的。OK， 最后我把它塞进去，这个延长导管再插远一点，是。这样的话，能缺血时间会短，来这里打气。
Now we are trying to apply the guide extension catheter to longer distal segment.
我现在延长导管已经插进去了啊，但是它压力马上就下来了。来把支架拉过来。
Now the guiding extension catheter has already been applied. Now we are ready to put in the stent.
这个支架是放到这个一个比较宽的地方，我看到后三叉前好像有一个比较宽的地方。
对，这里有个落脚点啊。你看支架现在很容易通过了。OK， 是吧
？After the pre-treatment of the doctor, the stent is going through smoothly.
OK， 还要走一点。这个还要再往前走一点点。
And now I'm going to introduce some part on our short fast ultra. It got a longer size ranging, from 2.0 to 5.0 millimeter, and we got much more length. It's 20 millimeter, with 3 emitters for long lesions, and we have reached to 240 pulses for this ultra version.
OK， 打气。1680， 40， 15， 12， 15个。
您觉得打了多大的压力？真的是。
我打了15个大气啊。
OK，
对，大气。
产品
16。3.033的支架。对。所以说，因为这个艾沃斯看这个近中段是全是斑块负荷挺重的，所以说我想这个所有的都拿支架进行接 所以说预计这个用完要3个支架。那再帮我准备一个3.0的开普隆切割球呢
3.0切割。
Now we are trying to apply 3.0 millimeter diameter cutting balloon.
我看这个支管是有了这个延长导管，还是血压还是挺稳定啊，还是挺
这个延长导管因为它是一个带刺孔的，带刺孔的话可能就是还是能提供的，但是你插远了以后的话呢，它这个压力是来自于这个母管，就来自这个来自这个盖顶。但是冠冕里面有没有灌注，现在也不好说了，因为我这个盖顶它已经离开了这个冠冕口。能给我来个支架模式吗？不是，他那个有，他那边有啊。给他支架模式吗？
他们有切割。
好像切了蛮多。啊，对，蛮多。OK， 刚刚接上吗？要进去一点点啊。啊，这里可以。而且。
打哈。
6、8、10、
12、
13、14。OK。10就行，10就可以。OK， 可以拉过来。
印主任还有个问题就是，放完支架之后是先后扩张呢，还是这个先看一遍 IVUS 才决定这个后扩张的一个球量大小啊，这个位置啊这样的一个策略。
So what's the next strategy will be applied? Like we using cutting balloon first, or we check the IVL first? No, IVUS first.
要根据不同的病变，因为这个病人他全程支架，而且从支架的形态上来看的话，起的不是太理想，所以往往这种情况，我会先去后扩张，然后再去看 IVUS。如果说你对一些病变不是那么长，也不是那么复杂的话呢，可以先去看 IVUS 看看。特别是对一些短的病变。
To this case, we will trying to do the post treatment, use the NC balloon first. Yeah. 李主任，我们现在现场要切回其他医院了啊。
OK，
All right, ladies and gentlemen, we are now going back to demonstration 9 from the cath lab of Shanfirst People Hospital.
来了。
We get back to Professor Dr. Chin Yong.
Hey, hi.
Hey, we back again, Dr. Chen.
Yeah.
OK， 陈勇老师，麻烦您这边做一下总结 ，review 一下我们。
你是先扩完。
行吧，我们先
讲完。
对。
Pro dilate, post dilate.
Previous.
从就我们做了
OK，
体外化，对吧？我们就
we just leave here.
Let us see the IVUS first.
IVUS 能转播过去吗？
Yeah,
Do you see the IVUS?
Yes. Yeah, we can see.
Okay, the final treatment.
Yeah.
Some bubble. we can see some hematoma.
Yeah.
But this hematoma is limited to just around the septal.
Septal is a true intima.
Chuluma.
Chuluma, yeah, is in the park.
The other one is retrograde RG3. So the wire is in the plaque all the time.
So do you think that the local the effect of local is it equal to the reverse cut?
I think maybe the proximal segment, the knuckle XTA is in the black, but maybe beneath the out point, go to the subintimal space. So you can see some hematoma, but limited to the septal. 把那个 IVOS 再到那个血肿那一段再给我们看一下。The hematoma is very short.
Yeah.
Here is a low hematoma. So I think maybe here the knuckle wire is go to the subintimal space. So in this case, if retrograde wire, maybe IVOS guided re-entry is very promising. Do you agree?
Yeah. So I think you enter in the intima and then to the subintima and enlarge the hematoma and then the retrograde wire punch. So the segment about the segment of hematoma about 10 to 50 millimeters.
No,
maybe only 5.
Yeah, maybe it's very limited. Maybe only 5 millimeters.
Yeah.
Just beyond the septal branch.
Yeah, it's very efficiency.
So anyway, we put a 2 stent. This is the final angle. All the branch is preserved. So I think it's I'm good with this result. Do you feel good?
Okay.
Very
How
good,
about total minutes do you cost? About 1 hour or more?
What?
Total procedural time. 1 hour.
X-ray time is 29 minutes. X-ray time.
The procedural time.
Procedure time
1.5 hour.
手术的时间总共手术
1.5
hour and a half, maybe.
1 hour and a half. Okay. Okay.
So I think
Congratulations.
for this question, maybe the retrograde is to our surprise is simple. So I think maybe retrograde can be effective and last this time. So for these days, I think undergrad have some very promising skill like HDR. In some cases, in some selected case, retrograde is also effective and we can get very good result like this case.
Yeah.
Okay, thank you.
I think so. TD ADR may be the advanced skill, and maybe we learn from you
Okay, thank you.
Thank you.
Okay, let's now move on to the next presentation by Professor Dr. Zhao Xiaohui. Please welcome.
Good morning, everyone. Okay. Good morning, everyone. My topic today is a novel coronary bifurcation classification. My topic is divided into 3 parts. First, classification of bifurcation lesions. Second, the jaw classification. Third, clinical evaluation. Part 1. The definition of bifurcation lesions, as we all know, is defined as a coronary stenosis adjacent and or involving an adequate sized side branch. However, as we know, the CTO is a very interesting procedure. It's like a quiet little dog, usually doesn't bite, and as long as you perform it properly. But bifurcations are different. They are like your girlfriends. You meet them every day, but they are difficult to handle. Also, they will complex and sometimes with poor prognosis. The challenge is there are so many types of bifurcation lesions, even though there is only one additional side branch. So we need to do a lot of work or study to compare, to get the right treatment. So we need simple and effective classifications, easy to remember, to capture the detailed morphology. There are many types of classifications, 1, 2, 3, 4, 7, blah, blah, blah. But many of them are difficult to remember, like this one, Duke. However, the Mediner classification are popular and recommended by the EBC and the guideline. According to the sequence of the proximal main vessel, distal main vessel, and the side branch, a stenosis more than 50% is recorded as 1, and a stenosis rate less than 50% is recorded as 0. It is a direct description, but is semi-quantitative. Also, Muvahid is a US doctor, also proposed classification in 2006. Dr. Chen in China also have his named classification. In 2024, we, according to based on the Mediner and Muvahid classification, we developed a 3M classification, but it's a little bit complex, so we improved it. We call the jaw classification. There are 3 parts of the classification. The first is location. We use the L as the left main vessel. The second part is the bifurcation angle. We use the T as the angles more than 70 degree, Y as less than 70 degree. The third part is the percentage of the stenosis in MB and SB. But it's different with Medina. We use only two numbers, only main vessel and Z branch. So it's simple. Like for example, LY98 means left main bifurcation, small angle. MV is 90% stenosis. Z branch is 80% stenosis. So it's very clear description. We know this. In this case, we need a two-stent technique, maybe. But if the classification is T98, it means non-left main bifurcation. It's a wild angle with MV 90% stenosis, SB 80% stenosis. So we need a two-stent technique, maybe. The advantage, the first is simple for memorize. Left main use the L. The TY routinely used for TY stenting technique. Also, the two numbers is similar with the Medina format, but is more specific. The second is the quantitative, so we can see the picture when we see the classification. It's very helpful. The part 3 is the clinical evaluation. There are 9 centers, 24,000, more than 24,000 CAJ patients was examined. Altogether, there are 17 obstructive coronary artery disease patients with 15,000 lesions were included and analyzed. First, of these patients, 41.4% had bifurcation lesions. It's much more than we thought. It's so popular in our daily work. The bifurcation lesions accounted for 18.4% of total lesions. The bifurcation intervention accounted for almost 21% of the total PCI procedure. The distribution of bifurcation lesions is interesting because we can see almost 90% of left main lesions are bifurcation. Also, 60% of left main bifurcations are T-type. 70% of non-left main bifurcations are Y-type. So it's useful for our daily knowledge. Second, guidance for procedure strategies. For example, a Y55 means we just need medicine. But LY55 means left main bifurcation. MV 50% stenosis, when maybe a single stent strategy is suitable. But for LY99 with significant stenosis in left main, so we need a double stent strategy. So we can see怎么停止这个暂停？有没有鼠标？Case 1 is non-STEMI. The classification is LT99, so it's a very serious condition. We use the ECMO to support, and two stenting technique is used. Next one, yes, the right coronary is occluded. The case 2 is also a non-STEMI with a trifurcation, LT992. So a two stent technique is used. Case 3 is acute myocardial infarction with cardiogenic shock. We use ABP. His non-left main lesions with the side branch stenosis is 30%. So we use the one stent cross over the diagonals. In our study, we found in left main bifurcations, 87.2% cases with main vessel stenosis more than 50% underwent PCI. It's in non-left main bifurcations, 84% underwent PCI. However, the Medina classification, only 64% were treated with PCI. So the draw classification is much better in this section. 3, prediction of side branch compromise. There are a total of 1,946 bifurcation lesions and 1,893 patients were analyzed. SB compromise occurred in 199 lesions. We found that the location, the Angela, main vessel and side branch stenosis were significant predictors of side branch compromise. A prediction model for side branch compromise was established also. The AUC values of visual model and the QCA model were similar. The value is high. Also, we use the external value. Also show the favorable effect. Also, we use the resolve score reported in 10 years, which is Dr. Doe's study. So we show the result is similar, but their score have 6 parameters, is complex than us. Also, we use the Medina to analyze, and we found that the Medina classification has no predictive value for set branch compromise. The fourth part is the prediction of prognosis in bifurcation lesions. There are 2,664 patients with bifurcation lesions undergoing PCI. Median follow-up was 45 months. The myths include cardiac death, non-fatal myocardial infarction, and target vessel revascularization. Our analysis show the bifurcation location, main vessel, and set branch stenosis were independent risk factor for prognosis. We also use another group of patients, 966 patients with only one single bifurcation lesions were also evaluated. They show the same result: location, main vessel, and set branch vessel stenosis. So in our study have some key insights. First, we developed a novel quantitative classification. Second, this classification are multiple function, providing a one-stop tool for strategy guidance, SB compromise, and prognosis. Also, this is one of the largest investigation. It shows that the bifurcation lesions are much popular than we thought before. Thank you for your attention. Thanks.
Thank you, Dr. Zhao. Please take your seats and relax. Next, please welcome Dr. Ahmed Karagos, Chief Physician from Turkey, to deliver a special PPT presentation sharing the clinical research and practice of Turkey in the PCI field. Let's welcome.
Dear Chair and panel and dear colleagues, good morning. We know that Shunmei will launch its new balloon expandable TAVI valve soon. So today we will talk a little bit about balloon expandable valves. We will evaluate some cases, and we will have a quick look at the features of this new valve. So the partner trials have shown the efficacy and safety of TAVI when compared to surgical aortic valve replacement in high and intermediate risk patients, and even in the low risk patients. The latest trials show the efficacy of TAVI when compared to surgical aortic valve replacement, and we have growing experience with high success and low complication rates. Day by day, we use more valves, and brands in the market make these valves cheaper and more eligible for all patients, and it's very important. I think it's an important issue. So there are mainly two types of valves, TAVI valves, that we use: balloon expandable valves and self-expandable valves. There are also some other designs like Janeway, like for pure aortic regurgitation valves. It's not available in Turkey. Some of these valves are already withdrawn from the market, and some of the valves have the new versions. So what are the advantages of balloon expandable valves? First of all, I think it is easier to implant a balloon expandable valve than a self-expandable valve because you can perform all the maneuvers in the sheet. In self-expandable valves, generally we perform sheetless implantation, so we have to retract the sheets and we perform balloon dilatation first in the sheet, then we took the sheet out, then we again advanced the delivery system. So sometimes the patient deteriorates and because of aortic regurgitation, and it's not very suitable for the operator, I think. And balloon expandable valves are also suitable for high implantation angles. Self-expandable valves are not recommended if the implantation angle is more than 70 degrees, but even in the 19 degrees implantation angles, we can perform balloon expandable valves. We have lower pacemaker requirement rates with balloon expandable valves, and we have lower valve embolism and valve malpositioning rates with balloon expandable valves. And again, we have lower rates of need for more than one valve implantation with balloon expandable valves. And if the coronary access is an issue after valve implantation, I think balloon expandable valves should be preferred because even we use the instructions for coronary access in the self-expandable valves. Coronary access in the self-expandable valves after the implantation is an issue, I think. So the last point, balloon expandable valves are suitable for off-label use in the other valves like mitral, tricuspid, and pulmonary valves. So we will evaluate some cases from our center. Our first case is a 75 years old male with symptomatic aortic stenosis, and he was scheduled for 26 millimeter balloon expandable valve. And I don't know if you can see, but the coronary ostium height are enough. We want to have a coronary ostium height more than 11 millimeter in order not to have a coronary obstruction. And the valve is not heavily calcified, as you see here. And the implantation angle is also suitable. But as I mentioned, in self-expandable valves, implantation angle is more important because you can't implant a self-expandable valve when the angle is more than 70 degrees, at least by the femoral access. So here is the angiographic image of the patient. A tricuspid weave is very important in balloon expandable valves. It's easier to implant a balloon expandable valve because you only use a one angle, one weave, the tricuspid weave. You don't need a cusp overlap weave in a balloon expandable valve, and you don't need to change the weave during the procedure. But it's very important to visualize the cusps clearly. Here you can see we can't clearly visualize the cusps, and we give more contrast in order to better visualize the all cusps, and they should be in the same line. Generally, the CT image give us the angle for tricuspid view, but if the tricuspid view is not correct, we generally follow the right cusp to find the correct tricuspid view. And here we are implanting our valve, you only have a one shot other than self-expandable valves. You have a one shot in the balloon expandable valves. You can pull and retract it while inflating the balloon, but you have to do the correct movement while implantation. We generally perform pacing via a temporary pacemaker, not from the TAVI wire. I generally do not prefer it because I don't find it safe, to be honest. So we are adjusting the level of the valve. Is very important, I think. And I am sorry, some of the videos don't run because this was a last-minute change. So I prepared this presentation this night. I didn't have the opportunity to check all the videos, and this is the final appearance. Adequate implantation is very important because if you implant the valve higher or lower, then you will have some problems like regurgitation. I will show it in the next cases.
Ahmad, sorry, can I interrupt for a second?
Yes, sir.
Thank you. Is this a different version than this? Because this is a two-cell design, both equal, and this is a sort of a classic big upper cells. And so is this a different version, an earlier version?
No. The Shunmei didn't launch his valve yet.
Okay,
now
so
we are talking about the balloon expandable valves in general.
Okay, thank you.
There are not much things to talk about the new TAVI valve of the Shunmei, so we are now talking about the general balloon expandable valves. And at the end, I will give some features about the new valve. But now we are talking about the general information about the balloon expandable valves. And here is the final appearance. A well-adjusted valve in a proper place, in a proper level, with no aortic regurgitation. And we always check the peripheral arteries at the end of the procedure. It's very important, I think. So our second case is a 86-year-old male with, again, symptomatic severe aortic stenosis, and he was scheduled for a 24.5 millimeter balloon expandable valve. Again, the corner osteo are at the enough height, and again, there's not much calcification at the valve, and again, the implantation angle is suitable for implantation. So here is our second case. We are again in the non-coronary cusps, and we are adjusting the level of our valve. And we are in the right place. And sometimes there can be some small complications during the valve implantation. Here on the right, as you can see, the two pigtails are stuck to each other, and they are coming together. They are stuck. When we advance the stiff pigtail wire, it doesn't work. They are struggling in the aorta. And to overcome this, we use the other straight, stiff side of the wire and straighten the pigtail and fix the issue. And again, we check the peripheral arteries. And this is a complicated case. Our 0.5 millimeter valve implantation. He again had enough corner ostia, and he again had not much calcification in the aortic annulus, and again a suitable implantation angle. Here we again check the tricusp view and try to see all the cusps in the same line, and we adjust the level of the valve. I would like to draw your attention to our movements during the implantation of the valve. We pace at a speed of 20 per minute during the valve implantation, during the balloon expandable valve implantation. We generally use lower rates in self-expandable valves, but in balloon expandable valves, we generally use high implantation rates. Again, I would like to draw your attention to the level of the valve. We try to adjust it, and we start pacing, and we are implanting the valve. We are expanding the balloon, we are inflating the balloon, and unfortunately there is severe aortic regurgitation after implantation of the valve. We think if it is due to the wire in the left ventricle or not, but we retract the aortic valve and check again, and as you see here, there's much aortic regurgitation, so we have to fix it. You can see the severe aortic regurgitation after implantation of the valve. It's because the valve is implanted in a low position, so we use a second valve to fix that. And here, after implantation of the second valve, when we check, there is no aortic regurgitation at all. So our last case is also important. We generally use valves for aortic stenosis, but also in aortic regurgitation, pure aortic regurgitation. In some scenarios, we can use TAVI valves. This patient is an aortic regurgitation patient, a 70 years old male. He had symptomatic or severe aortic regurgitation and no calcification in the aorta, and he was scheduled for a 32 millimeter balloon expandable valve. I would again like to draw your attention to the image, the CT image. There is no calcification in the aortic level at all. So in this scenario, our major concern is to implant the valve in the aortic annulus, because there's no calcification to hold the valve at the aortic annulus level. So in this scenario, balloon expandable valves are more preferable when compared to self-expandable valves. This patient has an ejection fraction of 30% and had no history of coronary artery disease. So we performed coronary angiography, and as you see, there is no obstructive coronary artery disease. And now we are performing our TAVI procedure. As you can appreciate, there is no calcification at all in the aortic level. So we have a big concern about fixing the valve in the aortic annulus. And we choose a very big valve, the biggest valve available of this brand. And we use more inflation than needed in order to fix the valve in the aortic level. And here, after implantation of the valve, you can see that there is again aortic regurgitation, but we thought it can be due to the wire in the aorta. So we retracted the wire, the confida wire, and we again checked, and there was no aortic regurgitation at all. And this is a very important case in terms of treating an aortic regurgitation with a TAVI valve. And we again check the peripheral arteries. So Shunmei is launching its new product. I think this product will be a game changer in TAVI because As you appreciate, in every case I presented, the calcification was not very much. Generally, we do not prefer balloon expandable valves when the calcification is very much and the calcification is extending into the left ventricular outflow tract and there is bulky calcifications. In these scenarios, we generally prefer self-expandable valves. We hesitate to use balloon expandable valves because we generally have concern that balloon inflation can lead to rupture. So if we can use another device in these scenarios, like IVL in the aortic annulus, then I think we will be more convenient to use balloon expandable valves in the calcified aortic annulus. So I think this device, this TAVI IVL device, Shock Pro, will be a game changer in the TAVI procedure. It has sizes from 18 up to 24, and it provides continuous perfusion, hollow 6 balloon design for uninterrupted blood flow, and it provides high strength fiber for maximum tear and stretch resistance. And the valve, the new balloon expandable valve of the Shunmei. The Shunmei also produces all the equipment that we use during the TAVI procedure, like balloon dilatation catheter, like TAVI guide wire. This is also very important, I think, an expandable sheet. And the sizes begins from 20 millimeter up to 34 millimeter. The biggest size in Turkey now is 32 millimeter, and it's also important, I think, to have a bigger size valve with Shunmei. And it provides a deflectable sheet and deflectable delivery system, 14 French delivery system, and it has 10 sizes beginning from 20 and up to 34, and it's very important to have that much size is very important, I think. And Jane has added this slide at the end. I am seeing this stand with you. The Shunmei Sun valve launch is new valve in Russia in June, and followed by Saudi Arabia this year. And thank you for your attention.
Thank you, Dr. Karagos. Please take your seats and relax. Appreciate it. And may I introduce the panelists for this session? The host will be Professor Dr. Alexandra Afran, and the panelists will be Professor Yang Junqing, Professor Omir Goktin, Professor Xu Zhaoyan, Professor Frankie Tam, and Professor Dr. Tariq Ashraf, Professor Dr. Zhao Xiaohui, Professor Dr. Akhtin Zayadianov, Professor Dr. Ahmed Karagos, Professor Dr. Mehmet Ulugayan. And we are going to take some review of our previous surgeon. So we will go back to our Provincial People Hospital.
Okay, can everybody hear me? I'm Dr. Yang Junqing now. I'm in my cath lab in Guangdong Provincial People's Hospital.
Good morning, Professor. I'm Dr. Sun Shuo from Guangdong Province Hospital. This case is
说个都不用我介绍。
这是之前的 case
go ahead. I'm so glad to have my colleague Dr. Sun Shuo.
我怎么说他之前的 case？ 我怎么说的？
把你做的介绍一下就行了。把你接手之后做的东西介绍一下就行。
接手之后的。
Let's review by
yes, the CTO, and I use the guiding is AL 0.75. And I use the macrocaster, Shunmei macrocaster, and the wire is Shunmei out. I will show you.
我们从这里开始吧。
Yeah.
I think the only one thing Dr. Shun has done is change the guiding factor to AL0.75.
Instant CTO.
我的声音有没有出去
I use macrocaster is the Shunmei macrocaster, and use the where is the Shunmei R. I confirm the macrocaster is instant, so I use the knuckle wear to and
What kind of wire is this?
This is Shunmei R.
Okay. The workhorse wire from Shunmei. Okay.
Yeah.
So because the macro is down, right?
Where?
Okay.
Oh, okay. So, Dr. Sun, can you present the case? This patient has instant CTO. Can you present the case?
回到那个幻灯吧。
PPT 来，换下 PPT。
Okay, this is the case. Dr. Shun just take over from Dr. Cohen. This is still the case of instant CTO. Dr. Rang Peng has presented the clinical data before. Let's show it again. 把幻灯打出来吧。把幻灯。Okay.
Okay, it's a case of the first session. Okay, the instant occlusion. Okay,
yes.
Great. Okay,
that's exactly the same case.
Okay, perfect. Okay. So how it's ending now?
现在怎么样了 Go ahead.
You have finished the case?
No. No.
Almost.
This picture is I use the Shunmei where like the palette 50.
Shunmei 50.
Yeah.
Shunmei 50.
Okay, so perfect.
And I confirm that where it's in the true lumen. So I want mix the macrocaster to the distal of the RCA, but it's so difficult. So I use the Shunmei Godzilla.
Okay.
Shunmei guiding extension. Yeah.
Slender.
This is a small balloon. It's so difficult. I cannot make the little balloon to the distal of the stem. So I use the Godzilla.
Yeah, slender.
This is and 20 millimeter balloon, a common balloon. But the balloon is not, it cannot to the distal of the stem. And I use another small balloon. It always cannot to the distal of the stem. So I use the cutting balloon, Shunmei cutting balloon, and the PCI can access to the distal of the stent.
Sorry, what size of your cylinder catheter? Is it 6 French or 7 French extension?
2.5.
No,
Sorry?
2.5 cutting.
延长导管
2.5 cutting balloon.
No, the cylinder
The cylinder.
延长导管是多大的？6F 的，7F 的。
Standard? What standard?
延长导管是6F 的。
他问了什么？
啊
？Sorry, beg your pardon.
No problem. We just want to ask if the cylinder is 6 French or 7 French.
7 French.
Okay, thank you. And cutting balloon 2.5.
Yeah.
Okay.
And this time the small balloon can reach the distal of the stent. This is the common balloon. 2.0.
You have still P wire inside, or you changed already your CTO wire? Did you change it?
No, I don't change. Oh, I changed the parallel 50 to the Shunmei R.
Okay.
Yeah, I forgot. Sorry.
Okay. So can you show us now the angio, the result?
I don't make the angio. I want to use the iris first.
Okay.
I will show you the iris imaging.
It's a very tough case, actually.
I'm concerned.
Where are the Turkish guy?
Sorry?
They disappear because it was firstly done by your colleague from Turkey, Mustafa.
Really? Yeah, okay.
But they disappear. So I will be afraid.
No.
You were here. Okay, so it's a magical trick. You start.
Dr. Kai are coming to the meeting, to the meeting hall. Okay. Because the patient suffered, so once we want to stop the procedure, but after a while, the patient is okay. So that's why after Dr. Cohen left, my colleague take over. I think for this case, what Dr. Shun did, most important thing is change the guiding catheter to AL075 and carefully engage, make it coaxial. And then he didn't record many imaging, so I guess he just manipulate and engage the guiding catheter.
It's so difficult
to get
to push.
I am not surprised. Boston IVUS is not that much.
Yeah, that's what I expect. Must be a lot of resistance. No problem. So what's your next plan, Dr. Shun?
I will mix Godzilla to the this of the stent.
It's one option, or we can just get the high pressure balloon. I mean, a non-compliant balloon,
Yeah.
All the way post-dilate with the high pressure. And I think without IOS imaging, we can also dilate the stent segment. And after that, if you want, we can check IOS again.
I use the NC balloon 2.5.
Oh, you did?
Yeah, I use.
What size is it?
2.5.
2.5 or something? What size is the NC balloon?
2.5. 2.5.
Okay. And what's the pressure? 20 something? 20 atmosphere?
Sure.
Are we still inside the stand? There is still some resistance. Okay. It's not very easy to get. Can we overcome the bending? No, it's not easy. How long is the stand beyond the cylinder? 支架的下游，银行导管下来还有多长的支架呀？
大概有5毫米。
Okay, there are still 5
millimeter.
5 millimeter. Can we just get the non-confined broom, go to very high pressure?
I think the hours and
oh, you guess the hours can overcome, right? Okay, let's see. Let's try it. That's our daily work. We usually discuss, argue in our case lab every day. Sometimes my junior colleagues challenge me, and sometimes they win. See? Dr. Shun wins again. Okay. You win. Okay, you win, my guy.
Okay.
Okay. Let's check hours.
Let's check the hours imaging.
I hate you, man. I hate you.
In a stand.
Can we see also the scopy? That's why we will learn where we are.
It's severely undersized at this part, I think.
Seems a lot of tissue. Okay, the guiding caster is engaged.
Yeah, I was.
Seems the stand didn't cover the ostium of the coronary, huh?
The second runner will check the open of the RCA.
Okay, now we are in the stand. This human is okay. Okay. Sip here. Okay, that's the orify. Okay. So now, may we take some angiogram. I'm here. I'm behind you. Okay. Would you like to engage the slender a little bit to the spine? 咽导管送进去一点点，照个影。
你帮我问问他们有什么策略？对。
Okay, Dr. Shun now have a question for our panels. What's the strategy from our? Is there any suggestion from our panels?
You mean how to treat this after IOS?
Yeah.
I think this is instant CTO, and I can say that there is under expansion. I think we could do nice and strong ANSI balloon dilatation, and I think it could be 3540, because I like to see the ostium, because in ostium there is non-calcified part, and we can see the size of the vessel here, for example, because otherwise we have circular calcification and we don't see the real vessel size.
Right.
So first of all, we have to make sure the vessel size, and I believe we can do 3.5 this stand and then 4.0 proximal part.
Okay, at least 3.5.
And then
Let's
DCB.
I'm sorry, we don't be in the cap.
In our hospital, we now we cannot use the DCB.
那我们就3.5
Can we stop here to see the vessel a little bit back?
为什么？
停一下 Iris. Go back a little bit. 往回退一点点。Iris 退一点点，退一点点。哦，不踩了。
你跟他们交流还是我
？Okay. Here is the ostium of the stand, right?
Yes.
We're now still in the stand. Okay, now it's out. I'm sorry, the signal is poor here. Here?
用顺美了吗？不是。
Are we? Oh, still there's some stand strut. Here is clear.
有后扩吗？大家说哪有没有
？Yep, seems it's clear of stand. And there is some plaque, not very severe.
Here is almost for, I think, the lumen.
Yeah, almost. So do you think whether we have to cover one more stand to the ostium? Or just leave it around?
I think we have to cover the ostium because there is no landing zone. All artery is diseased, more than 40-50%. I think we had better to cover.
Okay. But I'm worried about if we cover put one more stand protrude to the aorta, that may be some trouble if the patient need the PCI next time. Anyway, let's post dilate with the non-compressed balloon first, okay?
I think we had better to do some aggressive for post dilatation here to achieve maximum stent lumen area.
Maximum stem area， 来测量一下。对，就这里。It's okay. Area is 4.5 something, and lumen diameter is 2.5 something. Yeah. So, what size of balloon do you recommend?
So can we see the contrast image?
Yeah,
you know, after nitro, to see distal RCA, how big they are, how big the branches to guess also.
Okay.
The size of the ANSI.
Okay.
把那个延长导管进去一点点吧。Just a little bit.
放心。
Just a little bit. I subject.
没有好一点不好一点，最好的策略。
Okay, no. 不用太深。Just a little bit. Yeah, it's okay. It's okay here.
这个可以吗？
可以。To make it better coaxial and better perfusion of the contrast to the coronary. Because we have to keep in mind, I mean, I explain my thought to audience. At least view, LAO view, you always look good, but if we turn it to the IO view, the guiding catheter is always very poor of coaxial.
But distal is very big artery. You see that the PLA is a very huge artery. You know, look to distal. So I think we have to do some massage to distal as well, not the stent but massage. I would love to do a DCB to distal, but you don't have it, unfortunately.
So do you want
After
to put
seeing
one
this
more
big
wire to the
RCA,
PL?
I do 3-5 and then 4-0 post dilatation of this stent.
3-5, okay.
And then 4-0, and then 4-0, because he's a huge RCA. Look to distal.
Okay, now I get it. I'll subject to for one more injection in left shoulder view. 我们去左肩位再照个影吧。OK. Let's show the posterior bifurcation.
它这个改对了，好像很容易。
Yeah. It seems there is still some lesion at the ostium of the RPL. Okay.
Yeah, very big RCA.
Yeah. And also stenosis. So maybe we should put one more wire to the PL.
Oh, yes, it would be nice.
We implant the long strand to the distal of the RCA.
对，我们拿多一个导丝放到 PL， 然后全程用球囊长时间的扩吧。
再拿个顺美啊。
To put the wire to the RCL, to the PL, RPL, and pre-dilate with the balloon for long time, every time. I mean, do some massage, as you mentioned.
Yes, but I think I would do massage at the last touch of the vessel, because let's finish the proximal part and then do some massage to distal.
Okay, you mean the
otherwise we will have contrast-induced dissection at the distal.
Massage. So 那也行吧。他的意思就是说，先做那个近段的后扩。
You see that the proximal stent size is almost similar to distal artery size.
Yeah, it must be under expansion.
Yeah, exactly.
I agree with you. And I would like to get at least at the very first, at least a 3-0 balloon.
Is there anything at the distal part of the PL? At the distal part of the PL, some contrast just go out. Distal part of the PL, this wire goes out. At the last image we saw, I saw that there's.
Let me ask you.
Did you notice it? At the distal part of the PL, there is some contrast is just going out.
Okay,
or maybe it's intracavitary.
So, Dr. Sun, we will leave you for a talk, presentation, and please tell us what your plan now. I believe that you will do post-dilatation of the stent, and then put another stent, and then distal massage. Am I right?
Yeah. Just like you mentioned.
Okay, thank you.
You're
we'll
right.
back to you after 50 minutes, hopefully.
No problem. Thank you.
Thank you.
Thank you.
All right, thank you. We'll get back to the hospital later. And now, please welcome special PPT presentation sharing the cutting-edge research and clinical practice of Turkey in the PCI field. Welcome.
Okay, I want to ask you, how many of you are doing CTO in routine practice? How many of you, please? The rest? Okay, how many of you don't do CTO PCI? Didn't start yet. Okay, so in my talk, I like to focus why we should do CTO PCI, why we have to learn it, and why we have to be in this area. I like to focus the first part of my talk, focus why we should do C2 PCI, and then the second part, how we could do C2 PCI. So if we see the prevalence of, is it okay? Okay, yeah. So if we see the prevalence of this CTO PCI, after CABG operation, we have 54% of the patient we have CTO, and acute MI we have 10%. In general, we have 18% of the patient have CTO. And how many of them can be attempted? Like 9.5% of all CTOs normally are attempted. So it's very low, I think. 10% of the CTO only have some attention. It's very low. And the success rate is between 70% to 95% according to operators' experience. So most of the time when we talk to patients, we mostly ask for angina, but angina is not the only symptoms of CTO. If the patient has CTO, patient might have dyspnea and fatigue, and most of the time, patients don't tell us if they have, fatigue or dyspnea when they have. And also progressive LV dysfunction could be present despite without any symptoms under optimal medical therapy. And also we could have, CTO-related lethal arrhythmias in some patients. So we have a EURA-CTO trial, and that shows us, it's a randomized trials that show that CTO PCI helps for, increased physical activity, and it decreases angina frequency, and also it's increased quality of life. How about the prognostic importance of CTO? It's shown that CTO was associated with higher mortality, and risk attributable to CTO was greatest in patients with ST elevation MI and younger patients. So that's important to see that CTO is important for prognostic. How about complete revascularization? If we do complete revascularization versus incomplete revascularization in patients with multivessel disease with at least one CTO, and then it shows that if we do complete revascularization with opening CTO, patient has better mortality rate in 3 years. And also we have to mention that ischemic burden, right? So this patient has no symptoms, but ischemia, and ischemia is burden is 14%. The left system is not bad, and it is diffuse disease, but there is no that significant lesion. Most probably the patient has diabetes, but RCA is occluded here. We have seen some collaterals from left system. It's a big RCA, and when we do a dual injection, you see that we have a short lesion at the mid part of the RCA. So should we treat this patient because patient has no symptoms and is 50 years old? Then we should look the ischemia. Ischemia is more than 10%, and if the patient 10% is the cutoff level, if the patient has ischemic burden more than 10%, we had better to open that CTO because mortality rate is 5% yearly. So this is after stent. And when we look appropriateness of the percutaneous intervention in CTO patients, the first I think we have to ask if the patient has symptoms. If we have a symptom, then we have to check left system, but RCA is occluded from ostial to distal. This young chap again, 34 years old. He was my patient. I treated 15 years ago now. So how many of you would like to treat this? But less than, the previous case, because it looks like that it's a complex case. For a CTO operators, if you have a nice collateral, it's not that difficult case. And the success rate is, I think, more than 90%. So I think it's important, mortality in ST elevation MI is higher when we have CTO. Especially if you have a young patients, that patients may have, ST elevation MI in future, that time they will have more risk of death because they have a CTO. And also another study shows that if the patient has CTO, they have more prone to have a shock, cardiac shock. And we treat this patient percutaneously. So another patient, I think this is also important, this patient, because when we doesn't like the angiogram, when we see it is too complex, we just say, okay, go to CABG. Yes, it's very easy, CABG, surgery. This is one of that patients, 80 years old patient, classic 3 angina. There is no Q wave, ejection fraction is okay. This is the LAD. This LAD, and LAD is occluded. We have a huge diagonal, and we have CX, CTO also, and subtotal occlusion. Distally, please look at the distal CX here, especially. Distally, long CX, but diffuse disease at the distal. So RCA was okay. How many of you would like to send this patient surgery? Please, be honest. I think most cardiac interventionalists first, ask this patient to surgery. But what surgeon can do it? Very distal landing zone, right? So they put graft that part. There is nothing to do. It will be difficult because it will be intramuscular. And also for CX, look to CX. What can surgery do this? So I think this patient has only option for PCI. So that's why we have to learn how to do CTO, and then we should start. This is after LAD, PCI. We did the absorb in this patient, LAD, and then CX also. It's very big CX, you see, very big CX. Another case is this one. This is RCA occlusion. This patient has CABG operation, 58 years old. And you see his graft to PDA is diffuse disease. It's almost finished, but he has, angina. And in the left system, CX is not bad, OM is okay, but there is no LAD. LAD is small, actually, I think. There is lima, goes, small LAD and it's occluded. The patient has surgery, it's angina. I think we have to treat this patient. We cannot send patient surgery. I don't think it's a good idea to send him another surgery. And then we can open this retrograde using this very ugly graft, but in terms of technique, it's not that difficult. And then we have a huge 5-0 RCA here. Another example, why we should learn to CTO, why should be in this business. This is, again, post-CABG patient, acute coronary syndrome. This patient came to another hospital for acute coronary symptoms. Left venous disease, CX is disease, occluded, LAD is occluded. This is the left system. RCA is rudimentary RCA, I think, because CX is very huge. And then we have only graft to go diagonal supplies OM and LAD. LAD is not that big, at least here, but we have a thrombotic lesion. So this patient sent to us to intervene this graft. But we have only one artery, which is this one. If if something happened, it could very easily have no reflow because of the thrombus. Then patient may crash on the table. So what we did in this patient, we did dual lumen injection from a graft, and then you see we have now see that it's not actually OM is not total occluded. It's a kind of subtotal occlusion. And here again we have another view. We have also septals to go distal CX. Nice to see this because CX is also very big. You see the CX, very big one. Anyway, first we treat OM because we know that the diagonal supplies OM, right? So if something happened to diagonal, when we treat graft, then OM will help to diagonal. So there will be no any issue. That's why we open diagonal OM first, and then we did graft intervention. Of course we use filter. I think we have to use filter in this patient, and we did direct stent. And after stent, please look at it. We have no flow to distal. And then we have a thrombus in the filter. So we know that it could happen. If it happened before we opened OM, we had very hard time. Maybe we could lose the patient if we don't have impella. And then we treat, after we treat this patient, look now, there is no flow to OM because OM has own flow and big OM, and also we see CX is also big, and we did also another intervention to this distal CX, and then we treat it. So if I want to show you before and after the operation, we have diagonal now, and then we have this one. So I think how we do this with, of course, skill of CTO. That's why at least some of the PCI operator has to learn how to do CTO. Another case, this is also very young patient, 50 years old, post-CABG, 6 years later, he had severe angina last 1 month with minimal effort. He cannot walk without pain. And we have Lima to LAD and Safan to PDA. Patient had several PCI and 7 stents in total. And ECG shows sinus rhythm, no QA. Ejection fraction is 30%, no QA. And we have ischemia and viable tissue everywhere. And patient had recurrent ICD shock due to VT. That's another issue. And then we know that ventricular arrhythmia occurrence in sudden cardiac death with ICD therapy is related to CTO. If the patient has CTO, has more VT and shock. And also CTO revascularization improves ventricular remodeling and ejection fraction, and also that will decrease the ICD shock. So let's see the angio of this patient. This is left system. There is no CX, left main disease, diagonal disease, LAD is occluded. And here we have some septals, small septals, nothing more. And diffuse disease. This is the patient, 50 years old guy. So I think we have to help him. We cannot send him to surgery because Lima is already operating. So how we treat this? The first we treat under help of PulseCat. We use PulseCat in this patient. We did treat first left main and diagonal, and then LAD in the same station. We put a stent from left main to diagonal. As you see, we did the post-dilatation. And then the other trick is here, although we use PulseCat, we have to be very careful. If we use this short use, can we have charger, please? Can we have charger? Can I have my charger? Charge in my bag. Can I have my bag, Jane? So you see, we have a very, very diffuse diseased LAD. And how can we treat this? We can treat this through Lima, but we will have, again, ischemia because of the tortuous Lima. We will have accordion effect and no flow to LAD. So it will, again, difficult. What we did, we just crossed from left main to LAD. So Lima is working. We are working from left main, so we are very comfortable. We did some dilatations, and here, and then we treat LAD through left main, and this is the result of the stress. So before and after, we have a good result in this patient. Again, using CTO skill, because we did cross from left main to LAD. And another, in this patient also, this is control angiogram after 6 months. We have nice diagonal flow now. And we did also, the lemma is even better, lemma to LAD is even better. So we did also RCA CTO, it was also occluded. We treat this one after 4 months, and result is this, but after 4 months, as expected, RCA's distal flow is better. And then we have a CTO CX, and we treat that one as well. And this is after CX PCI. So at the end, patient has really great ejection fraction up to 45. We treat this like 8 years ago. I'm still patient under my control. He's very happy. Of course, I think in this patient, we definitely help for mortality, increase these patients, I think, survival. Imagine that this patient lives still alive. So this is before and after imaging I want to show you. Okay, so how we should... Okay, so how we should start then? I think, I mean, personally, I believe we have to do CTO. Some people, some guys say that, okay, CTO has no mortality effect and nothing, why we should just do therapy. I don't think it's a good idea. So why we have low attempt rates in general interventional cardiology? Because the main issue is fear of failure, right? People fear of the failure, fear of unsuccessful. And complications, yes, C2 has severe complications. We have to be aware of it. And we have some of operators stopped regarding long-term results, but we have a very good results now. We have an excellent stance, DCB now, and we have a long-term good results. Of course, time and cost is important. Yes, the operators should spend more time for CTO, and also cost is high, that's for sure. And radiation exposure for operator and patient is important, and we have also opportunity for the CTO. So we have keys to successful CTO program. The first is operator specific. Operator has to has good enthusiasm to do CTO because it's a long way and hard work to do, and also catheter staff, we should prepare them as well, because it's, again, long and problem with the hospital administration because of the cost. We have to convince them that we should do this. And of course, also we have to have some patients from other physicians. So a professional drive to go through a learning curve. We have a really learning curve for CTO, but we have to have baseline technical proficiency. I think it's possibly better for mid-career, not the beginners. Beginner interventionalists, this is mid-career, So if someone has to like to learn CTO, I think they have to do bifurcations, left main and calcified lesion, and then CTO should come later on. Because I think the CTO is the top of the mountain. There is no formal training that much. We have, of course, fellowship, but most of the time it's job training, most applicable. And there are lots of online live case archives, and we have observerships and proctorships, especially proctorships, extremely important. There are lots of CTO PCI meetings, and we have to describe with partner. This is also important. We have to have different catheters and materials. We have to have all of them. This is very important. And how we do start? I think it's important to create CTO day 1 or 2 in 1 month, 1 or 2 days in a month. We should start in that way. We can collect 4 to 6 patients, and then of course we can call proctor from either the same country or from international, because industry obviously support a lot the CTO business. So there are lots of proctorships everywhere. I think the one who like to do CTO PCI has to have some industry support. This is very important. And then we have to use new technology. Never do ad hoc PCI. And we have to see, we have to do detailed angiographic evaluation. This is very important. Before CTO PCI, we have to see several times angiogram. And I think it's good to have 2 operators at the beginning, because they help each other. In each center can have 2 operators. Dual injection is mandatory. ACT is very important. It's not that maybe important for routine PCI, but for CTO it's very, very important, because we use double guiding, and then we could have donor artery problem. And we have to set dedicated days and time, and also we have to if we fail, we have to send them to other operator to learn better, and maybe we should bring our patients to other hospital. So we have complications, severe complications. We have to be aware of them, and then we have to know how to deal with them. We have to have all materials we need, and I will show you some examples very fastly. So how to choose wires? I said this is an important topic. How do we choose wires? If we have tapered cap, and if we have microchannel or loose tissue, then we can choose, tracking technique and loss tissue tracking technique, which is sliding or drilling. We can use polymeric wires here, like Gladius EX or Pilot series or P series, belongs to Shunmei, and Fielder XT-AR or Shun FA or Shun FR, Sion Black. If we have blunt cap and interval plaque, if we have blunt cap, then we have to have better penetrating wire like Gaia's, GN series, Ultimate Pro, Miracle, Conquest Pro, and Hornet. If we have in subintimal space, if we do knuckle wire, we can use XT, again, Shun F series, and also P series and Gladius MG. So 2 steps is important. Proximal cap penetration is very important, and then wiring the CTO and reach the lumen, another step. Penetration, let's see this patient. This is RCA occlusion. We have a occlusion at the mid part of the RCA. In here, I think we can say it's ambiguous cap, right? We don't see where is the proximal cap. But this is one view. We have to see from other view. When we look from other view, which is RAO, now we know the proximal cap now. We have acute angle, then we can see RV branches, very wide angle. So we have, now we know where is the proximal. Gaia, second, and then you see how penetrated and it goes itself. What I do, if the wire goes itself, let it go, right? If it means that he finds that soft tissue and then it goes, let it go. No need to stop, no need to push your microcatheter. If it is goes. If it is nicely goes, means it's find a loose tissue or channel. We did this, and then wire goes distally, and then we did, of course, injection from left system, and we like the position. It first went to side branch, and then we were able to go distal lumen. And of course, we have to clarify where are we? We are distal lumen. This is final result. This is another example to show you. This is LAD occlusion. We have a diagonal branch here. After diagonal branch, we have occlusion, and distal landing zone is not bad. I think we have a good chance for antegrade here. We have septoseptal branch as well. Which wire would you like to choose here? If you choose polymeric wire, most probably it will go a side branch because we have a diagonal branch here. You see, we have a diagonal branch, most probably not easy to puncture cap, right? Hydrophilic and polymeric wire will go directly side branch. The first wire was here, ultimate bros, and ultimate bros went to side branch. I want to show you how the filling. You see, when we touch, this is ultimate bros. How is acting? It is touching the cap, but just slip the side branch. Any Gladius will do that, P will do that, many of them will do that. I think we have to have something that we can grab some tissue here, and here we had the concast, and concast just grab the proximal cap. It's touching cap and then just penetrate it. Now it's touching and then penetrate. That's the difference between wires. And then we did de-escalation here with the Gladius. And then this is the result. Sometimes you have a very difficult proximal cap penetration, and in that case we can use double lumen catheter. We have different double lumen catheter, and now we have lumen, which belongs to Shunmei. I never use it, but I will use hopefully next days, because we will have it in Turkey as well. This is proximal LAD occlusion. We have two branches at the proximal cap. One is septum, one is the diagonal branch. And you see this is concast, and microcatheter is Corsair. Concast either goes septal branch or diagonal branch. All the time, he can touch proximal cap but never penetrate, goes just slip. In this patient, I think double lumen catheter would be very helpful, as you see, because that's double lumen catheter stabilize my CTO wire, and when I touch the proximal cap, I could just penetrate it with the same wire. So if we are in the subintima with the first wire, what we can do? We can do parallel wire. Parallel wire is very, very helpful. We still do it a lot in Europe, and more than I think US people use it very, very rarely. This is LAD CTO PCI. Looks easy. Right? Looks like we have a channel, but sometimes it looks easy, but it may not. So here we use first wire. It was the Gaia second. Unfortunately, it went subintima, right? It goes subintima. And the other thing is there is a big difference between distal lumen and the wire. So we did here parallel wire, and we do parallel wire. We can say that we have to penetrate differently from the proximal, because you see we have this kind of curve, but we have our vessel is like this. So better to separate two wires at the proximal part, not the distal part. And from here we do penetrate between two wires. And then, of course, we will check where are we, and we are just about to enter the true lumen. So first wire helped me a lot in here, because I know the distance between lumen and then first wire. And we cross it. This is the final result of LED. So to do or not to do CTO PCI, I think we should do CTO PCI, guys. If you don't do it, and please, if you have, I would say young enough, if you have lower than, below 50 years old, you can start. But above the 50 years, I don't recommend. Too late, because until 65, we can work, and 15 years, I don't think it's a good idea. Because to make an expert, I think take like 4 or 5 years, I think, to my opinion. For 5 years, anyone can be real expert. And we need to do a lot of more CTO PCI, because one CTO operators can do 200 maximum in a year, most of the time, in routine practice. So, but we have lots of patients. All high volume centers should have at least 2 CTO operators, like big centers. We have a big centers from Turkey. Each of them has 2 operators at least. And also big centers, you know, like we have big hospitals in Turkey, like 8, 10 cath labs, and China also lots of. We have to have, I think, like EP guys. EP guys has 1 or 2 cath labs in business center. We have to, as a CTO operator, we have to have 1, I think, lab for CTO, because CTO is, you know, long procedure like EP. And of course, all CTO operators should have proper training. So we have to start with the easy case, GCTO score 0 or 1. This is very important. Please choose simple cases at the beginning and grow a CTO practice, establish a CTO program, and please teach how to do it to others. Thank you very much for your attention.
Thank you, Professor. Please take your seats and relax. And next, please welcome Professor Dr. Mihailo Kovacic, Chief Physician from County Hospital from Croatia, to deliver a PPT presentation focusing on the application of combined technology in CTO lesions. Welcome.
就这样吧。
It's a great pleasure to be here. Thank you, Shunmei, for invitation and organizers for creating this great event. So it's my honor to give a talk after the brilliant talk of my friend, Professor Goktekin. So can we go to the slides? So my presentation is new CTO chip and toolbox. So like Dr. Goktekin said, we need to learn, and you said all about that presentation, but before the start of the program, and you're getting better and better, first you have to do everything about the tools that you use in your hands. So that's why we are trying to help the community and people operator in the world, describing all those tools. And this is the third project of my team and myself. So this is, of course, never-ending story, and the companies, especially productive companies like Shunmei, don't let me sleep because I have to expand all the time all the material. So in my talk, I will just show some cases and some new tools that I was able to test in my practice recently. Of course, regarding wires, I will try to be short. You know, there is a lot of wires. We need to know purpose, construction, the coating, hydrophilic, hydrophobic. If this wire is polymeric, how the core wire is created. So you know exactly what, when you analyze the anatomy, when you know construction and purpose of that wire, you will how the wire make tips and pre-shape the wire for each scenario, but we nowadays have also pre-shaped types of the wire. So some of the wires that we learned about from the Shunmei, we have a lot of them. The names are not so hard how to learn if you know already some wires that exist. We didn't use all those wires today, but some of them. So this is Shun R family wire. It's basically like workers wire, very good workers wire. I tried few cases. It's like run through. It's nitinol, very good shapeable tip and shape retention. So it's a classic hydrophilic wire, 0.6 and 1 gram, very similar to run through. Shun S family also, it has inner coil, hollow wire rope coil like Asahi wires, and this is like a regular Xeon wire, full hydrophilic wire with 0.1 gram tip load, so it can be used good workhorse and also good septal surfing or similar. Shun F family is like a filter, Shun F, FA, FR, 1 gram, 0.6 gram, and we can use those wires like usually first wires in CTO. So this is one case of like
previous was mentioned, loose tissue channel tracking. So long, narrow channel tapered cap. So the Shun F or Fielder family wires would be first choice here. So this is a little, slides are not so working. So this is microcatheter antegrade crossing, and you can see behavior of the wire. The polymeric wires intend to be intra-architecture of the vessel. So there's one small side branch that we knew from the previous analogy. So this is very easy case through crossing and final. Also, we use new family like a pilot to Gladius. The very good addition is it's a little bit harder. So P200 is a little bit more potent than when Pilot 200, but very good addition that we have today is P300. It's 6 gram tip-load polymer jacketed wire. Maybe the company will produce P400 with 9 grams. It should be also good to have. So this is some case with true-to-true wiring with P200, like 4.1 gram. So this is not so calcified lesion, but very long. We have distal verification, and everything was wired with only up front. Today I start majority of the cases with similar cap up front with a harder polymer jacket wire. I skip usually tapered polymer jacket wires only. So this is the case with Shun P200. And also we use for knuckling. Polymer jacket wires we use for knuckling in most cases. So this is like rolling knuckle. You see the big rolling knuckle followed with a microcatheter. Then knuckle rolls further and travels distally. Traveling knuckle is the name we use for Gladius MG dedicated small knuckle because the integrity of the knuckle travels distally, and this is a rolling knuckle. Also with tapered polymer jacketed wires we can do small knuckle, but also big knuckles with like this. Special wires we heard a lot today with the GN family. This is directable wire, penetrative wire, similar to Gaia Next regarding tip load and also tip radiopacity. This is pre-shaped, highly penetrative, like a needle tip. So we have to be very careful. And in general, we have to very good know trajectory and vessel direction, because you don't go over the bendings, you don't go with those kind of wires. When you don't know the architecture, when do you expect architecture? So this is a one case also with true crossing through that calcified lesions with small tactile feedback. You have to be very careful what you feel in your hands and combine what you see on the screen. So you go to the resistance, you deflect the wire on the opposite and cross it. So this is the idea how those wires should be used. Microcatheter structure also very important. Tip types, shaft types. Is it braided? Is it coiled? So braided microcatheters can be slightly rotated, but cannot be built to work. And what important is distal shaft outer diameter is one of the main focus how the microcatheter has crossability properties, and proximal shaft also you have to know this regarding how to be compatible with your devices. We nowadays have various length, and also from Shunmei, the driver microcatheter is also very long and 130. So I tried a few cases, the driver, this is very similar to fine cross, but the driver rev is unique. It's very, very tiny 1-point French microcatheter. It has very tiny, very soft, this 35 centimeters. So it is unique microcatheter on our market, at least. I know the microcatheter named High Track. It's only available in Japan, but this is super tiny microcatheter. And you can see this is the main difference from known microcatheters that we have. Only 1.5 French, and the length is 130, which is also a little bit more supportive than 135, but we have also 170 available, and of course 150. This is one case. We have only retrograde options, and in this scenario, we explored a lot of collaterals, but there is very hard crossing of those collaterals. So we finally managed to cross, but this was so tiny, so muscular, so muscle bind collaterals. Turnpike LP didn't cross, Caraval didn't cross, and even small Elong 1.7 French didn't cross. So we couldn't manipulate with the wire distally. And after that, I used driver ref, which is smallest crossing, and even driver ref could go up to the level of the PD, and luckily we were able to do knuckling from the retrogate and complete the job with a reverse card. But the very interesting thing about the driver microcatheter is also it is extremely visible under the fluoro, so it has very condensed mesh. So this is most visible microcatheter because we know that if you do something with fine cross, with Elong, with Mamba, the body of the microcatheter is no visible, but only the radiopack tip. But the driver microcatheter is very visible through the whole body. So this microcatheter helped us to cross. I think it is super useful in very tiny septals. It is very safe driver ref. It is very safe in some very tortuous small epicardials and also for uncrossable lesions. Sometimes those kind of microcatheters can slip easily between the calcium instead of big bulky microcatheters and torqueable. So shock-fast, we see a lot of cases, this is, I started to use it sometimes in last year. Also, I'm comparing it all the time with the shockwave. So the main difference between shockwave is that pulse frequency 1.5 hertz, so it delivers 10 pulses in the time of 6.6 seconds, not in 10 seconds. So the shocking process is a little bit faster. And regarding the deliverability of device, it is a little bit smaller profile than shockwave. So in my few cases that I use it, it's a little bit more deliverable than shockwave. 1.5 pulses per second. Shockwave has 1 pulse per second, and also have 100 pulses in total. And that button on the it can be double pressed, so the shocks going by themselves. So crossing profile is a little bit bigger, and also it's available 12 and 15. And we saw that this available also Shockfast Ultra, which has 20 millimeters length of the balloon and 240 cycles. This is one case of very calcified. Lima was okay, but we have to treat these CCS3 angina patients, extremely calcifications. So I did myself. I tried lytics balloon 3.5 to work, but it didn't work. I did 25 implantations by the protocol, and it was always dog bone. So I replaced lytics balloon with a Shockfast 3.5, and after 15 pulses in the second run, balloon opened fully. So probably lytics is not proper. It is very good in compared to the Boston Scientific Wolverine, that it is basically balloon is non-compliant, so we can inflate it above the 20-25 atmospheres, and we can use with the same cutting balloon, we can use cut and crack technique. So crossability is okay, and this is one case we use safe cut here and Shockfast here. So this is the crack after the Shockfast. In proximal LAD, it was very thick calcium. We couldn't crack it with the balloons. And this is the final result in the proximal LAD. So combination of the Shockfast, dual lumen microcatheter. This is all utilization that we have to do. I won't go through all these steps. And now we have this lumen, the new microcatheter. Basically, the construction is very similar to Sasuke. But the main difference is that we have also 135 option. Sasuke is only 145. So with 145, we can do retrograde cases through the septal collaterals, but also support and maybe deliverability is a little bit better than Sasuke. And Dr. Avran used it yesterday, so it is oval. It cannot be torqued, but deliverability is expected very similar to Sasuke. But like I said, the main difference is this 135, so 10 centimeters. So maybe pushability is a little bit better for the anterograde cases of this short. This is guide extensions. We use it mostly to deliver materials to overcome the complex anatomy and so on. And we have also new device slender, which also we did some nice cases like this one, complex case when we need rota and heavy inchworming, balloon assisted tracking with a balloon. So we just saw a safe cut case before using slender, and this is our everyday tool. So compared to Guidezilla, we have side holes, which is nice, especially non-CTO PCI side holes, and also long and short. So a little bit more addition to our everyday. So we see the inner diameter, effective inner diameters basically is very similar to Guidezilla. So this is the new stuff that I tried from Shunmei, and we will exploring further and evaluate further and maybe sharing knowledge to the people through our projects. Thank you very much.
Thank you, Dr. Mihailov. Please take your seats and relax. And just a quick reminder before we get back to the provincial hospital. Shunmei has ordered 500 pieces of the toolbox, and the Shunmei is willing to give it to any doctor from any country for free. The toolbox, which costs each one is 65 euro. So, should you have any interest, you can contact your local distributor for the demand.
对，非常好，支架非常好。
Okay, now we are getting back to the provincial hospital.
OK， 可以。对，那就收吧。是，好的。
So could you hear us?
Yeah, I can hear you. Can you hear me?
What was your strategy after the result of the IVUS? We were discussing about NC balloon, or so. What was your decision? Freezing. So no decision. We lost the connection with. So,
sorry, we have some problem with the connection, and we are still working on it. It costs maybe 2 minutes.
Okay, so you want to sing something? We need a singer now. 2 minutes. Omer, a Turkish song? We have 2 minutes to wait, so we need a Turkish song. So maybe we can see the final after the lunch, no? If the connection is delayed, maybe we can have the lunch and see the final result after the lunch, depending to the. Yeah, well. Okay, great.
可以了是吧 ？OK。
Okay,
I'm
perfect.
I'm sorry because of the technical problem.
No problem. We are
Okay.
back with you, waiting for your.
Yeah, the imaging. We can see the imaging, right? The
Yes.
angiogram. Okay.
Great result.
Dr. Shun just did a massage for the distal vessels all the way from the stent edge to the replication to the RPL. And after that, he did a post dilate with like a 3.0. Okay. After I was. Okay, sorry. I missed something. He did the post dilate with a 3.0 non-compliant balloon up to 26 or 28 atmosphere. And after that, check IOS again and put the stent. Unfortunately, we don't have a shorter stent. What we have is 12. So we get the because we are today we're also out of 3.5 short teeth stent, so we get the 3.0 12 stent. And okay, 3.0 12 stent here. Cover everything. Precisely located the ostium of the right coronary artery with a different projection. Make sure projection is good. No, 别踩. Yeah. And after stent, angiogram look like this. Let go the high pressure and the IVUS. 把最后一个 IVUS 放出来。Let's check the IVUS. Okay. 这最后一个吗 ？Okay. Can you see the IVUS?
Yes.
Okay. We pull back just the proximal segment. 能不能把它放大 Let me enlarge it. No problem. Look like this. The proximal segment.
crossability. Its ultra-thin 60 microns wall design improves crossability and deliverability, enabling easy navigation through narrow or tortuous vessels. The low push force reduces resistance, making it easier to cross calcified lesions, while the stent provides excellent radial strength for reliable arterial support and optimal vessel.
For lithotripsy-enhanced balloon dilatation of lesions, including calcified lesions, in the peripheral vascular system, including the iliac, femoral, iliofemoral, popliteal, infrapopliteal, and renal arteries, as well as in the aortic valve. The S6 IVL catheter is a lithotripsy device delivered through the peripheral arterial system of the lower extremities to treat difficult calcified stenoses. When energized, the device generates acoustic pressure pulses to disrupt calcified lesions, enabling subsequent low-pressure balloon dilation of peripheral artery stenosis. With its compact emitter design, S6 IVL offers a consistent high sonic pressure wave output. S6 IVL is 0.018-inch guide wire compatible for optimal treatment and support in large vessels. The length of the balloon is available in 7, 8, 9, 10, and 12 mm diameter sizes.
Introducing the state-of-the-art forward IVL platform, purpose-built to transform the treatment of difficult-to-cross lesions. The Jenkin peripheral IVL catheter is designed to modify and cross-calcified occlusive disease. It features a single distal emitter positioned inside a non-expandable IVL window located 3 mm from the tip of the catheter. The IVL window contains sealing, which enables energy transfer from the emitter to the calcium. The reinforced braided stainless steel shaft is 5 French compatible, features a 1.5 mm crossing profile on a 0.014-inch platform, and has a working length of 130 centimeters to allow treatment of challenging lesions above and below the knee. The emitter delivers up to 160 sonic pressure wave pulses that emanate spherically beyond the catheter's tip, getting closer to occlusive calcium than ever before, enabling calcium cracking in front of the catheter. Jenkin is IVL redefined to modify and cross-calcified occlusive disease.
An aneurysm is an enlarged blood vessel that can rupture, posing serious risks. Coil embolization blocks blood flow in the aneurysm to reduce this danger. During the procedure, the neuro-microguide wire is first introduced into the vessel, followed by the insertion of the microcatheter. The microcatheter, with its 3-layer design, provides excellent maneuverability and trackability, allowing precise navigation to the aneurysm. As the coil reaches the aneurysm, the physician mechanically detaches it by bending and breaking the push rod. After pulling back 1 to 2 centimeters, the coil is released. Once released, the coil tightly conforms to the aneurysm wall, forming a dense barrier that isolates the aneurysm and prevents blood flow. Popeline detachable coil effectively provides excellent visibility, a reliable release mechanism, and conforms to vessel contours.
Coronary drug-coated balloon catheters are now widely used for ISR, small vessel disease, and bifurcation lesions. Shunpearl carries 4 micrograms per square millimeter sirolimus, which ensures robust drug delivery to the vessel wall, especially in challenging lesions. The butylated hydroxytoluene excipient enhances stability, release, and performance of the coated sirolimus. The loss rate during delivery is less than 10%. Less than 5% of the drug remains on the balloon surface after releasing. The drug concentration in the vessel wall exceeds 7 nanograms per milligram within 1 day, maintaining therapeutic effectiveness for up to 28 days. Shunpearl coronary drug-coated balloon catheter has an excellent size matrix, 1.5 to 4.0 millimeter in diameter, 10 to 40 millimeter in length. Uniform drug coating. The Shunpearl coronary drug-coated balloon catheter effectively improves vessel patency and reduces the risk of restenosis.
Peripheral artery chronic total occlusion (CTO) is one of the most challenging types of peripheral arterial disease. When treating complex calcified lesions, use the Shun PI-18 peripheral CTO guide wire and Shun throughs or Shun light microcatheter, with excellent crossing ability and torque control. Afterward, switch to the Shun Super V peripheral guide wire to navigate through the lesion successfully. Proceed with the Shun Sofer PDA balloon for predilation, ensuring proper vessel expansion. Then, use the Shun Ocean peripheral drug-coated balloon dilation catheter with excellent size matrix, 2 to 7 mm in diameter, 20 to 300 mm in length, to expand the vessel while simultaneously delivering the drug. German technology. Uniform drug coating. The Shunmei peripheral artery solution effectively improves vessel patency and reduces the risk of restenosis. Coronary chronic total occlusions, CTO, are frequently identified during coronary angiography and remain the most challenging subset of coronary artery lesions to treat. The Shunmei CTO kit offers a comprehensive solution for CTO cases, including CTO guide wires, microcatheters, workhorse guide wires, and CTO balloons. For example, in a complex calcified lesion with an antegrade approach, use the CTO guide wire GN series with a tapered tip to penetrate the calcified lesion proximal cap. Employ our microcatheter driver to enhance support, torque control, and penetration power during the procedure. If the CTO involves softer fibrous tissues, the Shun F CTO guide wires, featuring a tapered tip with a polymer jacket, are designed to tackle fibrous caps effectively. After penetration, switch to CTO wires Pi series with a polymer jacket for smooth lesion crossing if needed. Advance the microcatheter to maintain the acquired position, then switch to the PTCA workhorse guide wire Shun R or Shun S to provide a safe guide rail for subsequent devices. Use a CTO balloon, 1 mm or 1.25 mm according to the lesion itself, to prepare the vessel for stenting.
Shunmei's balloon expandable transcatheter aortic valve system offers 10 sizes from 20 mm to 34 mm, fitting a wide range of patients. With its low-profile 14 French delivery system, it minimizes vascular complications and improves patient outcomes. With durable bovine pericardium leaflets, it provides superior hydrodynamics and anti-calcification. The X stitching ensures strong connections, reducing prolapse risk, while the cobalt chromium stent offers radial strength and fatigue resistance. The high-skirt design with PET film ensures optimal sealing and reduces paravalvular leakage. The low-profile expandable sheath expands patient access into smaller and increasingly complex vasculature. Its design enables to streamline the TAVI procedure. With a precision knob for accurate placement and steerable curvature for smooth delivery, implantation is simplified. Shunmei transcatheter aortic valve system delivers precision, durability, and reliability for improved patient quality of life. Shunmei's transcatheter aortic valve system includes 7 accessories: TAVI guide wire, TAVI valve, TAVI delivery system, heart valve crimping tool, balloon dilation catheter, loading tool, and expandable sheath.
An interventional radiologist makes a small incision in the groin, and using real-time imaging, inserts a peripheral guide wire and a guiding catheter. After reaching the celiac trunk, the guide wire is exchanged for a TACE kit. The TACE guide wire and Shun ropeway microcatheter are then navigated into the hepatic artery, which supplies blood to the tumor. Once in place, chemotherapeutic agents are injected into the tumor's blood supply. Afterward, embolization with microspheres blocks the tumor's blood vessels, inducing necrosis.
Hello everyone, I'm Mai Mei. Welcome to PCI Future, the premier think tank for complex PCI and structural heart interventions. Founded and guided by leading global experts like Dr. Jiangping Yang from China, Dr. Alexander Afrin from France, and Dr. Mamur Göktekin from Turkey. Dr. Ahmed El-Gwindi from Egypt. Here, you can connect with leading global experts in real time, participate in in-depth seminars, and access our vast library of HD procedural cases to master the latest techniques. Become part of our global community and help advance the field of interventional medicine. Register now and embark on your journey to excellence.
Shunmei Medical was founded in 2009 and is one of the leading companies in the global vascular intervention field. The company has 5 major production bases in Shenzhen, Huizhou, Hunan, Turkey, and Germany, with business covering more than 120 countries and regions. Relying on a sound quality system and innovative product solutions, it provides comprehensive support for clinical procedures. Shunmei has built 5 core business segments: coronary intervention, structural heart, peripheral intervention, neurointervention, and anesthesia consumables, and has formed a product matrix IVL family, covering multi-site lesion. In the field of coronary intervention, Shockfast CIVL and Jenkins CIVL deal with conventional calcium and complex CTO lesions respectively. Combined with SafeCut cutting balloon, Vita stent, and Shun Pearl drug-coated balloon, Shunmei forms a closed-loop treatment and reduce the risk of restenosis. In the field of structural heart, Shunmei provides a full-course pre-treatment plus replacement solution. Shock Pro Aortic Valve, IVL, is used for calcification pre-treatment, followed by the implantation of independently designed Sun Valve transcatheter aortic valve, providing a new minimally invasive treatment option for elderly and high-risk patients. In the field of peripheral intervention, 3 types of IVL products: namely Shockfast PIVL, Jenkin PIVL, and S6 IVL, address ordinary calcification, CTO calcification, and peripheral large vessel calcification, respectively. Combined with SafeCut peripheral cutting balloon and ShunOcean drug-coated balloon, they ensure lower extremity revascularization. In the field of neurointervention, products include micro-guide wires, microcatheters, balloons, aspiration catheters, and detachable coils, supporting delicate surgeries such as aneurysm embolism, apoplexy, thrombectomy, and stenosis dilation, helping to restore cerebral blood flow and safeguard patients' nerve health. Shunmei Medical has always been driven by innovation and is committed to providing safer and more effective diagnosis and treatment solutions for doctors and patients worldwide through cost-effective interventional products.
The intravascular lithotripsy IVL Shockfist system by Shunmei Medical is primarily used to treat severe calcified lesions. The system comprises three main components: generator, connector cable, and a balloon catheter. After confirming the lesion location via angiography, the balloon is expanded and guided through the lesion area along a guide wire. Next, an injection of a 1:1 saline and contrast agent solution inflates the balloon to 224 atmospheres. The main console then releases an electrical current that travels along the catheter to the balloon's electrodes. These electrodes begin to emit acoustic pressure waves, which selectively fracture the calcified plaques while leaving soft tissue unaffected. During treatment, after the calcified plaques are fragmented, the balloon is further inflated to 6 atmospheres to dilate the lesion area, restoring a larger vessel lumen. A stent may be placed as needed afterward to ensure optimal treatment outcomes. Shunmei's Shockfist system is effective in treating various types of vascular calcification, including concentric, eccentric, and nodular calcifications. Why Shockfist? Reliable safety, safe for soft tissue. Enhance efficiency, targets both shallow and deep calcifications. Simplify procedures, makes complex cases more predictable.
The double lumen microcatheter, designed for complex interventions, tackles challenges with precision. The double lumen design is the heart of its precision. It has 2 lumens. The RX lumen ensures smooth delivery of the catheter along a pre-placed guide wire to the target vessel, while the OTW lumen eliminates the need for guide wire exchange, allowing simultaneous insertion of an additional guide wire. This simplifies the procedure and provides extra support for complex interventions, facilitating access to side branch circulation. Featuring a meticulously designed 6.5 mm tip-to OTW port, the double lumen microcatheter delivers exceptional guide wire support, ensuring smooth navigation through even the most complex vascular pathways. Enhanced by a radiopaque marker, it significantly boosts visibility under fluoroscopy, enabling precise intraoperative tracking. The distal shaft adopts an elliptical outer diameter design, which optimizes the passing diameter. This unique structure not only significantly reduces the passage resistance of the microcatheter narrow or complex blood vessels, but also greatly improves its crossability. Experience superior lubricity with a 380 mm hydrophilic coating, reducing friction and enabling effortless advancement through even the most challenging anatomies.
cardiovascular treatment, the cutting balloon revolutionizes coronary artery stenosis treatment with its unique technology. Shunmei coronary .25mm devices and 4 blades for 3.5 to 4mm devices, ensuring safe micro-incisions. It provides a well-prepared vessel lumen for subsequent stent implantation or further dilation. Offers a safer blade working height, reducing the damage to the vessel wall. A smaller outer diameter for easier passage through narrow vessels. And a 250mm super long hydrophilic coating for smooth navigation through tortuous vessels.
Vita Sirolimus Eluting Coronary Stent is engineered for superior performance and reliability in coronary interventions. Available in diameters from 2mm to 5.
Good afternoon, dear colleagues. Welcome back to the PCI Future conference site. Now, we officially started session 7. First of all, please let me introduce the host and the panelists for this session. The host would be Professor Alexandra Afran, and the panelists would be Professor Dr. Omir Goktin, Professor Dr. Sun Shuo, Professor Dr. Xie Nianjing, Professor Dr. Korhan Solu, Professor Dr. Mohammed Hassan, Dr. Khalid Aled, Professor Dr. Sinikthrai Mithra Kumar, Professor Dr. Lei Xiaoning, Professor Dr. Taner Sikr, and please welcome Dr. Ahmet Karagöz, Chief Physician from Turkey, to deliver a special PPT presentation. Welcome.
Dear Chair, dear panel, dear colleagues, good afternoon. We have been using the Shunmei products in ordinary PCI for a long time, and we are very satisfied with the performance of the Shunmei products. And the best part is, I think, when we notice an insufficiency and we give a feedback, they correct it very quickly, because there are many stuff in the field. This is one of the, I think, good parts of the Shunmei company. When we give a feedback to their staff in the field, they correct it very quickly. Before the lunch, I made a presentation about Taviye. In Taviye, we generally use the Shunmei pigtail guide wires, and they were being stuck on the wire. And we give a feedback about that, and they correct it very quickly. Beside the ordinary PCI, we have just started to use the Shunmei CTO wires in the CTO PCI. Today I will show you 2 cases of CTOs that we have finished with the Shunmei CTO wires. And those cases were no other option cases. So it was very valuable for us. The performance of the CTO wires was very important for us. So our first case is a 56 years old female with a family history of coronary disease. ECG showed trivial change, and echocardiography revealed an ejection fraction of 55 with hypokinesia in the anterior wall with class 2 to 3 angina, and coronary angiography revealed an LAD CTO. Here, as you can see, there's not a very promising retrograde link, and there's an LAD CTO. But fortunately, there was a channel at the beginning of the CTO. So here again, we can see that there's not a very guide wire, CTO wire, and as you see here, it tends to go to the side branch. And then we exchange the wire to a non-polymer jacket, medium tip load, pre-shaped wire, but unfortunately it was in the subintimal space in our every attempt. When we check with the retrograde injections, we can see that the controllable wire was also in the subintimal space. So now, on the right side, I would like to draw your attention to the behaviors of the Shunmei wire. We took a Shunmei 300 wire and again, the wire is struggling in the subintimal space, and in a short while it will jump into the true lumen, and it's struggling, and now it jumps into the true lumen. So this was the behavior of the Shunmei 300 wire in the scenario. And we checked that we were in the true lumen, but unfortunately we retracted the wire. But the P300 wire did it again. It again struggled in the subintimal space, and I'd like to draw your attention to the bands behind the tip, and again it jumps into the true lumen. So we again checked that we are in the true lumen. And one characteristic of this lesion was we couldn't pass this lesion with the microcatheter. So we had to make some balloon dilatations, some granuloplasty in order to advance our microcatheter. Here we again do some granuloplasty, and after granuloplasty, the lesion seems like that. And as you appreciated, we thought we are now able to advance our microcatheter. And after balloon dilatations, we are advancing our micro, and we are exchanging our P300 wire to a workhorse wire. And after that, we make balloon dilatations and stenting. And at the end, here is the final appearance of the patient. This case was finished with a P300 Shunmei CTO wire at the end. So, Shunmei family has 4 members. We generally use Shunmei 50 in side branch wiring and in other ordinary procedures, but we generally use Shunmei 200 and Shunmei 300 in CTO cases. They have a tip load of 1.5, 2.7, 4.1, and 6 grams respectively, and it is synonymous to Gladius EX wire. We know the properties of this wire, and the Shunmei P300 also works well in the scenario. And the other case, our second case, is a 67 years old male with a normal ECG and an ejection fraction of 50% with mild regurgitation. And he had class 3 angina and ischemia in the inferior and anterior regions. And coronary angiography revealed LAD, both LAD and RCA CTO, and the patient refused to undergo surgery. Here is the small part, and the RCA is also occluded. So in this case also, we don't have much retrograde option. So here is the appearance. The distal flank is from the left system again, and we unfortunately in this case just at the beginning of the CTO, there is a septal branch and there is a diagonal branch, and our first wire always tended to get into the side branch, as you see here on the right. First, we chose a soft tip polymer jacket tapered wire to find a channel in the CTO, and now as you can see, we found that channel and our wire got into the CTO body. And after a little advancement, it started to give bands behind the tip. So at that point, we are now ready to advance our micro and get into the CTO body. But after advancement of the microcutter, the soft tip wire cannot go further. So it's time to change the wire. Now we are in the CTO body with our microcatheter, and we changed our wire to again polymer jacket intermediate tip load wire, and we had improvement with this wire. But here, as you appreciate on the left, our wire is again in the subintimal space. And we retracted it and advanced a low tip load non-polymer jacket wire and tried to cross the lesion with that on the right. But we were again in the subintimal space. And here on the right, the Shunmei story begins. We took a GM4 wire. This fight is a little bit long. I don't have the gear to shorten the video here, but here the GN4 wire struggles with the CTO, the distal cap, but our microcutter is a little bit back. So after a long fight of the wire with the distal cap, we advanced our micro a little bit further. You will see now we are advancing our micro, and after advancement of the micro, the GM4 wire is now passing through the distal cap of the CTO. Yes, it's the passage of the GM4 wire. So after we confirm that we are in the true lumen, we perform predilatations and we perform stenting, and after stenting, here is the final appearance. So GN family includes 3 wires, GN2, GN4 and GN6 with 2, 4 and 6 gram tip loads. It's a non-polymer jacket pre-shaped wire and acts as a Gaia wire, and it works well in some scenarios, in general scenarios. And we generally use the driver microcutter also, the Shunmei microcutter. Shunmei cutter in our ordinary cases, it has a 1.f distal tip diameter, and it works well in our undergrad cases. And thank you for your attention.
Thank you, Professor. Please take your seats and relax. And now we are moving to our demonstration case presentation from Foshan First People's Hospital from Professor Dr. Xu Zhaoyan.
Okay, can you hear me?
Yes, perfect.
Okay, thank you for you. And now I presentation the case of this patient. Now Dr. Wong make a presentation. PPT. Okay. Good afternoon. What's that? Here we have a 57 years old male patient with chief complaint with chest tightness for 3 months. And he has a past medical history of prior myocardial infarction and prior PCI. The laboratory findings include CETI 23, NT-proBNP 42.5, creatine 79, LDL-C 3.45. Next. The echocardiography shows us left ventricle 43 and right ventricle 24, left atrium 35, and left ventricle ejection fraction LVF 75% with mild MR and a normal LV diastolic function. The ECG shows sinus precardial with inferior Q wave in lead 3 and AVF. Here's a prior CAG image. We have the first image of a cranial view, and we can see the LAD artery with the CTO in the proximal part, and the distal part was perfusing with right artery. The last one is a haptic view, and this is right artery, and we have in the last posterior have revasculated the right artery. This is the summary. Okay. Thank you, Dr. Wong, and my company, including our Dr. Wong and Dr. Ho. And now I introduce my strategy. I think that from the first PCI procedural images, we can see the LAD. Can you see the first images?
Yeah.
You
can you
see
play it? Play.
From the PPT. From PPT, we can see from the first one. I go next slide. Okay. No. First image. The last. Okay. The right side. Okay. You can see the LAD of a specimen of LAD can see a little short segment, not total occlusion, not total occlusion, just a little, really little segment. Can you see?
Yes.
Yeah. Okay. And I think that the distance of CTO lesion is about 20 to 50 millimeters. The non-lesion CTO, and a little capsule from the right-hand side image. Okay, now last time we performed the PCI to the right coronary artery, and next slide.下張幻燈片. Okay, you can see the right-hand side. We perform only one stent to the right coronary artery. Okay, now that's the final result. Now we have checked the image again. From okay, the first image. Oh no. That's okay. Okay. Now we can see that about 2 months ago we performed the coronary PCI, and you can see the vessel is open. The vessel is totally open, and we can see the RCA provide the LAD distal from the distal to the middle. The LAD is a very good provide. Provide to the LAD, and we can see the only a little tortuous, and in case of anterograde cannot open, we can use this vessel to the retrograde channel. This is the first images. Okay, the next. Okay, just the spider. Yes. Oh no. Yes. Now, but to my surprise, the very short very short segment had disappeared. It's gone. I can find the entry point. The lesion become the entry point ambiguous. Yes. You can see, and nothing.
We can't see nothing now. Okay.
Yeah, nothing. Okay. The last 上一個 now we can see the binary angle. You can see anything. We cannot see anything at all. The very short Siemens disappeared, but to my surprise, the lesion is short, about lower than 20 minutes. You see, but the calcium become heavier. The calcium become heavier. Okay, this is the first review. Okay, and then I think that the strategy maybe from the entry point ambiguous strategy. Start with the entry point ambiguous strategy. Okay, I reviewed the iris. I checked the iris for 5 entry point. Okay, that's the first run. You can see slowly with Mandi. You can see okay. You can see the about the 9 o'clock is the L60. You can see the about the 9 o'clock is the L6 bunch, and about 5 o'clock. 5 o'clock is the occlusion LAD. The part of the LAD. You can see. Yeah, stop. This is the next one. This is the next one by manuals. The manuals. You can see the 11 o'clock L6 and the 5 o'clock the LAD. And we can see it's the soft plaques, relatively soft, not the heavy calcium. The plaque maybe have some little channel. Okay. Can you see?
Yeah.
And I think
what will be your first wire for this soft proximal cap?
Yeah. Soft. Down Lumen captain assist, and you can see the last. 去几个钟？去那个？等先吓，等先。好快好啦，好快好啦吓。Now, okay. Okay. That's the iris captain. The close mark is the iris captain, and the entry point is that point. Okay. Let's. Now this is the down Lumen capacitor, and we insert another wire to L6, and let's. Now we punch with the Gaia second. Modify the breadth, and you can see we can punch it. We can punch it and out to the part, and slowly modify the breadth. 下一张。Okay, I slowly advance and modify the breadth. Some resist, and then we and modify, and let's. And then I chance to that according to the angel image, we can see the wire diameter may be good, and okay, the angel and continue advance. Continue. For the shock listen, I can see the wire located in the true lumen, and let's and angel to verify it. You can see located in the true lumen, and I continue to advance. Continue to verify it. Okay. Multi projection to test to verify it. Okay. Okay, can you see it totally in the true lumen, and then we change it. It change it to the normal wire, and then we pre-dilate, and then we perform the iris. You can see the iris. Yeah, a small one, and have some capsule. You can see the capsule. I find it. You can see, heavy cancel, and then to the LED, and kind of proximal LED also cancel, and then to the left main. The main had some parts in the left main, so we decide to the stand include the LED and the left main. Just now. And then we pre-dilate with the cutting balloon, and then now and check out again. 最尾one. Check out the calcium have been detonated and modified, and the vessel have been enlarged. So we decided to in plane stance and that's my job. Any comment?
I will ask. So, do you have any comment?
Dr. Xu, I'm Dr. Lei.
Hey, Dr. Lei. Hey.
Yeah.
Hey, good afternoon. Hey.
Yeah, I think this case is a complex case because the tip of the LAD occlusion disappeared for this time. So I'm very appreciate you use IVUS to identify the ostium of the LAD, and then you use the dual lumen catheter and use a Gaia second to punch the pack. My question is, which strategy? You can also use IVUS to guide the wire punch, or just use a dual microcatheter to punch. Which strategy you perform? 就会实时的用一个 IVUS to 去穿刺，还是用个双向微导管？
It's a good question. Online with IVUS guy, maybe we should use the AF catheter. For too much device, so we must use the large catheter, guiding catheter. So we have it's not available in our cath lab. So I use this strategy not frequently. Another question is that with the IVUS guiding, it sounds good, but everything can easily move. It's unstable. So I tried some cases, but it costs many time. So I have not interest to do that.
Dr. Xu. I'm Dr. Xu. Just a quick case, CTO. I have a question. Why do you think Gaia second? Why not Chatty or Pilot? Why?
Yeah.
Thank you.
It's a good question. I think to my experience, Gaia series is my favorable wires. To this reason, I even think about the XTA series, but I think to my experience, the successful rate and the feel of my hand, feel of that is good. So I used to Gaia, especially Gaia second is the first choice.
Okay, can we see the? So after the IVUS, you did some predilatation.
Okay. I have finished predilatation. It is the last IVUS images. You can show. So we plan to stand to the arteries.
Okay, we now move on to the next case presentation from Guangdong Provincial People's Hospital from Professor Dr. Ahmed Al-Gendi and Professor Dr. Yang Junqing.
That's Dr. Ahmad here.
Hello, Ahmed and Dr. Yang, we are with you now.
Yes, we are.
Can you hear us?
Yes, perfect.
Okay, brilliant. So is someone have they presented the case already?
No.
Okay, so is someone going to present the case?
I'm so glad here to with my friend Dr. Ahmed and also our fellow buddy Dr. Song Junting. Jun means handsome, sorry. And Dr. Wang Zhuwei. Wei means gorgeous. Okay. Now we have Dr. Wang to introduce the patient's data, clinical data, please.
18, 20.
Yes, sir. How much?
20.
Okay. You want to update?
No, it's one or we can afford it.
20?
Is it a 20? Is it 20 millimeter? How long is it?
Oh, you mean the length? I don't know, maybe 10.
Oh, that's why.
Just 10.
Do we have a 1020?
1020? I don't think so. We have a 1015. 长一点的1.5就难。
Okay, so we have read the first slide. So can you see the next one? Perfect. So EKG. Perfect.
好，1.5来吧。
Next.
下一张，幻灯下一张。
Okay, so ejection fraction 47. Next.
Okay. What's happening with the ACT, guys?
Oh, don't worry, I'll take care of that.
You take it? Thank you.
We're already at 2,000 heparin. 2,000 heparin is already.
So.
Ready.
Okay.
Okay. Oh, this is off.
Okay, so the right coronary was fixed. And now you have to deal with the left system.
Exactement.
Okay, perfect. So
the LED as well as the circumference are total occlusion, total occlude. But this time, I think we better just take focus on the LED.
Okay, I need to do lumen. So,
双纤维导管.
Are you ready to show you where we are today?
Yes.
Okay, brilliant. So the setup here, setup here is right radial, right femoral. We have a 7 French AL1 for the right coronary artery. Is this a 7.4 EBU? Is it a 7.4 or 3.75?
3.75.
Okay, so it's a 7.375 EBU. And we can show you straight away the setup images. Dr. Yang here initially took a diagnostic angio just to check that everything is where what it was left last time. And you can appreciate that the LAD here fills predominantly from very close to the distal cap, then it fills antegrade. And there's this very tortuous collateral from the PL that joins just about at the distal cap. But there's another branch from the marginal branch that you can appreciate that seems to be connecting towards the end of the loop. Anyway, to look better with the dual injection, which we can skip to straight away. Yeah. So this is what we have. It's a relatively short segment. We think we understand where the proximal cap is, but again, there is a degree of ambiguity because there is some calcification that is evident here. I'm not entirely sure you see it your end. I think we have another projection.
Can we see from spider, Ahmed?
Sorry, Omar?
A spider view? Do you have a spider?
We didn't do spider view, in all honesty. We did an areocranial and an AP cranial. So yeah, and then we did an IVUS, which I have to admit wasn't very helpful for two reasons. One, there's a lot of calcium at the proximal cap. We can show you the IVUS if you want, but there's a lot of calcification there. We can see a sudden jump, step up in the size of the vessel, so it gives us an idea where the proximal cap is, but you can't really use it for live proximal cap puncture, again because of all the calcification. Not sure if you're getting the IVA screen.
Okay,
Let me show you the
to
IVAs
summarize,
here.
we have an ambiguous proximal cap. We have a short CTO segment, but we have a LAD which is fully diseased. So
Exactly.
the landing zone is not very healthy. There is some stenosis at the distal part of the LAD, and you have some collaterals, septal and epicardial from the right to the LAD.
And also, I think we have one occluded diagonal, right? Is it diagonal? Yeah. So
the wire, the first wire is in the diagonal.
Big diagonal as well.
Yes, the big diagonal.
Yeah.
See,
So
the
we
diagonal.
currently have a wire in that diagonal.
But before diagonal, we didn't see anything look like a occluded LED. Some crew over here, maybe not. At the 12 o'clock.
Ahmed, can you show us the jumping area?
Yeah,
in the
here.
IOS?
Yeah.
Let's
Okay,
try
here.
to figure.
Do you see, guys? Do you see the IVAs?
We did.
Okay, here, around here, it jump. See, suddenly it jump over here, but nothing look clear for the LED.
We have a dissection already here. Is it
not really?
Failed case?
Not really. Just
okay. So
it's a small. It may goes to a small branch.
That's small occluded.
Could you explain your strategy?
So yeah, now we can go back to the fluoro. And this is what we decided to do initially. Let me go back. We got a dual lumen microcatheter. We have a wire in the septal. We understand where the proximal cap is from the IVUS and from the calcification. We punctured the proximal cap with a Conquest Pro 12. Was pretty sure there was. Didn't we fluoro store that? Anyway, this is a CP12, and because the distal vessel is diseased, we didn't, and this was a slightly bigger curve just to allow us to engage into the proximal cap. We did not want to carry on a lot with the XTA, with the CP12. So we removed the dual lumen microcatheter, got a fine cross, which was what was the short microcatheter available at the time. We de-escalated to an XTA, and the XTA took us into the direction of that diagonal. And then
there's a Shun STA.
Shun XTA. Sorry. So the Shun FA took us into that diag, which is totally occluded afterwards, but that's another thing to worry about. The fine cross, not surprisingly, we were unable to advance it. The strategy at the point was to dilate into that diag, get the dual lumen again, and then puncture downwards into the LAD. But we were unable to pass with the fine cross. We were unable to pass with, yeah, you can see that's the wiring bit. We tried to redirect. We got another, Dr. Yang here suggested that we got another Shun FA and tried to rewire. So that was a bigger curve. But you can appreciate here that this is not in the true lumen. So we stopped at this stage. This is extra plaque. Then we tried to advance a 1O balloon. That didn't work. We changed to a Corsair. That also did not work. You can see the Corsair here. A lot of struggling and a lot of rotation. We tried a new 1O balloon. The first one was a 1O10. We got a 1O20. That also did not work. And this is where we are right now. And what we're going to do right now is we have the dual lumen back in place.
Do you want to put the wire in first?
So you cannot dilate this part, right? You're
no, not cross with anything.
Sorry?
We cannot cross with anything, Omar, at this stage.
Did you anchor this? We have a nice septal branch to the anchoring. Did you tried it? Let's do anchor, and then you have a better.
No,
we have not. We still have options in terms of crossability. The GN4 will try to redirect. So what you can see right now, I'll give you a cine. The dual lumen is just beyond the side exit port is just beyond at the level of the septal now. We'll try to follow the course of the Shunmei FA and then turn slightly downwards, hoping to catch that LED. I think if we're able to send the wire far enough and get enough purchase, crossability shouldn't be an issue. It's just the combination of a polymer jacket, a relatively lightweight polymer jacketed wire, and a very short working distance that is not helping.
All right, ladies and gentlemen,
so Ahmed, I think if I see the diagonal wire, I think we are in the diagonal. But can you give antegrade injection to make sure?
Antegrade.
Yeah, because that diagonal fills from antegradely. Antegrade.
No, it was filling retrograde, Omar.
Are you sure?
Yeah.
Okay.
We can show you.
No. Upper.
Retrograde injection didn't show it to us.
All right, ladies and gentlemen, because of the tight schedule, we shall move on to the live connection with Professor Farie Benjamin, Chief Physician from France, to share the latest progress on Shunmei Shockfast clinical research with us online, and we will go back to the hospital later.
Hello, good morning. Good morning, good day. Do you hear me?
Perfect.
Hello. Wait a minute, I'm just... Okay, perfect. I'm going to share my screen because it's not a live case. It's a recorded case live in the box. And I hope you will see my screen. Do you see it clearly?
Yes.
Oh, wonderful. So, my pleasure to present a live in the box case about a CTO lesion with use of plaque modification techniques. We have been doing this case with in a French course meeting on CTO with Alex and a couple of friends. This is a 80 years old man, former smoker, high blood pressure, dyslipidemia, is a bit obese. He has a peripheral artery disease. He underwent bypass in the past. He had COPD also, and renal insufficiency with a clearance at 35 milliliters per minute. He complains about a dyspnea, stat 2, no clear angina. But despite this, he had negative T waves in inferolateral part. 65% ejection fraction, and at maybe there is a large ischemia inferior, 30% lateral and inferior. So a complex case, old patient, very calcified lesions, no significant lesion on the left system, as you can appreciate here, very calcified on the LAD, on the circ. You can see the distal filling of the RCA through septal connections and epicaudal connections coming from the diagonals. And you can see here the osteo lesion on the RCA. Very calcified here on the proximal part, on the mid part, and the distal part also. So we had to choose an option, and thanks to this hybrid algorithm, we choose to go retrograde through septals because we have a clear, we don't have a clear proximal cap. We have a kind of ambiguity. The lesion length is long, and we have some interventional collaterals. So this is what we've done. Here we have a bilateral approach with a 7 French guiding in the RCA, and we have 6 French retrograde approach in the distal radial on the left end. So XB4 on the left system and AL1 on the right coronary artery. So we choose to use a Corsair microcatheter, antegrade and retrograde. So we went through septals. I skipped that part for the sake of the time. And we are here in position to do a reverse cart. The lesion was very long. And we are here with a Asahi Gladius MG retro with a knuckle wire from distal crux to mid part of the RCA. And here we have another Corsair, shorter, with a Gladius EX. And we are about to connect and to do the reverse cuts. So sorry, I skip a bit the film. So this is the point where we use many balloons to do the reverse cut, and I'm trying to show you one important step. Which was to use also guide extension, but with a trapping balloon, so-called trap liners. Sorry, I didn't have time to... So you can see the guide wire here, which is a Gladius AX retro. We inflate a 3.5 millimeters balloon in this big RCA, and we try to connect retro guiding catheter to antero guiding catheter. So that's what we've done, and we push the guide wire into the guiding catheter, and we trap with the trapping balloon, with the trap liner, we trap the guide wire in order to advance the microcat. But advancing the microcat was very difficult. You can see here is inflating the balloon of the trap liner, and we are pushing the microcatheter into the antegrade catheter. So here we push hard to cross with the microcat, and it was very tough. Here you can see the Corsair is blocking. Oh, sorry. Corsair is blocking. And so we advance with the microcat retro. And then we did a rendezvous technique, a tip-in technique, sorry, with the 2 microcatheters. I'm going to show you that. So we have 2 microcatheters facing. The film was a bit long. Okay, this is it. So sorry for that. If you have any question during the time. So the microcat, boring. So here you can see the retro wire going, the antegrade wire in the microcat going into the retrograde microcatheter. So 2 Corsairs, and you can see the Gladius AX trying to catheterize, I would say, the retrograde microcatheter. So after a few try, we made a small mistake here that we didn't place the 2 microcatheters in the concavity, in the convexity of the guide catheter. And we try a few and get finally into the microcat here, as you can see here. and the guide wire is flying down the microcat very easily. So we were in position to do our job, and so I just showed very calcified lesion with calcium arc more than 200 degrees, even 360 degrees at some points. So a couple of so the IVUS could cross very with big difficulties. And then we decided to use IVL shock-fast Shunmei balloon with a 3.5 balloon. I'm going to show you that, so you can see that this is a big artery, and we choose to use a 4.5 millimeters balloon from Shunmei, and you can see how this balloon is crossing quite easily into the mid RCA. And then we inflate the balloon here with the catheter at 4 atmosphere, and we made 100 pulse on this lesion. So we have to deflate the balloon properly with a 50 contrast dye inflation syringe, as you can see here. And we inflate the balloon and succeed in open it at many points of the RCA. And you can see at the beginning the waste that we still have, but you will see the efficacy of this device in a few seconds. So some waste here. And we worked hard on the mid part, which was the most calcified part of the RCA. So very easy to cross with this big IVL balloon, despite all the calcium. So we did 12 inflation and on 10 pulse, and you can see on this video that if you push twice on the button, you can have the delivery of all the pulse in the same time without letting your finger on the button, on the knob. So we insist on this part because you saw that there is some waste here. And we inflate all the pulsations. So we succeed to do so, and we open this artery and place 2 drug-eluting stents on the proximal and mid and distal part of the RCA. And we respected the distal crux, which was a bit diseased, but probably with some negative remodeling of the lesion. So this is quite the final shots that we get here with the shock-fast balloon inflation, and we respect that distal crux. I don't know if you agree, but we will control this patient in a few months to control that.
Great, perfect result, Benjamin, as always. But I know that you are conducting a trial on the shock-fast, comparison between shock-fast and shockwave. Could you just tell us some words about with this international trial?
Yes, Alex, just some words because it's quite confidential for the moment, but it's the first time.
This is the CEO of Shunmei who asked me, so I think you are out of the confidential point now.
No, I'm just kidding. But it's the first time that a randomized study is done comparing two IVL device. So we designed a randomized trial comparing the ShockFast Shunmei IVL with the Shockwave device, a 2-for-1 randomization. So all the cases are typical IVL lesions. I mean, it's more than 180 degrees calcified arc lesions, or big calcium noduli, which were included in France, Poland, Germany, and Spain. So we intend to include 120 patients, 80 in the ShockFast arm and 40 in the IVL Shockwave arm. To see the results. So the primary endpoint is the final MSA, minimal surface area in the stented area. So it's a non-inferiority trial first, and second endpoint will be to see if there is a difference in the crossing profile in opening the lesion, in handling the catheter. Because one advantage of the ShockFast device is that they have two lengths, one 20 millimeters length and one 15 millimeters length, able to treat maybe longer lesion with a shorter period of time. So we will see all these endpoints in this trial, and we hope to finish over this summer. This year, 2026.
Okay, great, perfect. So I think it will be very interesting to wait this result. Okay, so any comment on the case? It's on the trial.
Regarding the arm of the Shockwave itself, you are using the C2 plus standardized for all the cases.
Yes, exactly. Yeah, to avoid bias. Yeah.
ShockFast will be faster actually because it's 1.5 compared to 1.0 hertz, and a longer length will lead to lesser complications and faster procedural time. You might include this as a secondary endpoint, the procedural time that you used for delivering the shocks and treating the patient the same way.
Yeah, you're right. Maybe we will add this because we count all the pulse and the sequence, but it's good to see how long is the pulse duration. You're right.
Great, Benjamin. So I know in France it's very early, so I think we let you go on with your breakfast. Thank you so much for your intervention, and see you soon.
See you soon. Bye. Have a good day.
Thank you, Professor. And now we're moving back to the Foshan First People Hospital from Professor Dr. Xu Zhaoyan.
Okay, I come back again, and I will introduce the result of my in-play stance. Now is the first stance, the 2.75 by 58, and we use the visual angel to confirm the lender seat, and now landing in the bifurcation seat, and now other implantation, and we mirror the length. We mirror the length of the next stance, and now is the second stand. And according to the iris result, we post dilate with the field balloon, and then the 4.0 balloon. Now I will introduce you the iris result. Okay, that's the after implantation of stents. Now the lesion have a long lesion, have heavy pus, but we
Which size of the stent, Dr. Q?
2.75.
275?
Yeah.
And then post-dilatation?
I think, let me think, at least about 8 atmosphere, and we draw the balloon, and then to the at least 16. And then I can see the stent have been not well expanding. Now, okay, you can see have not well expanded as the leaf main. Now you can see the heavy pass, and then we. Oh, okay. What? Oh, right. And then we post dilate with the other bigger balloon. You can see the stents have been expanding well. Just a little calcium we expanded.
In this part, stent looks a little bit actually undersized.
But we post dilate with the 3.0 balloon, NC balloon, so at least the 20 atmosphere. Course with the calcium. So you can see the calcium and maybe some calcium load. Now this is the left main.
So in here, we have a circular classification to me. What is this? Why it happens?
Pardon? Sorry?
Here. We have here we have a dissection.
Oh no. We have the stand covered.
Frame by frame, we will see it better. Frame by frame.
No. You see? We are covered by stands, so don't worry the dissection. You see? Maybe the stocks not tight, not cover everyone. But I think we use the 3.5 stand and then post dilate with 4.0.
We have a circular hematoma there. I don't know why we have it. Here, for example.
Yeah. Maybe the you can see now it's the second phase wire. Yeah.
Outside the stent. Here. Outside here. Yeah.
Now, some calcium.
Outside, there's a dark space. We don't see it normally.
Okay, perfect. So it's a matter of iris picture, but can we see the final angio?
Oh yeah, a final angio. Yeah.
Thanks.
Wait. Sorry, wait. Now, now is the cranial view. You can see
Yes.
Flows TB3. Even a little competition flow. A little, just a little. You can see the terminal of the LED. So the flow is okay, and then we can see the caudal view. You can see it. The left main is open well, and you can see the spider view. Now it's the spider view.
So what's your plan for the left circumflex?
No stance to second pass.
So just leave it because you are having an osteal lesion and there is a previously mid-segment lesion after the obtuse margin.
I think the patient have I think have the right corneal dominant. So since I performed the second phase, we think we can cause the stem without much difficult. And now,
analyst, what do you think about the left circumflex?
So you said it's crossing will be difficult?
Yeah, but another issue is that the second phase has the long lesion, so I don't think to treat the second phase just leave alone.
Yes, but from here it seems quite tight. You know, you could do just wire and then do kissing, but you can do it later on if you want.
To the crossover lesion, I think that the kissing bloom maybe it's a choice, but according to the iris region, so we can see the second phase is well have not much path, so I don't think the kissing balloon is useful.
Yeah, perfect. So thank you so much for your work. It's a very great result.
Okay, thank you everyone.
Thank you so much.
Okay.
Okay, thank you. And we will do a review about yesterday's demonstration 6 from Guangdong Provincial People's Hospital. Complex lesion from Professor Dr. Kuyanov Pavel Sergeyevich. Welcome.
Yes, good afternoon, everyone. Very happy to be here. First thing I want to say, I'm, to be honest, not a professor. And yesterday we were a little bit behind the schedule, and that is why we were unable to show the case online, but I was asked to make a little recap of what we've done yesterday. As you can see, this is well away from the coronary artery bed, but Shunmei company also does some products for peripheral vascular interventions. That's one of the main vectors for them. So that is how this kind of case got into the schedule. So I work in a multidisciplinary limb salvage team. So infrainguinal CTO is the only type of CTO that I actually deal with. So this was the 57-year-old female who presented with a significantly long history of rest pain and some tissue loss in the first web space on her right foot. A diabetic with hypertension and ischemic stroke occurring 5 years ago. These are some labs and instrumental findings that I was able to obtain from the hospital. As you can see, she had discrete stenotic lesions of the proximal SFA and the CTO at the distal SFA, very typical site for SFA for CTO in the infrainguinal level, and also there was some anatomic variation with plantar arteries arising from the peroneum. So we planned the antegrade access, which, well, with it you can afford the luxury of concentrating an enormous amount of pushing force at the tip of your system. We plan to cross the lesion with a hydrophilic wire, predilate, and then cover the entire treated segment with the DCB. So these are some sine loops from the intervention. As you can see, the wire is inside the SFA, discrete stenotic lesions at the proximal and middle third. The wire first goes into the subintimal space, but then we re-advanced it through the true lumen. Everything was really quite straightforward. So it took us like 45 minutes to do the entire case. Predilation with 4 millimeter balloon and 4.5 millimeter balloon. The arterial path was through the coronal artery. There was a significant stenotic, nearly total occlusion of the trifurcation. We treated it with a 4 millimeter balloon. And, well, actually, we had a working target arterial path, but it's very hard to withstand the temptation to open another tibial artery, and we decided to treat the ATA as well. This was optional. We did not have to do that, but we decided to do that. And at the moment we tried to treat the TP trunk with DCB, we defined that there was a significant stenosis in it. So this is a 4x200 balloon. You can see the result. Some dissection in the...
Just one for all balloon, sorry, to below the knee for all, the last one for all balloon.
Excuse me?
No.
Yeah. Let's go back to the previous slide. Yeah.
Perennial artery. How size is it anterior and then this one? Is this for all, you said?
This is a drug-coated balloon.
Yeah.
4x200.
Oh, it's 4, huh?
4. And we treated the proximal portion with the 5x200, so a little thicker balloon. We didn't have IVUS catheters for SFA, so we didn't size the DCB according to IVUS data, which was desirable. So now that is the 5 millimeter balloon inflation.
And then how long do you inflate normally in your practice?
We kept the balloon inflated for 3 minutes. Not every manufacturer actually leaves strict recommendations on for how long should we wait until the balloon deflation. But we use the most, I think, most popular timing is 3 minutes. So, and of course, we try to use the DCB at the end of the procedure, not to dislodge the cytostatic drag from the walls. So that is what we got in the end. Some non-flow limiting dissections, direct angiosomic foot revascularization, and there should be the AP aspect. Yeah, here it is. So, maybe not as interesting as the coronary CTO, but a significant problem when it comprises 100% of your daily routine. Thank you. Maybe some questions have arisen from the audience.
No, I think it's perfect. You have the question during your presentation, so I don't know if anyone has a concern. No, it's good to see something different than always coronary. Yeah? So, great job. Thank you so much. We know that with this kind of treatment that then the ulcer will disappear. So it's really impressive because I saw one of my colleagues is doing that, and it's really incredible. So the result is quite very, very good. Thank you so much.
Thank you.
Thank you, Professor. Please take your seat. Appreciate your hard work. Now we're moving to another PPT presentation. Please welcome Chief Physician, Professor Dr. Jing Rui, to present the presentation. Welcome.
Okay, good afternoon, everyone. It's my pleasure to come to our PCI Future. Today, I come with a point about application of the IVL catheter and cutting blue in the severe calcification cases. We all know the calcification is a big enemy for the PCI, and someone think maybe it's the less difficult for just like PCI, just like CTO. But it's very common more than CTO in our cases. Someone said about 3/4 patients have a little of or most of the calcification sooner or later. So let's to think the calcification will cause a lot of difficult for the PCI. Sometimes just like the valve fracture. In the long days, the stand thrombosis and ISR is very common. In the last days, we have some way to treat with the calcification lesion, such as common balloon. Common balloon is not often used in these days because it makes the dog bone effect. It cannot put the way for the stand to go through. And the function balloon is more common, just like an ICE cutting. And the laser is not very common in our country. Sometimes we use in some CTO case or some calcification or graft cases. Rota is very common, but not all of the cases is fit the rota. Now we come a new treatment, just the IVL. IVL is very interesting. We have the ring and for the negative pole and the dot for the positive pole in the blue. So let me see the Unicode technical for IVL. In various field with electronic solution, the shock wave emitter generates unfocused shock wave energy. And electrical energy is transmitted to the pulse emitter, and the electrolyte solution vaporizes instantly, produce bubble that rapidly expand and then collapse. Therefore, we make the shock wave. And the shock wave can get to the tissue, but in the hard tissue, the soft tissue, it just do nothing. It won't harm the normal tissue. It just maybe to the fibroid and the calcified lesion. So it makes the ring of the calcified open. This is some ways for just for the NC blue, the scoring blue, the cutting blue, and other with laser and IVL. So we can know the most advanced for the IVL is first it is very easy to procedure. Most of the people, the doctor, physician can just learn this skill just in 1 or 2 cases, then it's okay. And it fit all the severe, the deep or the shadow calcification, and it can open the calcification just for maybe a ring, a real ring, 360 degrees. So it's easy, but it's more safe than rota and less complications. In the guideline, even in China, we have some suggestion for the IVL. They talk about an IVL suggestion is safer and more effective and simpler than other techniques. So it's not only effective for superficial calcification, but also for the deep calcification. So other suggestion, when the calcification score reach 4 points, it is caused by the OCT. IVL can be the procedure method, mainly including acute coronal symptom, ACS. We can also consider about it. So understand the case. This case is just a young woman, 41 years old, but he have a special with chronic renal failure and regular dialysis. We all know if the patient have the CRF and regular dialysis, maybe the patient very severe calcification lesion. So the patient have no symptom because the maybe the hypertension, maybe the diabetes, but he just was found by the abnormal EKG. And then he go to another hospital, just do the CEG and found a lot of lesions. This is the EKG, just the TV. The CREA is about 200. It's just the next day before his dialysis regular. So the CE is okay. This is the echo. The left ventricular ejection score is 46. So the heart failure have no heart failure. The function of the heart is okay. This is the diagnosis. We come to the imagine. 这个怎么放呀？这个有点击吗 ？OK。我看just the back and again. What's wrong? Oh, 太快。Okay. Both the RVD and the circulation have the severe calcification lesion, diffuse, and diagnosis are more than 90%. Okay, let's see the RCA. So we think the RCA is where the make it more dangerous and the TV because the lesion not very stable. Still calcification. So we do OCT, and first we use a small balloon to go through. Otherwise, the OCT cannot go through. First, 1.5 balloon, and then OCT. We can see the result. It's a ring for the calcification. So the MLA is 1.26. It's very small. And we can see a lot of white thrombosis. Let's see the score for the calcified. No nodule. And superficial calcification. 360 degree. The depth is over 0.5 and the length is over 5. So I get the score of 4. So we need pre-treatment. This is the shadow for which how much is score and how we choose the way. Maybe in some cases, if you the score 3 or 4, maybe we use more just like laser and rota and IVL. Just 1 or 2 score, maybe we just use cutting blue and CSE. So we use 2.75 and 12 shockwave blue. Just 3 circle and it's open. A little dissection, but no hematoma. So the shockwave we use IVL for Shunmei is more smaller. Just preferred is better. And 1.5 pulses per second. about 34% shorter than treat time. It's very easy to go across of the lesion. Double chelate is an easy operation. So we put a stand 2.75, 29. And then post delete 3.0. And then we use OCT to examine the result. No dissection, no hematoma, and the 8 pound is well. This is the final CG. In fact, about 1 month later, we treated the LAD and circumflex, but not in this point. Another case is another way we don't use IVL, but the cutting blue for treatment a male, 57 years old. Yes, master chest pain for 2 months. But he have acute infiltrate myocardial infarction 2 months ago, but no treatment, no PCI. The call come to our hospital is 2 months later. Hypertension, diabetes, smoking. But the EF is okay. 被你们试了吗？ We just talk about the left main is okay. RCE is okay, but very severe lesion in the LAD, the middle. The MLA is 1.03. AS is 80%. So let's see the result of the CT. The same superficial calcification. I see it's very severe, but not a real rain. It's 300 degrees. So in this case, we do not try the IVL. The depth is over 0.52 and the length is over 5. The score is also 4. But the difference to this data is the angle is not really a ring. So we use cutting blue. Still Shunmei cutting blue 2.2510. This safe-cut corner cutting blue is dual laser safe design. The cross profile is 6% smaller than others, and RBP up to 20. And some is we see 3 knife, just like 120 degree, and some is 4 knife, 90%. What's the difference? You know. Use the cutting blue from the distal to the proximal. And put a stand 2.75. The result of CT, no dissection. But we can saw the calcification is correct. Okay. And repeat the stand and do a 3D view. And then we treat the circumflex with a 2.25 28. Then still the OCT. I'm sorry about the PPT. It does not work. Thank you very much.
Thank you, Professor Jing. Please take your seat. Appreciate it. And now we'll go back to our provincial hospital.
Hello, Ahmed.
Not really.
We are back with you.
Alex.
So we can see that you made some progress. You changed your strategy. So explain us what came to this idea.
We'll just secure the position of this retrograde wire because we don't want to lose it. Okay. So we left you.
No, the upper button.
So I think we left you. We were trying to reintroduce the dual lumen microcatheter.
Yes.
And we battled with introducing something through the hub, and I think we ruined the dual lumen at some stage. But you can appreciate these are multiple tries with a CP12, obviously outside, but still within the vessel architecture. Failure to advance a Corsair. We tried to get the dual lumen and a GN4, right? That did not work. Then a Gaia third, and the Gaia third was really close, but there's this part is very calcified and very sticky. We were eventually able to advance it in the vessel architecture, but clearly extra plaque. At this stage, we decided to shift to a retrograde strategy. We actually had to cross twice because for some reason I crossed initially, then took the wire back. I think there was a fluoro store somewhere here. Yeah, so that's the sign black. So what we have right now, this is a Shunmei 200, Caravelle retrograde, and Gaia third in the anti-grade thing.
Did you perform a tip injection from your Caravelle to understand where the wire is going? Because
I'm just considering that now because the wire is behaving in a very funny way. Can we go LEO slightly? It should not be the case unless we're completely mistaken about where we are. And we're not. More cranial.
Okay, when do you want to do reverse cut, Ahmed?
Yeah, we want to, but my retrograde wire is going in a funny place, which I don't understand at this stage.
It could be
so yeah, a tip injection is in order.
Yeah, because maybe this is your antegrade wire who mistake you, I think.
Sorry, say again, Alex?
Maybe this is an antegrade wire which is not in the good place, in the good position, and the retrograde maybe the retro is right and the antegrade is wrong. So that's why maybe you need to.
But it's very unlucky, Alex, because we have this is a retrograde injection.
But it's antegrade wire also follows classification, right?
Yeah, the antegrade wire looks pretty nice.
Yeah.
And we know that the second wire in the diag is definitely correct.
That there is some superposition with the proximal LAD. So I'm not sure that your anti-grade was so in the right place.
Let us go more audio.
Dancing is good, which both catheter wires.
Yeah.
Yes, and then you can understand
So
that
Alex
your
is
anti-grade
correct.
was wrong.
The antigrade is inside the vessel architecture, but it's a very big vessel, so it's going in out, obviously. So this is a very funny bend. And yeah, can we have a saline, please? I just want to flush it.
And then you can see that your first wire is really in the diagonal branch.
It's really good, yeah.
Looks like, yeah.
Just this is a free shot anyway.
Ahmed, you don't want to go back for the antigrade with the help of guide extension. Open the balloon there.
I just want to get my retrograde wire in a decent position for reverse cut, and then we'll do that.
Perfect.
Still this one?
Yeah.
I think you can do reverse cut using that diagonal wire now.
I think, Omar, that nothing is passing by over that diag as well. We tried that with the 1.0 balloon.
Yeah, so just Ahmed, we have an option because my colleague Khaled is telling me, but why you are not using the Jenkins just to create the way to this diagonal branch? Because why micro was not able to cross, small balloon was not able to cross. Maybe this is the right indication for the IVL microcatheter. So I don't know if it's available or not.
Yes, we have Jenkins ready.
Dr. Yang was just considering that, and I think it's a brilliant idea.
I think it's exceptional. It will be the first time I can see it in real. So I think everyone here is in the same. So
yeah, do you have it in the CAT lab?
Yes.
Do we? We have it.
Okay. I think it's great to see it. Now you are grabbing something, right?
Yeah, but it keeps going in a very funny position.
Yes, but I think somehow you have to do something antegrately here. It make your
okay. Let's have the Jenkins.
No,
guys, it's.
So,
but please do
save everything for the if you.
Yes.
If
but
we
will.
But
we will.
Let's do septal anchoring here because Jenkins also not easy to push.
But if you succeed, Ahmed, you will present this case on MLCTO.
Yeah, it's about getting the vessel open first, and then I can promise you we'll agree on something for MLCTO. Okay, guys, we will store everything for you.
We stay here.
You're still with us.
Nobody will take any word. So now I'm directing the guys who said, now we have a presentation. I will kill him, so you can go now. You have time, no problem. I will steal his mic. No, give me your mic. Thank you. So now he can't speak anymore.
So I think
stole his mic.
More audio.
So now we are 100% with you. Okay.
Okay, brilliant. Give us more audio.
No more talk. We just look at the Jenkins microcatheter.
Ahmed, I think now it's enough now for this wire. You know, it goes the
Let's
same.
bring us with the audio.
Yeah,
we don't have many wire choices.
Gaia like wire, GN or Gaia, I think, because this is hydrophilic wire and it's behave like this for
okay.
5 minutes.
Give us. Can we have another Gaia third, please?
Gaia 3。随便进个人来，随便进个人。拿个Gaia 3给我。
Do we still have one field at XTA that is open?
XTA? 我们有 XTA 在台上吗
I think that the main problem is the distal cap has this bifurcation as well.
Main problem is the angulation.
The angulation, and there's a bifurcation both with the septal and diag.
The best thing is the P20, para 20 have already.
I'm counting
out
that we
some-
dilated that slightly. The other thing is just go subintimal at this stage. Only problem is we lose this diag. It's lost anyway. We can always start into that diagonal afterwards.
Yes.
So
Guys,
this is the guy third?
Asahi guys.
Can I have a talker for the guy, please?
Talker. 忍下啦嚇，因為硬到死咯，嗰啲鈣化乜嘢？我聽唔清啊，做緊啊。No. Okay, good.
One solution is to actually
good.
go subintimal, so I don't really care about. We don't follow
This
the
is better
lumen.
just overlap with the anti-gray wire. Do you want to check with everything's out, huh? Okay, that's the stiff wire.
Can we see from other view?
I don't think we really need to. I think it's the Gaia is facing a big problem. Just making that bend, you can appreciate. Now I have a lot of resistance.
It's better.
It's good.
Resistance is good. Resistance is good.
Yeah,
Do you follow up the microcaster or? Okay,
Yeah.
let me
So
start
just
it. Let me
need to
start
improve my
it.
support.
1 second, let me start it.
Right.
Okay. Watch out the anti-gray guiding caster.
Just need to bring my micro catheter.
Never mind if the wire can go. Oh, wire out.
So why do you try
Because the
to
guide.
insert your micro? Because your wire is very happy.
There was no support,
cross.
Omar.
What?
There was no support, Omar.
Okay.
Because of the calcium, everything's very.
Yeah, but we've created a track.
Yes.
So you can see how the micro catheter is buckling.
Okay. Can we go
You're
further?
almost there. I think you crossed.
Yes,
yeah.
I think we crossed.
Okay.
Yeah.
Let me.
Okay, can you take us to a less steep REO, to the 3010?
So I'm very disappointing because you cross without the Jenkins.
But still, we may need
we
it,
might
right?
still have
We
to
don't
use
know.
it. Exactly. And now we have a lot of radio opaque junk. I don't know what is what.
Let's pull out the
The
anti-gray
MP,
guys.
exactly. No, the MP, at least. Just, guys, can you help, please?
But maybe the retrograde microcatheter will not cross.
It probably won't. It's a
It was
caliber.
there. We can see the tip of the
So you need
of
to do
the wire. So can you go further?
Yes, but this is giving us a lot of.
Yes.
Besides the radio opacity, it's taking a lot of space.
Okay.
Okay.
Would you engage the guiding caster?
I don't want an LEO. Can we have AP cranial, please? Okay, brilliant. Now this is actually not good because this work is probably crossing through to true, which is not going to help us with the calcification.
But we can chop it.
And I have to say those wires are really radio opaque.
Pull back the anti-gray guys.
Yeah, the anti-grid guy third is control.
Must this one.
Page.
Yeah. And if you want, we can integrate the insert guide extension.
We have a
Docker.
And as you would imagine, everything is a bit too sticky.
No. Which one's? Sure, which one is the right? This is left, right?
This is left, yes.
Okay.
So this is
okay.
this one. Put it back slightly.
What's wrong? Okay.
Yeah, okay. But I actually hit it.
Let me twist a little bit. No. Another way.
I'm getting no.
No, it's not. Do you want the extension?
I want to
keep in?
Perhaps go in very deep.
Yes. Is it better? No.
Yeah.
No.
Give us AP coder, please.
And you can also do some clockwise or counterclockwise rotation.
Yeah.
Now it's overlapping.
Very sticky.
No.
You can see that this is too deep. Slightly less.
Yeah. No.
Little pullback.
Let's try.
You don't want to spend one
Guys, let's get a guide extension. Yeah. I'm just trying to save on that, but this can take forever.
Give me a slender.
I can see Alex now is really not interested about anything.
Exactly.
He's just waiting for the Jenkins.
Exactly. So I'm so disappointing that now we will go for the next presentation.
As do you have the slender?
So you ask for the extension, then you can cross now. Try.
That's usually what happens, but no, didn't work this time. So do you have the guide extension?
Yeah, it is. For about the double root orchestra.
Yeah, but can we just clear the clutter?
Yes. Hold on.
Guys, what you can go if you have a presentation, you can go, and then when I need to clear out this clutter, and then if we have something interesting or we're using the Jenkins, we'll let you know.
All right, thank you, everyone. Now we are moving to the next presentation. Please welcome Professor Dr. Glassi Alfredo Reguero, Chief Physician from Italy, to deliver a PPT presentation titled The European Consensus on the Treatment of Patients with Chronic Total, focusing on the core consensus and clinical norms of Europe in CTO diagnosis and treatment. Welcome.
Hello, can you hear me?
Yes, Freddy. Happy
Hello,
to see you.
How are you, Alexander? I can see you, Omar and all my friends, and it's very nice also to participate to these live cases from Ahmed El Guindi, which was very nice. So, can you see my screen?
Yes.
Okay. So basically, first of all, let me thank this Shunmei for this kind of invitation to be there, although I'm not in presence, and this is because, as we know, we have many meetings nowadays everywhere, but I'm sure that I will be joining for the next time with great pleasure. And for those who don't know me very well, I am being the former president, founder of the EuroCTO Club, and also former president of the EuroCTO Club. And it's for me a great pleasure to present this talk nowadays in this arena of China, which is also very welcoming in the new era of CTO revascularization. So as you all know, basically the progress of evolution of CTO PCI has been dramatically increasing during the last 20 years. And this is thanks, of course, to effort from Japan to concentrate on this topic, which has been then after 20 years. Now it's really, I would say, allow not only to revascularize the CTO itself, but to revascularize the lesion in the context of a multivessel PCI patient. And this, for me and for the new welcoming key opinion leader, is the new era of complete revascularization by PCI, which is something that nowadays we are obtaining in all our patients who do have also CTO and other vessel disease. So, making the story very short, now we are we started many years ago only with an antegrade approach, and now we are going to what we call an hybrid approach. So as you can see, also antegrade has been increasingly complex during the last period, with a lot of technique, which are not only the antegrade wire escalation, but also ADR, and the retrograde, which is going to be now standardized by the new device that can basically facilitate the retrograde crossing. And also the experience during the last 20 years made us possible to basically use a sort of algorithm which has been coming from a global publication that has been basically summarizing the whole algorithms from all over Europe, China, Japan, United States, and basically coming to the final conclusion that according to special issues, we can have a simple antegrade wiring or complex antegrade wiring, a simple retrograde approach or complex retrograde approach, which basically is going to going into a sort of dual sort of hybrid approach, and then finally with an antegrade dissection reentry approach, which might be probably the last resort option for recanalization, but always considering as issues that nowadays are very important: the time of the procedure, the 3 by time estimated glomerular filtration rate ml contrast, and the air kerma no more than 5 gray, unless the procedure is well advanced. And going to the issue of the materials, we basically obtain all these issues because we are able to basically have different type of wires, where basically these wires were developed mainly from Japan, as we all know, and are in the category of polymer and non-polymer wires, and this is the antegrade approach. But as you can see, the temporal approach during the last 20 years has dramatically changed, and you can see that the antegrade dissection entry wires are increasing, and probably the old pilot wires are decreasing, and the stabilizing with the new antegrade stiff wires. Also for retrograde, we are basically going into different sort of new idea of the wire, which are not only the non-polymer old Sion wire, but basically also to the new polymer wires, which are also basically mainly using the for recanalization for the septal regularization or epicardial regularization, the SUO, and for the crossing the CTO, the Gaia. But also in the temporal trends, as you can see on the retrograde approach, is more stable than in antegrade approach. Also, microcatheters have been growing like hell in the last 10, 15 years, especially in the last, I would say, 15 years. And now we are basically having so many companies who are developing microcatheters from all different characteristics. And we knew that these catheters, microcatheters, were basically very important for us at the beginning to use them in the proper way, to appropriate use of the wires, and also to assist in antegrade or retrograde approach the penetration of the wire. And as you can see, as I said to you before, many companies develop different types of microcatheters with more or smaller profile, also capability of torquing, capability to be angulated. And recently, it is interesting that also from China, many companies like Shunmei has also developed microcatheters, and also, of course, which are basically compared to the standard microcatheter used in the past, like the fine cross, and they are using and they are basically performing properly both for antegrade and retrograde approach. And also, wires are, of course, very important for in the complexity of the lesion more not only complex, but with advanced MACE and mortality, and probably also is the cause of more pericardial synthesis. And so, for this reason, we have been showing that basically in these CTO settings, we have to have also some other assistance of this device, which are basically, we called basically either advanced calcific plaque modification device, in which basically we are getting inside all the rotational atherectomy or with orbital atherectomy and laser, and also intravascular lithotripsy and cutting the scoring high pressure balloon, which are basically used, as you can see in this recent editorial from Gambis Mashayeki, our president of the EuroCTO Club, into a sort of algorithm that can be used very nicely for having the possibility to use and to optimize the recanalization after the wire has been passing. And in these regards, as you can see, we have been during the last, especially during the last 10 years, we've been using a lot of new devices, as I said to you before, like lithotripsy, intravascular lithotripsy, and also the orbital atherectomy, which is basically probably the new devices that can be used as part of the older balloon and the older rotablator. And in this topic of intravascular lithotripsy, I think that this is the best thing, as the best result. Also, Shunmei has developed a new generation of shock fast, which I also been using several times, and is very efficient, very professional working, and also a part of the possibility of disruption of the plaque, which we all know how does it work. It also has the possibility of having a very, very good profile of the balloon, which of course makes the advantages of the device itself. And you can see here that you can also use up to 120 cycle, and also with the nominal pressure as usually very low nominal pressure with a minimum pause of 8 seconds. And the results are really fantastic, as the other companies which have been using these devices. But basically, all these techniques of the wires, microcatheters, and especially and devices for debulking are basically coming to a sort of possibility to be used and to obtain this 90% success. But let's go back now to the modality of the CTO and to this paper that we published a few years ago, where basically CTO are not only coming in the case of unstable angina, but also in the case of dyspnea, heart failure, and also they are found not only in stable patients, but also in ACS and multivessel disease patients. And as you can see, coronary angiogram studies, and this is something that is more and more frequent. As we know, we are using CT scan more and more frequent as before. But what is interesting is that we showed in the ERTO registry recently, Vadala is one of my colleagues in my department, that basically, as I said you already, the presence of angina, but not only angina, dyspnea, both are an important issue. And also the technical success, as I said at the beginning of my presentation, is reaching almost 90% with a 73% approach by antegrade technique and around 30% by retrograde approach. And as you can see, still the higher risk factor of MACE are a part of the technique, which is the retrograde approach, which has still some issues for the complexity of the lesion and the technique, but also there we have the female sex and the experience of the operator. M is for medium volume operator, and as you can see in medium volume operator, we can have basically still with medium volume operator, we have a higher percentage of success. So this means not only high expert and low expert, but even medium volume operator should work in the high number to get basically separation and appropriate in the security and reducing the complication of the procedure, and also to obtain the percentage of success which are aiming, which is 90%. Also, interestingly, in this paper, we show that radial approach is decreasing also in CTO nowadays, the risk of MACE, and this is something that we are using more and more often than in the past. But of course, let's go now to the indication of this CTO revascularization. First of all, as we say, it is angina, dyspnea, but also exercise tolerance, self-image, leisure self-image, also the reducing the drug burden, and also other activity like the sexual activity are some of the quality of life that we are taking into consideration for revascularization of this patient. And in this study, that which was one of the our experience of the EuroCTO randomized studies for CTO, we clarify and we are underscoring the issue, the importance of basically the possibility to reduce significantly quality, the angina and short of breath, and so improving quality of life, as you can see here in this group of patients. But as we know, quality of life is something, health outcomes is something, but health outcomes are also an important issue, and we see that basically death, myocardial infarction, stroke, and repeated revascularization are those of the hard outcomes that we are taking into consideration when we are looking to revascularization of this patient. And despite the fact that we all know that is a successful CTO PCI is better than a failed, when we go down to successful and we compare medical to PCI, we basically understand in observational study that CTO revascularization is favorably affecting the overall cardiovascular death. However, when we go to randomized studies, this is not fully true. This is because probably most of the time the randomized studies are not really considering what we are considering in real-world registry. And as you can see The randomized studies are selecting patients with fewer comorbidities, they have extensive crossover, they have less complexity of features, while when we go to the real-world registry, made mainly by people who are devoted to this kind of revascularization, you can see that the percentage of success is much higher, and also the procedure are more devoted to this operator. So probably the issue, because of the randomized studies are still not representative of the real world in these settings, should be interpreted with this limitation. But also when we look at the follow-up of some studies which have been followed, but been done, the previous study had been done by our CTO, and we see that at 3 years, probably still the difference between cardiac death for the medical therapy as compared to the PCI is not evident. We have to remember that these patients are coming back, those who are kept in medical therapy, more often to hospitalization as compared to those who are revascularized. And this so is basically affecting in one way or the other also the hard endpoint of these patients. So in other words, despite the fact that probably the follow-up of these patients were too short to clarify the difference in cardiac death between medical therapy and PCI, we are still thinking that this study was positive in terms of reducing hospitalization for those who are undergoing into the revascularization strategy. Of course, another important issue is the indication, and we published this paper many years ago. It was 2016, and we basically, at that time, we were thinking only of the symptoms of angina. We were thinking also on the presence of viability, and basically we were not talking about ischemia a lot. And now, after this new consensus document, we are including, first of all, quality of life, and also the short of breath, which are symptoms very important to be evaluated for our patients. And also we included in the indication to revascularization also the presence not only of viability, which is important for us, but also ischemia. And the concept of ischemia and viability nowadays should go together to increase the probability that what we're doing is really worthwhile. Indeed, as this consensus being a consensus between medical doctors, echocardiographer, interventional cardiology, and also surgical doctors, we all try to making this clarification that revascularization can be advised in those vessels who are basic with hypokinesia, normal wall motion, and both viability and ischemia. And also in case of absence of these characteristics, and especially in case of normal V function or optimized medical therapy and follow-up may be more advisable, as well as if we have left ventricular dysfunction, more than one vessel complex situation, and not and basically and good ischemic viability, revascularization might be considered, and might be considered in terms of either PCI or revascularization, according to, of course, of what is the possibility of to evaluate a sort of heart team evaluation. The idea of having different modalities for assessing viability and ischemia is something that is related to the place where these studies is being going on, and we have center where echo is very well basically used, and others where CMR or nuclear scan are used, and other now more and more frequently CT scan and functional CT scan may be also used for that. So this is not really an important issue which technique are you using, but as long as you are using the technique to assess both viability and ischemia. And finally, and to come to the end of my presentation, an important issue is not just the isolated CTO, which especially is not ILD CTO, because as we know, that is nowadays going to CTO PCI straightforward if we have the indication. But I think the most important issue is the context of LAD CTO, as we can see, as we saw before from Ahmed El Guindi, where basically we need to look for local CTO PCI expertise. We need to look to the complexities. We need to look, of course, to the indication. And also another important issue, when this CTO comes in the context of a multi-vessel disease or in a patient with previous CABG operation. I think CABG operation. I think that this is something that in which focus for the patient sort of best indication, and many issues should be considered from the surgical approach to the PCI approach. And also nowadays we know that we can also assess this patient with also with the low ejection fraction, with the ventricular assistance device, which are very, very useful for both patients with the percutaneous interventions and also previous CABG. So this is my final slide, and I thank you again and once again, Shunmei, for this kind of invitation. And I will give you all the really greetings from Italy to your fantastic meeting, live meeting, and all the best. Thank you very much.
Thank you, Freddy. So is there any comment? So I think it was very, very clear, so thank you so much, Freddy. We let you for the day. Thanks so much again.
Thank you very much. Have a nice meeting.
Thank you, Professor. Now we are moving on to the next presentation from Professor Dr. Kadi Ali, from Chief Physician from Nasser Hospital, Egypt. Welcome.
Hello, good afternoon. I think this is the final presentation for the session. I would like to thank Shunmei for this elegant future PCI course. My case presentation today will be a little bit interactive, so help me a little bit. Always there is a way. It's a case of CHEP PCI in elderly. I'm Khaled Ali, I'm an associate professor of cardiology from Ain Shams University. It's turning by itself, please help this. So let's go for the case. Scene one. It's getting back by itself. She's an 84-year-old lady. She's hypertensive for the past 25 years, dyslipidemic. Presented as a referral case from another hospital with chest pain of 4 hours duration with the diagnosis of ventroseptal myocardial infarction. She was admitted and referred. She had CALIP class 2 on presentation with fine basal crepitations, a systolic ejection memo of the base with desaturation, oxygen saturation 90, and slight tachypnea, high troponin levels, normal creatinine. And she has some comorbid conditions in the form of mild depression using walkers, and she is frail with frailty index of 0.35. The white one was the ECG and the primary facility where they had some investigations before referral, and this was the one that we received. We have Q waves with cellular ST elevation in the precordial leads. So we went for primary PCI immediately. I always go right radial approach most of my cases, and we can see that we have some difficulties going down to the ascending aorta, but we managed to cross with some tricks and help. We have a dominant right coronary that is not severely diseased with mild disease in its distal portion, but it fills the LAD retrogradely with septal collaterals. As well, we can appreciate the calcification in the proximal part of the LAD and the left main from this view. The angiogram of the left system was not much better than what we have seen. We have a very critical lesion in a very tortuous left circumflex, calcified as well. A calcified distal left main trunk bifurcating LAD into a diagonal branch, then it is totally occluded. Assuming that this is an anteroseptal myocardial infarction with less than half an hour interval between the two ECGs, so I went for a workhorse wire. The trial recanalized the LAD, but actually it was not successful. Then we went for a PI 50. That was not good as well. It went to the subintimal space. Actually, at this position, I stopped. The lady was quite well at that moment. Chest pain resolved, she stabilized, and we only used 40 cc's of contrast. I rechecked from the right side to check for the hematoma space, if I created some with the wire, but I had the same retrograde filling. Luckily, after we finished, we had an echocardiogram in the CCU. We have seen that we have normal ejection fraction, a normal LV functions, LV dimensions, but the ejection fraction was down to 35%. Severely hypokinetic LCX territory, akinetic apical segments with preserved segments, moderately severe grade 3 mitral regurgitation, possibly of ischemic origin, and low flow, low gradient sclerocalcific aortic stenosis with area of 0.9 centimeter square and gradient of 29 millimeter mercury. The same day, she was stabilized overnight. Luckily, didn't need mechanical circulatory support. She developed some chest infection and she had leukocytosis, CRP is high. So how to treat the lady right now? To go for bypass surgery and mitral valve repair, to go for bypass surgery only, medical therapy, PCI to left circumflex, PCI to left main LAD, left circumflex, TAVR and PCI, TAVR only, PCI, TAVR and mitral valve clip. Any help? I need to tell the family something the next day, how I'm going to treat the lady.
Yeah, first I would do PCI and then TAVR and then see mitral regurgitation, if it is decreased or not.
Okay, and the valve, aortic valve, we will consider it's not a significant one with an area of 0.9 and decreased ejection fraction. So I had to sit with my team. Let's do some risk assessments. She's having moderate frailty. She's really old. Anatomical risk score, the syntax is 54. Syntax 2 is too high, but still favoring bypass surgery. But the surgical risk is too high, 13.13% renal failure risk, and STS score of 8.8. This is a little bit high for bypass surgery and mitral valve replacement. And regarding the intervention, the PCI risk chip, if I'm going to go for upfront mechanical circulatory support, it's 13. Which speaks of 2.9% in-hospital mortality. Again, I'm using this one. This is validated 2022, 2023. This a novel risk score to predict the 1-year mortality for patients undergoing CHIP, especially elderly patients. Her score was 2, which speaks of an intermediate risk 1-year mortality 2.4. It's comparable to what we have from the surgical one. The complete revascularization could be an option, but actually it's very difficult to obtain. I usually search for viability if I'm going for CTO segments, even if I'm having these changes. So in dobutamine viability, I got 2 benefits. I have good viability, stroke volume index increased, ejection fraction rose up to 45%, mitral regurgitation improved, And the aortic valve area rose up to 1.3 without much increase in the gradient, so it's still a moderate, a low flow, low gradient pseudo one. So again, for planning, I would go for upfront mechanical circulatory support or a bailout one. Which support? We don't have impella in Egypt. What will be my axis in elderly? Anesthesia type, PCI plan, imaging, toolbox for CTO and calcium verification. So we are going to scene 2. Okay, answering this question, upfront circulatory support or bailout one? Any votes for bailout circulatory support? Okay, we have one. Any goes for upfront circulatory support? Okay, I went for upfront circulatory support. Actually, this is a very risky patient. I'm going to do CTO, most probably rotational atherectomy with ejection fraction too low and severe mitral regurgitation. Which support, as long as I don't have impella, I went for VA ECMO with intra-aortic balloon pump as backup if I need to devent the left ventricle. Nerve block and sedation in my hospital. Actually, I have a good team in anesthesia. IVUS guided IVL if needed, rotatripsy technique, a left main LAD crossover and PTCA to circumflex if we succeeded. This is the fire trial why I'm treating an old lady with an infarction with full revascularization plan. So at that day, I got the right femoral axis as the primary axis, right radial for the donor vessel axis for the right coronary, left femoral. We had some discussions to go percutaneous with proglides for the ECMO or cut down, and left radial arterial line with right subclavian vein for central line. Again, I had to went from the right radial approach the same way to the right coronary as the primary PCI. Can you play this one? Yes. And I got the primary axis and then I got this film. So we all agreed, the ECMO team and me as well, that we have to go for surgical cut down. This is not a good axis for a proglide one. Then we put the cannulae, the right coronary, the donor and the guiding, and let's start. Luckily, I got the microcatheter down. This was a Mamba. And this was a polymer jacketed wire. I thought it could be easier, but actually it went down to the subintimal space. It was not tough. I got the GN4, and actually I could find the track easily to the true lumen. And then everything is not passing. I changed the microcatheter. I did granuloplasty with 3 O1O balloons. 1O balloons are not crossing. A guiding extension was used, but nothing works. So any help? Put in mind I don't have laser. Any suggestions?
What's the problem? You cannot insert your micro?
Microcatheter is not going.
Not going, okay.
With everything. I did granuloplasty, guiding extension, used maximum that I can get down there. And I did 3 granuloplasty.
Okay, try 1O balloon. 1O balloon.
1O balloon and granuloplasty with 1O 3 times and 1.2 1 time.
So now maybe your microcatheter is a long way or is far away from the distal cap or?
No, it's good, in a good position related to the distal cap.
Okay, so maybe if nothing, because your support is perfect here. So if nothing is crossing, the only solution maybe is to remove the wire and go with a rota wire.
This was the only thing that I had in my pocket, so I had to remove the difficult wire, but after granuloplasty, actually, we create some good pass for the rota floppy. We still don't have the drive one from Boston. I still don't have this one, but actually, rota floppy was not bad tracking the old pathway down to the true lumen. I don't like to go even in CTOs for a 1.2 because of the risk, actually. So I used a 1.5 millimeter burr at 150,000 speed. with difficulty. Actually, it's not that easy just pressing a button. We crossed down, and then we started the intervention. Always after rotational atherectomy, I use a long NC balloons. This is a 2.5 by 30, and this is what we got. All through, the lady was awake, asymptomatic, and actually ECMO is not taking too much. It was on autopilot mode, working like less than 1 liter at that moment. And we can see we don't have lots of smoke in the ascending aorta. Then I pre-dilated the diagonal branch and the main branch with a 3.0 by 30 millimeter balloon, and then it's time for intravascular imaging. So from this long IVUS run, actually, we can assume that we have diffuse distal disease. We had good cracks in the mid-LAD. And we have good cracks again in the proximal part. But actually, in the distal left main portion, we did nothing. This clarifies what we had, the post-rotablation atherectomy results. On the right side, you can see the arrows pointing to the cracks and luminal gain, but on the left side, this is at the distal left main with a residual lumen of 2.2. So at this moment, which suggestion for the left main calcium modification tool? Would you go for a cutting? Would you go for an IVL?
You can try after ROTA, you can try NC balloon and to see if you crack calcium.
I could do this, and I have done this actually. With a 3.5 NC balloon, it was having a dog bone. I couldn't do anything. So I stopped and said, okay, I will go for a double bifurcation 2 levels. I will finish the LAD diagonal first. It was well treated. Then I will go for the left main LAD IVL to the distal left main with a 4.0 balloon. And trial of LCX dilatation and reassess, if possible, provisional technique. So I went for a 2.5 by 38 millimeter stent. It was good, expanding well. I got a good result for the side branch. It was preserved, and that's it. The diffusely diseased vessel. So at this moment, you can appreciate that still I don't have lots of smoke, but there is some smoke in the ascending aorta. This is not a good sign on VA ECMO. I tried to get to the left circumflex before doing aggressive dilatation, but actually everything failed. So I had to go for treatment of the main vessel calcification. I have some papers for these ones. You can cross after you pre-treat the distal lesion first. I got the 4.0 shock fast balloon. I delivered 6 times shocking, 60 pulses at the distal left main, and then we got good results afterwards. So in this moment, if you look there, you might see some haziness in the roof of the left main. It will be evident in this position. You can see that there is some roof haziness at the LAD and the distal left main part on the right side. At this moment, I could cross now with a longer balloon, and I delivered a drug-coated balloon 3.30 by 25 millimeters. It was good. We had this dilatation, but we had this nasty dissection, but without any complications. Flow is good. I don't have staining, so it's a type B dissection. So I decided to leave it, retreat it like this. At this moment, the patient had some collapse, and the ECMO was taking over nearly 4 liters, but she was awake and she was fine in the meantime. Then I had to resize length with using intravascular ultrasound. And then this is a 4.0 by 38 millimeter stent with pot with a 5.0 based on the IVUS results. And then post-stent dilatation with a 3.7 down.
So you put left main stent while you have a dissection at the CX, right?
Dissection and the nasty dissection in DX, actually I planned not to treat.
Okay.
No stenting for the circumflex, just the DCB. And then we had this IVUS run. We had good stent edges, but still a little bit underexpanded. So I had to go with more aggressive post-dilatation. And at this point, you can see how much the stent was underexpanded at the diagonal branch. So I had to go for more aggressive post-dilation. And then the final IVUS results was good. You can see that we got an area of 12.4 millimeters in the left main and a very good expanded post-stent, especially in the portion that was not properly inflated in the first time. This was the final result. I know that the LCX looks very ugly, and now we are 10 months post the procedure. The patient's fine, and most probably I'm scheduling her for a control angiogram when I come back to Egypt this week. It's not done yet. We have to get the recovery. Post-procedural hospital stay with another 4 days, 2 days in the CCU and 2 days in the ward. She had 2 grams drop in the hemoglobin and received 2 units of packed RBCs over a couple of days. Creatinine was the same, chest infection resolved, rehabilitation started in hospital, and she was discharged ambulant with the walkers, same as the baseline. The pre-discharge echo improved. Actually, I don't see this much. It takes time, and she was discharged on her 5th day. My key points: CHIP PCI is a growing field rapidly, and risk assessment before any planned complex intervention is mandatory. New risk models and schools can help decision-making. Heart team discussion is a cornerstone for providing proper and crucial proper patient care. And adequate calcium modification is mandatory step in calcified lesions. We have to use all the tools we got to get good luminal gain before stent implantation. And teamwork is the cornerstone to success, and we have to be ready before going to battlefield. Thank you so much.
Great case, and after this case, you were right to do ECMO.
Yes. Yeah. When she collapsed, actually, I didn't regret ECMO.
No, I think it was a very good idea to do ECMO in this patient. ECMO was,
yes,
I think, must.
It was a must, yes. A very high protect score. Yeah.
Thank you so much.
Thank you so much, Professor. Appreciate it. Please take your seat and relax. And we are now moving back to the provincial hospital to Professor Dr. Al-Gandhi and Professor Young.
Give us hello, everyone.
Ahmed, we can see you.
Okay, we are running into problems.
Okay, so, now we can see the angio. Can you tell us where you're sitting right now?
In.
Yeah, it was pulled in. Let me show you what we've done. I think we left you at
before the guide extension.
Yeah, okay. So this is when we were trying to externalize. We eventually got inside the guide extension. That's not the issue. We trapped the balloon, we trapped the retrograde wire. Felt some resistance. You can see this is a retrograde caravel going around. It's entering the CTO body. And then we felt it was getting trapped. So we stopped moving. And then this is a cine. You can see this is a retrograde Gaia third. You can see that it's a Gaia third, right?
Yes.
You can see that the Gaia is starting to break. There is a radiolucent part very close to the tip of the microcatheter.
Is it Gaia or diagonal
Gaia,
line?
Asahi Gaia.
How it's collapsed?
How it's what? No, not the antegrade, Omar. The retrograde and broken. The retrograde. Can you see very close to the tip of the XT? It's starting to break and the coil is unraveling.
I see.
And then, so we didn't want to pull. This is what happens when we pull. We still had some control, so the core did not separate completely. But you can see this is close to the guide entry now, to the tip of the guide. We managed to get the wire antegrade, did a rendezvous, did a tip-in, sorry. So you can see this is an antegrade Corsair. Yeah. So that's the antegrade Corsair. And then we're advancing the antegrade Corsair. And this is what happened. This got stuck as well. And once we felt that it was starting to feel a bit funny, we tried to withdraw the Corsair. And this is what's happening when we draw the Corsair. We're withdrawing the Corsair. You can see that the caravel is going into the anti-grade guide.
Yeah.
And then we decided that, okay, that's not a bad position to be in. We inflated the balloon between both microcatheters. And that is also not working because Dr. Yang and I, we were talking that perhaps this might be a good indication for IVL. And we used the IVL in, again, similar to what we did in the tip-in maneuver. And that was the plan. But unfortunately, we now have this. We have both the antigrade and retrograde microcatheters stuck on the Gaia. You can appreciate that the Gaia there's a long segment here that is unraveled, uncoiled. And I think this is the last shot. Yeah. Yeah. So this is where we are right now.
Did you trap caravel in the catheter when you pull?
Yeah, we tried trapping the caravel.
Yeah.
We tried opening the balloon and fixing the caravel in place, actually partially on the wire, and that also did not work. What I want to do right now, because these are all 2O balloons, and we have a 6 French guide extension. So I'm going to remove the guide extension. Get a...
Hold on, the wire now is in.
And then you will cut the Corsair.
See, we lose the wire this way.
We lose the wire is in. That's perfect.
Yeah, so we should pull it.
We should pull it all the way, but that means that it's not.
So chop it in the.
What we were trying to do at some point, but it didn't work. We tried to pull the wire all the way from the anti-grade route and pull it obviously in the opposite direction. But it wasn't working. But Dr. Yang now just drew my attention that
where's the balloon?
We no longer have it here. The balloon is up there.
You can cut it because
where's the caravel? Where's the caravel?
You can cut microcatheter.
The caravel is all the way around the corner.
So we should chop it beyond the caravel. Leave the caravel along.
Yeah, but if we don't see it any longer here, it means that
we have no choice now. We have no choice now. Yeah.
Yeah, exactly.
We now still chop the caravel. So don't. Okay.
What are you pulling now?
Hold on.
We're trying to pull the
guiding catheter.
Everything is stuck.
Everything is stuck. It's still stuck.
Yeah. So
the wire is still stuck, but somehow we managed to mobilize it from here.
Let's release the caravel. Okay.
Yeah, release it.
Release caravel. Pull a little bit the caravel.
And hold on.
So I really don't understand anything. So could you
Brilliant.
summarize me because
Yes,
which is broken?
Yeah. I think we have to do
Alex,
because
both
I
the
think
antigrade
audience
and
also
retrograde
may not understand.
microcatheters are stuck on the wire.
Wait a minute, Robert. So just
where's the caravel? Is that here?
The caravel is where is the caravel?
Is here or there?
Retrogradely in the
antigrade
guiding.
But now where is it? It is a guiding
the
catheter.
caravel is all the way up.
Yes, it's in the guide.
We cannot chop the caravel anymore. Okay?
Yeah,
we just chop the wire.
I want
the wire
where the Corsair is.
chop the wire in the blender.
Okay. We just want to. Was this a 130 or a 150 centimeter?
135.
So what are you removing now?
Anti-grade Corsair.
Anti-grade Corsair. Okay.
Yeah.
No, but can I see the heart, please? Can I see the heart, please? We're squeezing the heart. Can I see it up there, please? Okay. So we're trying to remove the Corsair, and I don't know if you can see, we have quite a good length now. This was a 150 or a 135?
135.
135? Yeah. Okay. The problem is our retrograde microcatheter is still stuck.
But where?
Yeah. Can I have, this is a good time, by the way, for Stefan's thing. Can I have a regular workhorse wire?
OK， 一个常规的工作导丝。工作导丝，工作导丝。
This is, you know, descending artery.
So Alex, this is what's happening. Yeah. Alex, this is what's happening. The antegrade system is stuck. The retrograde microcatheter is stuck. The wire is unraveled because both are pushing. So the Gaia is in between both, but it still has a coil. You can see that the caravel is already in the descending aorta, just at the beginning of the descending aorta. There you go.
Yes, we can see the caravel. Okay. Yeah. So inside the caravel, there is which wire is the Gaia third?
It's a Gaia third that is partially unraveled.
But the Gaia third from the retro.
Yes, that's the Gaia third because we went with the retro wire into the antegrade guide, did a tip in.
Okay.
And when we did the tip in, we eventually ended with both microcatheters stuck.
Okay.
So can you remove Gaia now?
So if you pull the Gaia, the Gaia is not going out the caravel.
No, we don't have the Gaia from the caravel side any longer.
Okay.
It is mostly all from the... And we don't have it from here either, because this is pulled way.
You can snare it integrate from...
You have the hub of the caravel.
I have the end of the caravel, yes.
The hub of the caravel, there is nothing here, because the wire is not anymore at the end, okay?
Exactly.
Okay,
the wire
so
is not at the
I
end
can
of
give you a tips, because it happens to me already. What you can do is to connect to the hub of the caravel the inflator. Okay?
Trap the caravel itself.
No, to connect
the
inflator to the caravel and to inflate. And then it will make the pressure.
Can we have it in the inflator? I got you.
You will increase the pressure.
And we have it in the inflator.
In my case, it was good to remove like that the caravel from the wire.
Yes, but you can trap that caravel anyway, and then you can remove it. Why do you do Nanto? Yeah, you can also trap Gaia at the descending artery.
The Gaia is not in.
No, Gaia is in the descending artery, right?
In the caravel.
Yeah, in the caravel. So he wants to remove the caravel now, right?
I basically want to remove everything because this is a difficult situation.
Where do you put the what?
Yes,
and
you have something in the ascending aorta coming from the right Judkins.
Guys, where is the... Yes, I just put a wire here to avoid deep intubation.
Protect. Okay,
so this is a floating wire just to avoid deep intubation. Okay, what I want you to do at this stage is can you keep constant tension on this? And I will try to remove this. No, not loose, constant tension.
Now you are removing.
Okay, so this is free somehow.
Okay.
Okay.
Oh, the caravel, I think it's too low, huh? It's too low. The blood pressure, the patient suffers from ischemia.
No, the blood pressure is... But that shouldn't be the case.
Because we hang everything
to heart to some extent.
Release the tension, release the tension, okay? Yeah.
Okay. Potentially because of the squeeze of the heart.
Yeah, but it seems that I released the tension
like a tamponade, direct tamponade.
Yeah, that's true. But this is what I don't fully get right now.
The blood flow is not good yet.
Sorry, what? Where's the guide extension, guys?
不要快一点啊。
Okay, we're reasonable.
暂时不。Well.
So this is
for what? You chop the.
I want to
no.
it.
You need to be careful that there is no bubble in the connector, huh?
Yeah, we're doing that.
So because you will.
No, more.
Okay.
More.
这个照你记住了。
这里哦。
Thank you.
Okay.
Go 20.
It's 20. What are you doing? Are you putting the?
Yes.
Putting the well? No. Why do you put?
That's the whole point. Okay.
No, you have to keep it there and pull out the wire.
We'll have to go back in. You're right. Have to go back in.
Go back the well if you can.
Pull on this. Okay. Just pull on it. It will take the cable back in.
I'm sorry?
It will take the cable back in. Alex, your suggestion, just pull on it.
It's not working?
No, it's not. It's not only it's not working, it's also not safe because then the wire is shear stressing on the heart. The only safety I have right now is having golden plastic. You know what I mean?
So your anti-grade guiding is has big stress.
Yeah.
Yeah, because we're pulling because I just want to get back
here.
Yeah.
The cab. Okay.
It's good. And please control the guiding caster.
So we will let you manage this situation. We have a presentation. Okay. We will come back to you.
Okay. Go deeper.
I can't push. You have to pull. There's nothing. There's nobody.
Okay. Little by little. Never mind. Just watch the blood pressure.
All right, ladies and gentlemen, we will get back to the hospital later. And now we move into the next presentation. Please welcome Professor Dr. Shubin, Alexei Shubin, Chief Physician from Russia, to deliver the BP presentation. Welcome.
Hello everyone. I will change topic a little bit because I guess that no one had the opportunity to present narrow interventions tools by Shunmei company, and I'll try to fix that problem. And my presentation, this talk focused on practical technique and decision making in the acute treatment of ruptured intracranial aneurysms. The central goal is to understand when and how we can, how to understand when we provide superior stabilization practically in patient where stent or antiplatelet therapy are contraindicated. This presentation covers the full spectrum of double microcatheter coils embolization through step-by-step procedural technique, framing, strategy variation, and complication management. The key priority of the treatment of aneurysmal subarachnoid hemorrhage is the early and complete occlusion of the aneurysm to eliminate the risk rebleeding. Each episode of rebleeding increases the risk of death, and so rapid surgical or endovascular intervention is the cornerstone of acute management. The first priority in subarachnoid hemorrhage is to prevent rebleeding, as this can dramatically worsen outcomes. This is why securing the aneurysm rapidly is essential. during the acute phase of subarachnoid hemorrhage, treatment decision must strike a balance between procedural speed and safety. The chosen technique has to be compatible with the patient's delicate physiology. Each modality carries distinct advantages and limitations, particularly in the acute rupture setting, where anticoagulation, device complexity, and procedure time must be all minimized. This method occupies a critical niche. It is most valuable when standard single catheter coiling is mechanically unstable, yet stenting is contraindicated due to antiplatelet requirements of the acute subarachnoid environment. Understanding aneurysm geometry is the foundation of every endovascular decision. Neck morphology, dome orientation, and the most critical anatomical factor is determining coil strategy as it affects coil stability, the safety of the parent vessel, and the risk of coil propulsion. Wide neck aneurysm represent the primary challenge for simple endovascular coiling. Two accepted morphological thresholds define this category. 4 millimeters neck width and dome to neck ratio below 2. Why does this matter? In cases of wide neck aneurysm, the deployed coils are missing neck scaffold. The result is coil prolapse into the parent artery, causing potential thromboembolic complications and incomplete aneurysm occlusion. These morphological parameters directly trigger the need for neck remodeling strategies, including balloon assistance, stents assistance, or double microcatheter technique. This specific anatomical configuration are precisely where the double microcatheter technique demonstrated its greatest utility, providing independent support to each morphological component of the aneurysm. Bifurcation aneurysm arising at vessel branch points such as bifurcations present unique coiling challenges. The aneurysm neck spans to efferent vessels, resulting in a wide and unstable landing zone for the coil. The double microcatheter technique has evolved over more than 2 decades, from an experimental approach for selected wide neck cases to a recognized primary and rescue strategy in ruptured aneurysm embolization. Baxter and colleagues describes using 2 simultaneously positioned microcatheters to achieve coil stabilization in wide neck aneurysms, where standard single catheter technique were failing due to coil prolapse, inadequate framing also. The 1998 publication established the anatomical rationale and initial case series that would motivate broader adoption. Building on Baxter's initial description, multiple groups have made contribution to the catheter positioning strategy, coil selection, deployment, and patient selection criteria. And understanding the mechanical logic of double microcatheter technique is essential before approaching catheter positioning in the framing strategy. The double microcatheter technique is elegantly simple in principle. It's 2 microcatheters simultaneously positioned within the aneurysm sac, enabling a cooperative coil deployment strategy that achieves stability impossible with a single catheter alone. the core mechanical inside. A second coil's mechanical support prevents the first coil from prolapse during neck stabilization, distinguished from all single technique, single catheters technique, yeah. Appropriate coil selection is integral to the double microcatheter technique. Each catheter's coils must be matched to its mechanical role within the framing construct. The mechanical success of the double microcatheter technique depends heavily on procedural catheter shaping. And like you see in this picture, different shapes for each catheter are essential to achieving divergent deployment vectors within the sac. In both catheters shaped identically, they will tend to occupy the same spatial position within the sac, negating the mechanical advantage of the dual catheter procedure. Shape diversity equal vector diversity and equal mechanical advantage. Next it will be a step-by-step case, and I will explain it. Optimal microcatheter positioning is pivotal for successful double microcatheter framing. Both catheters must be placed in distinctly different spatial vectors to maximize the mechanical diversity of the coil loops. Avoid placing both catheter tips in the same region of the sac. Ideal vector dome tip versus lateral wall, or lobe 1 versus lobe 2 in bilobe aneurysm. The first framing coil is deployed from the primary microcatheter by critically is not detached. This partially deployed coil serves as the mechanical anchor for cooperative framing construct. A critical principle: early detachment of the first coil before positioning the second coil eliminates the key mechanical advantage of the double microcatheter technique. While holding the first coil in the undetached position, the second coil is deployed from the second microcatheter. The second coil is positioned to provide mechanical support to the first coil and occupy a complementary region of the sac. The second coil is also left undetached and physically braced the first coil against the aneurysm wall. The two coil loops interlock across different spatial vectors, forming a cooperative mechanical structure that neither coil could achieve independently. The operator can advance, retract, or reposition the coils in response to developing real-time configuration. Step 4, after positioning both initial coils, the operator adjusts each coil progressively until a stable, well-configured frame is established across the entire neck and dome. Before committing to detachment of either coil, a formal stability assessment must be performed. The most mechanically stable coil is detached first, like you see, and locking in the established framing construct, while the second coil continues to provide temporary butter support. It's switched off here. It's closed. Okay, I see it here. After completing the packing, second coil is detached and removing microcatheter. This is the final result with good endpoints and packing density of more than 25%, like it's good to be. Yeah, thank you. Instruments which was used is Shunmei devices. Here, it is a microcatheter, guide wire, and 3 coils. Name of coils, Popoline. And now I would like to show you 2 cases in cases of cerebral aneurysm embolization using Shunmei devices. We performed 100% of our nerve insertion via transradial access, as we did in this case. For internal carotid catheterization, I use 125 centimeter seam 2 catheters, and in wild cases, hydrophilic guide wires, such as Shun ski trails. I have a monoplane angiograph and this cath lab, and we did a lot of views to clearly visualize the neck of the aneurysm. Next, we perform catheterization and internal carotid artery using guide wires and microcatheters. Microcatheter, you see, it is the Shun Captain. Excellent microcatheter that we use in our daily practice. The most often use 1.7 range. Includes arteriovenous malformations, peripheral. And now we're measuring the aneurysm. Here is the site. We carefully advance the guide wires and guide wire, and you see position of microcatheter into the aneurysm so that we can embolize the aneurysm. The 2 microcatheters make markers are clearly visible, and we see the process of coiling. Proximal marker are coil deployment, forward coil deployment. The assistant always helps with coil placement. We try to position the loop coils so as to cover aneurysm neck as much as possible. When then the second coil, either also 3D or filling coils, is typically one size smaller in diameter than the first or the second. We go in like step by step. We continue on the process of filling the aneurysm sac until we are fully confident of occlusion. And you see that the next coil is difficult to advance, especially in its final loop. And this must be done very carefully and cautiously. We see that there is a still now, yes, still contrast enhanced position of the portion of the aneurysm, and we advance the next coil. Most of it is occluded, and we're trying to finish the procedure. Yes. And the next case also involves transradial access on the left side only, since this is a basilar artery and right vertebral artery is hypoplastic. We immediately advance the guide catheter on a hydrophilic guide wire as high as possible. We perform angiography and determine the best projection for performing the embolization. For aneurysm catheterization, we often use the guide wire. It is a soft 14 gauge guide wire with hydrophilic coating. Very nice, very good one. It has an easily shapeable tip with a very good torque control, excellent torqueability, and And now we select a 3T coil of the appropriate size to ensure proper formation of the frame. There are two types of coupling coils, forming and filling, and also diameters 0.10 and 0.14. There are, for most important features, excellent visibility and reliable release mechanism. And as you see, the detachment process is mechanical and very simple. This is a step-by-step procedure of detachment. And the procedure is complete, and we can remove the entire device. Thanks a lot. That's all.
Thank you, Professor Dr. Alexei.
Thank you.
Please take your seats and relax. And we are now moving to the next presentation. How to deal with the anti-grade CTO cases. Let's welcome Professor Dr. Alexandre Evren to the stage to do the presentation. Welcome.
Thank you. So I think it is the last presentation of the meeting. So it's what is it? Okay, it's the live in the box case. I did with my first experience with Shunmei guide wire. So this is a young man with a history of acute coronary syndrome, where we make some PCI on LAD on circ, and he has still angina. So the right coronary, as you will see, is not a very big, it's an equilibrate, balanced coronary artery, so it's not a big one. So it was fully occluded, chronic total occlusion. And as you can see, this is a control of the left system, so there is not so much visualization of the retrograde, only at the end. And I was not very enthusiastic to do the CTO of the right, because as I told you, it's a balanced right, it's not a dominant right coronary. So we did a lot of stress tests, MRI, and everything shown that he has ischemia and viability on the territory of the right coronary. So this is the right coronary. So as you can see, you understand why I was not very enthusiastic to do this CTO, but the patient with maximal angina therapy was still symptomatic. So we use the Shunmei with a microcatheter driver just to go just in front of the proximal cap. So if I can suggest something to the CEO of Shunmei, is maybe to make the radio opaque part of the driver a little bit larger, because it's too small. And in France, we have big guys, and sometimes we can't see the tip of the microcatheter. So then, because it was a tapered proximal cap, we use now the Shun FA and try like a fielder family to grab some microchannel, and you will see that it will find some microchannel. Here, antigrade way was the only way. As you can see, there is no retrograde. The distal landing zone was not so big. So you can see some progression in the CTO's body. So we use the Fielder XT, so the Shun FA. It's tapered, low tip loaded, 0.8. And now you can see that the wire is buckling. So we need maybe something more stiffer. So then we turn for GN2, which quite same that Gaia next one. So it's 2 grams, and you will see that the problem with this wire is that it is going straight. And there is some curvy part on this right coronary. you see the curvy part, and my concern was to say, okay, maybe he will puncture, but then after, did he will go through this curvy part? I'm not sure. And then you can see that now I am in front of the curvy part, but he is going always straight. You see, up. So it's not good. So it means we need to find something different. We need to find a guide wire which will take this curvy part. So we turn with the polymeric guide wire. So it's a Shunmei P50. So I was very interesting on this one because I was supposed to go to take a P200 first, but then I said, okay, I will try the P50 and see if it's able to take the curvy part. So you will see now I'm in front of this curvy part, and then the tip of the wire takes the curve, and now I just drilling. Then approaching my microcatheter and not pushing too much the wire, only with drilling, and you can see that the wire is going on. So it was good. Then we will do just an injection, only antegrade because there is no retro. So it seems to be in the architecture of the vessel, not sure that we are true lumen or not, so we continued the advancement. It was quite easy, no resistance, so it seems to be in the right way. But with the polymeric guide wire, we never know, but then now we have the confirmation. So now we are in the distal part of this small RCA. We have now to advance the microcatheter, so it was a driver. So here, you can see I just increase my support and then make some rotation with the driver. You see, not so easy, but the support was not incredible. But then pulling back a little bit the wire, then rotating a little bit, increasing the support. And then you will, now the microcatheter is advancing, and then you will jump forward this curvy part, up, and then now we are in the healthy part of the RCA. So that was my first experience with the new Shunmei CTO guide wire, so it was a good experience. I could have tried 3 different wires, so the tapered one, the more directive one, and the polymeric one. So it was very interesting. Then we can do some pre-dilatation and just place one stent. It was a 2.7532, I think. Okay, and this is the final result. So distal is not very healthy, but as we mentioned, it's not a very dominant right coronary artery, and the patient now is totally asymptomatic. So it was really this artery who make him suffering of angina. So this is a data procedure. So you see it's not a long, complex procedure. It was less than 1 hour and everything. So thank you, Shunmei, for this new guide wire. Maybe we can have more success rate now. And thank you so much.
Thank you, Professor. Please take your seat. And now we are going back to our provincial hospital to Professor Algandi and Professor Young.
Size of cutting balloon do you want?
Sorry?
Cutting balloon?
I think 2.5. It doesn't look like
okay.
a huge vessel.
Where to cut?
The mid segment, the
back
CTO
to
body.
you.
And
Okay,
just
okay.
Okay, so
Ahmed,
we
can
can
you hear
go
me?
back. Yeah, so
Ahmed,
are
we
in a
don't
much
want
better
to
position.
disturb you. We don't want to disturb you, but if
No,
you
we're
have
okay, we're
time
stable.
to say what you did, I
这个
think
球囊
everyone will learn a lot
5.5
of this,
2.5的这个球囊。
of this case.
So I think you left us at this position, Alex. And I think your suggestion worked slightly. It was very uncomfortable for us because as we withdrew the caravel, we now have, and this is important for the audience to understand, have a part of the wire that is not covered. So any tension is going to cut through the heart because the wire is not covered with a microcatheter. But I think, so we advanced, we pulled again the anti-grade microcatheter that was a Corsair, and we took back the caravel all the way into the guide.
of live cases, maybe too much, because we can't follow everything. So I think next year you will improve a little bit the format of the meeting, but it was great. Thank you so much to all the faculties, moderator, and participant. Next year, I hope you will have some mic also in the room to ask some question, okay? Because it needs to be, you know, I like interaction, like the one who came for MLCTO. It's already more interactive. You need to ask question because this type of meeting is for you to learn, to improve your skill. Then you come back to your cat lab and you gain some tips and tricks that we had during this meeting. And then it's same for me, same for Omer. I learned something today, so I will remember all my life. So Omer, you have also something to say?
Yes, I'm very thankful to Shunmei. Really, it was a great meeting for me. 2 days, we learned a lot, nice live cases, successful cases. And it's interesting to see that one company cover everything. Next year, maybe we can do all, you know, interventional procedure, including TAVI as well. And later on, maybe matcha clip. So that's very interesting. And also, I like to congratulate my colleague from Russia, Alexei. He did great job. You know, I like his job. Yes, Alex, thank you very much. You did a great job, my friend. So yes, this is the first edition, but I find it very successful. Thank you, Jane, to have all of us in here. And next year, I think we will go to Germany. Am I right? So it will be another, I think, opportunity.
So I will call Jane to come and to close the session. Thanks.
Thank you, everyone, to join this PCI Future Congress. And also, first of all, especially thanks to our founder and all the doctors and also our distributors. Yes, thank you so much. And as a final gift, I want a little bit clarify. The CDO tour box, we bought 500 pieces, and the distributors, doctors who wanted this can contact with us, and then we can deliver from our German office to every doctors. So, but it can be ready after 1 month because printing needs time in Europe. Sorry, not like in China. Yes, we will continue the Congress. The next summit will be in Germany, maybe end of the year or early of 2027. And we are also discussing to do PCI Future in Turkey and also in Egypt, the Middle East. Yeah, we're planning, and we have a lot of new products coming. TAVI IVL, TAVI Metro Clips, a lot of new interventive products. And also lastly, actually, if any doctors who have very innovative ideas, we are very much ready to cooperate to make the samples. Any doctors willing to try, we will post in our PCI Future website. Currently, we have TAVI guide wires from Dr. Picho, Poland doctor. And there is a tipping device from Dr. Hohan as well. We will post in the website. Any doctor are interested can contact with us. We will deliver for free. If a lot of doctors interest, if after your evaluation is very useful, then we will proceed for the CE certification, and the patient and doctors can get benefit. And also any other new ideas doctor wants us to do, we are very much appreciate and very much ready to follow and to make the samples. Thank you very much all.
Thank you, Jim, and thank you everyone for these 2 days. And the conclusion of the first PCI Future Global Summit is a brand new start for cross-regional cooperation in global PCI field. In the future, PCI Future will enter more countries and regions around the world, one after another, build a broader international exchange platform, continuously promote innovation and development and of cardiovascular interventional diagnosis and treatment technologies, and let experts from all over the world join hands to contribute more to the cost of human cardiovascular health. Finally, I declare the first PCI Future Global Summit
So you can go